For today's CME, the Menopause Masters, unraveling the journey of a woman through menopause. So without further ado, we'll start with our first session, which is the basics. I invite Dr. Mayuri Kelkar. She is consultant at Narayani Hospital, Nashik. Professionally trained obstetrician and gynecologist, ensuring high standards of competent care for a wide variety of patients with diverse needs. She is currently Secretary of Nashik Obstetrics and Gynaecological Society, life member of Nashik Obstetrical Society, and Joint Secretary of NOGS in 2020 and 21. So I welcome Mayuri ma'am for her first talk.
I start with the basics of the menopause. So India, with a population of 1.4 billion people, it is the largest emerging economy and the most populated country in the world. So according to WHO organization data published in 2018, the life expectancy in India for a female is 70 years and expected to increase to 77 by the year 2050. So currently approximately 10% of the Indian population, that is more than 138 million, is aged over 50 years. So you can see it in the graph. And that is the need of more programs on menopause, because we will be having more population who will be older. So for many women, the impact of menopause is significant, and for some it can be devastating. However, for some women it will pass almost unnoticed, and with others simply requiring reassurance and lifestyle advice without needing medication. The Indian Menopause Society, established in 1995, is committed to fostering general well-being of the mature and elderly Indian women. The IMS family is unique, and they believe in a holistic approach towards managing the midlife, which goes beyond the scope of pharmacotherapy. The estimated mean age of menopause is 46 years in India and is lower than that of the Caucasian. From the available Indian data, it is hypothesized that an early age of menopause predisposes a woman to chronic health disorders a decade earlier than a Caucasian women. So menopause is a transition phase from the reproductive to non-reproductive phase in a woman's life. It is nature's protective phenomenon against the reproductive morbidity and mortality in the aging population. It sets the stage for aging and accelerates the process of non-communicable disorders. So Journal of Midlife Health, which is the official journal of the Indian Menopause Society, elaboratively describes all the terms pertaining to menopause. So there is natural or spontaneous menopause, which is recognized to have occurred after 12 months of amenorrhea, for which there are no obvious pathological or physiological causes. It occurs due to the depletion of ovarian follicles, resulting in near complete but natural diminution of ovarian hormonal secretions. There is no independent biological marker for menopause. Then there is term called as premenopause. It is often used to refer the entire reproductive period up to the final menstrual period. Then there is perimenopause. It is the period immediately before and up to 1 year after final menstrual period. It may last for 3 to 5 years. Perimenopause begins on an average 4 years before the final menstrual period. The characteristics are increased blood levels of FSH due to the endocrinological changes, anovulatory cycles, significantly reduced fertility, erratic menstrual periods or irregular menstrual cycles, onset of symptoms such as hot flashes. This term is used interchangeably with menopause transition. Then there is post-menopause. It is a span of time dating from the final menstrual period, regardless of whether the menopause was spontaneous or iatrogenic. Senescence is the period after the age of 60 years. Then there is premature menopause or premature ovarian insufficiency. Premature ovarian insufficiency, POI, is described as an amenorrhea due to loss of ovarian function before the age of 40 years. It is a state of female hypergonadotropic hypogonadism, and it can manifest as primary amenorrhea with onset before menarche or secondary amenorrhea. Statistically, it is defined as spontaneous menopause occurring below 2 standard deviation below the mean estimated age for the reference population for 5% level of significance. So for Indian population, it is around 38 years. The European Society of Human Reproduction and Embryology laid down the following diagnostic criteria for POI, that is oligomenorrhea or amenorrhea for at least 4 months and an elevated FSH levels more than 25 international unit on 2 occasions 4 weeks apart. Then there is one term called as delayed menopause. It is not defined but may be important in terms of increased problems associated with hyperestrogenism. It is 2 standard deviation above the natural average age of menopause in a given population. We may consider it to be beyond 54 years. And there is induced and temporary menopause. Induced is cessation of menstruation that follows after bilateral oophorectomy or iatrogenic ablation of ovarian function. And temporary, it is termed preferably not to be used since definition of menopause is complete cessation of menstruation, and rarely ovarian function is interrupted for a period or time. Then there are, based on NICE guidelines, the diagnosis of perimenopause and menopause should be done without laboratory tests in otherwise healthy women aged over 45 years with menopausal symptoms. So perimenopause is based on vasomotor symptoms and irregular periods. Menopause in women who have not had a period for at least 12 months and are not using any hormonal contraception. Menopause based on symptoms in women without a uterus. So it takes into account the fact that it can be difficult to diagnose menopause in women who are taking hormonal treatments, for example, for the treatment of heavy periods. The National Library of Medicine from USA has simplified menopause definition as menopause is a routine non-pathological condition involving the permanent cessation of menses for at least 12 months. Menopause occurs in all menstruating females due to non-pathological estrogen deficiency. Indian Menopause Society has defined menopause in a concise way, like they have included 12 months of amenorrhea, retrospective diagnosis, depletion of ovarian follicles, diminution of ovarian hormones, no independent biological marker, and objective sensitive marker is irregular cycles. So there is no need to conduct tests routinely to diagnose menopause. That is usually based on the history, symptoms and signs, maybe vaginal pH and lateral vaginal smear, and trial of medication, like you give progesterone if it doesn't respond to that. Then what are the basic physiological changes in menopause? Physiological changes of menopause are consequences of changes in both ovaries and hypothalamus. As woman grows older, her ovarian follicles diminish in number. There is decline in granulosa cells of the ovary, which were the main producers of estradiol and inhibin. With the lack of inhibition from estrogen and inhibin on gonadotropins, the follicular stimulating hormone, that is FSH, and LH, luteinizing hormone, production increases. FSH levels are usually higher than LH because LH is cleared from the blood faster. The decline in estrogen levels disrupts the hypothalamic pituitary ovarian axis. As a result, a failure of endometrial development occurs, causing irregular menstrual cycles until they stop altogether. In the pathophysiology, menopause is a normal physiological process in aging women in which number of ovarian primary follicles quickly diminish such that there are inadequate amounts to respond to the effects of FSH. In turn, there is no LH surge and ovulation does not take place, resulting in decline of estrogen production and cessation of menstruation. However, LH and FSH go uninhibited and remain on higher levels years after the onset of menopause. Small amounts of estrogen may still be produced via conversion from testosterone released from the adrenal glands, such that symptoms often that the discontinuation of periods may be negligible in some individuals. Markers for the diagnosis of menopause are preferably restricted for the use in special situations and in fertility issues. Levels of follicles FSH more than 10 international unit per liter are indicative of declining ovarian function. Then FSH more than 20 international unit are diagnostic of ovarian insufficiency in perimenopausal age group with vasomotor symptoms and even in the absence of cessation of menstruation. And FSH level more than 40 international unit per liter done at least 4 weeks apart is a reliable marker for menopause or impending menopause and association with low estradiol levels. Anti-Mullerian hormone becomes undetected, inhibin levels fall, and antral follicle count and ovarian volume decreases at menopause. Menstrual irregularity is the only objective marker to define and establish menopause transition. NICE guidelines clearly mention that you should not use the following laboratory and imaging tests to diagnose perimenopause or menopause in women aged over 45 years. That is anti-Mullerian hormone, inhibin A, inhibin B, estradiol, antral follicular count and ovarian volume. You did not do all these things if the woman is more than 45 years. It suggests using a FSH test to diagnose menopause only in women aged 40 to 45 years with menopausal symptoms, including a change in their menstrual cycle, or in women aged under 40 in whom menopause is suspected. So these are the menopause symptoms at glance. You have various changes which are occurring. The biology and symptomology of menopause are blurred due to its relationship to the underlying aging process. The history will include symptoms related to estrogen deficiency. The obvious symptom is the cessation of menses, typically heralded by changes in the menstrual cycle. Other symptoms are vasomotor symptoms, somatic, genitourinary symptoms, psychogenic symptoms. So vasomotor symptoms, approximately 45% of the women experience vasomotor symptoms. These symptoms include hot flashes, night sweats, palpitations and migraine. Hot flashes often last approximately 3 to 4 minutes at unpredictable intervals. They may be worsened by alcohol, eating, emotional stress and exertion. Hot flashes are characterized by a rapid rise and discharge of heat with perspiration, discomfort and possible redness. Ranging from mild to severe in intensity, they may be preceded by an aura-like experience and may be followed by a subsequent feeling of chill. Hot flashes may be preceded by a prodromal experience or a set of signs of rapid heartbeat, anxiety and dizziness or weakness. As the flash comes on, there is a feeling of sudden heat that produces as little as a beading of perspiration on the upper lip or a sudden and uncontrollable drenching. The sudden feeling of heat may be followed by a cold, clammy sensation as evaporation of the perspiration occurs. The episode may last from 30 seconds to 5 minutes, on an average about 4 minutes is reported. Migraines may change in the intensity and severity. Migraines without aura are more common than migraines with aura. Migraines with aura have an increased risk of stroke, especially in a woman who smoke or use oral contraceptives. Other types of headaches such as cluster and tension headaches may also increase with a change in the hormone levels. Vasomotor symptoms may be reported in menopause transition, reaching the maximum intensity during the first 2 years post-menopause and then declines over the time. Vasomotor symptoms generally last for 6 months to 2 years, although some may experience for 10 years or longer. We need to exclude other causes of flushing before planning a treatment. Then there is grading of vasomotor symptoms. It is important to plan management, follow-up and for research. So grades of hot flushes are classified like there is mild feeling of heat without sweating, or moderate feeling of heat with sweating, or severe feeling of heat and sweating with palpitation that disrupts the usual activity. Then there are somatic symptoms like joint aches and pains, which are more commonly reported among women at midlife. While women are obese or depressed are more likely to experience joint pain, there also appears to be an association with menopausal status, with peri and postmenopausal women experiencing more joint pain than with the premenopausal women. Then body composition. Although women typically gain weight during midlife, it does not appear to be due to menopausal status or stage. In the early menopausal years, women typically gain abdominal fat mass and lose lean mass. Skin changes the skin and the bones is reduced by estrogen deficiency. The decreased cutaneous collagen may lead to increased aging and wrinkling of the skin, frontal balding and hirsutism. Balance. Impaired balance is the postmenopausal woman may be a central effect of estrogen deficiency additional to aging. Problem with balance may play a role in the incidence of forearm fractures in women. Coming to the genitourinary symptoms, approximately 60% of the women experience urogenital symptoms. It presents as vaginal dryness in around 32%, pruritus vulvae in 10 to 17%, dyspareunia and urinary urgency in 10%. There is vaginal atrophy, urethral atrophy and sexual dysfunction, that is decline in libido. It is due to urogenital atrophy as a result of declining estrogen levels and may also present as recurrent urinary tract infections. Urethral atrophy results in stress incontinence, frequency, urgency and dysuria. Physical signs of vulvovaginal atrophy are variable and include reduced vulval fat, reduced vaginal rugae and blood flow leading to a pale appearance, a change from moderately acidic range, that is 3.5 to 5, to a neutral range 6 to 8 pH in the vaginal pH. There is a shift in the vaginal maturation index. Then coming to psychogenic symptoms, approximately 45% of the women experience psychogenic symptoms. These symptoms include anger, irritability, anxiety, tension, depression, sleep disturbance, loss of concentration, loss of self-esteem and confidence. The IMA consensus group has done one staging for the menopause. I'll just quickly run through this. Uncle Celia in India published a simple clinical method of staging of menopause to understand and deal with the problems of transitional phase and beyond. So this is the chart. Both modified classification of Uncle Celia staging and stages of reproductive aging workshop classifications may be utilized for clinical purposes and treatment of menopause. So even though menopause is a physiological condition and not a disease, it has significant morbidity. Besides the increased risk of osteoporosis and fractures, the women also regain their risk for heart disease. In addition, the symptoms of the menopause are poorly tolerated and lead to poor quality of life. The plethora of symptoms advocates compassionate approach for the treatment. Thank you.
Thank you, Dr. Mayuri, for such an informative and thorough talk. We'll be having our question and answer session at the end of each segment. Now our next speaker has sent her lecture all the way from Toronto. Dr. Susan Goldstein. She is a family physician and assistant professor in the Department of Family and Community Medicine at the University of Toronto. She is a menopause practitioner certified by North American Menopause Society. Her menopausal assessment tool, the MQ6, and the treatment algorithm were published in the April 2017 Canadian Family Physician Journal. Dr. Goldstein is a recipient of a number of honors and awards, including Award for Excellence in Undergraduate Teaching and the Award of Excellence from the College of Family Physicians of Canada. So I will be playing a video which is sent by her in just a couple of seconds.
I'm Susan Goldstein. I'm a family physician in Toronto, Ontario, Canada. I have an interest in women's health as well as medical education. I am a NAMS certified menopause practitioner. It's the North American Menopause Society. I also sit on the board of directors of the Canadian Menopause Society, and I'm the author of the MQ6 assessment tool and algorithm, and now the MQ6 website. I want to thank you for inviting me to come speak with you today. I'm sorry that you can't even do it by live Zoom, unfortunately due to some scheduling conflicts. However, I hope that even in this realm, I'll be able to provide you with some valuable information. So these are my disclosures. I have received fees from a number of companies for a variety of reasons, but please be sure that all the content in the website and everything I talk about today has not been influenced by outside influence. I did receive, very happily, an unrestricted educational grant in order to create the MQ6 website. I have not received any personal fees for my work to do that, and I'm not receiving any fee for this presentation. So, what is www.nq6.ca? Because that is where you will find this menopause management toolkit. It's a website that contains a number of menopause management tools. It's centered around the 2017 publication of the Menopause Quick 6 Assessment Screening Tool and Treatment Algorithm. This was published in Canadian Family Physician in 2017. But we have not just stopped there. There's a lot of other information and tools for you on the website as I'm going to talk to you today. On the website, the content and the recommendations are evidence-based and peer-reviewed by a group of multidisciplinary national menopause experts in Canada. The website is designed for use for both healthcare providers and patients. The purpose is knowledge translation, education, and support. For healthcare providers, the focus is on symptoms assessment, risk assessment, creating an individualized treatment plan, and associated counseling for menopause management. For patients, we provide basic information and links to resources, and also the purpose is to encourage patients to do self-assessment using the MQ6 assessment tool in order to facilitate them obtaining care for their menopausal concerns, to get that conversation started, because we know worldwide there are some real obstacles to obtaining and provision of menopausal care. I'm going to start with the MQ6 assessment tool. This is a quick screening tool, and Menopause Quick 6, quick not because I speak quickly, although I do, but because it's very quick to do this screen, less than 2 to 3 minutes. It is a validated tool. After publication in 2017, it was validated for internal validity with good results in Peru in 2020 and also in Malaysia last year. We've submitted our Malaysian data for publication, so at this point it is still unpublished. But in both cases, we did see good internal validity. So we are using a validated tool. The original tool was written over here, as you see it, using open-ended questions because the purpose was not just to screen, but to ask the questions in a way that was going to facilitate conversation with the patients. The 6 questions are there for 3 big reasons. The first one is, these are the questions that all the guidelines really around the world are recommending we should be asking of our perimenopausal and menopausal patients. These are the symptoms that are the most frequent ones that present, and these are the symptoms for which we have menopause-specific treatments. For example, if we have 33 symptoms of menopause and one of them is palpitations, as a primary care physician or as OB-GYNs, we can provide them with care, but it's not menopause-specific. So what are the questions and why? So the first question is, any changes in your periods? We want to ask this to ascertain, is the patient perimenopausal or postmenopausal? When was their final menstrual period? And we ask it in this way because sometimes patients will say, my last period was 2 years ago, but I had a bleed 3 months ago. And that helps us screen for potential postmenopausal or abnormal bleeding that patients often will not tell us about. Second question, are you having any hot flashes? As we all know, 80% plus of women are going to have some form of hot flashes during the transition or postmenopause. Third and fourth questions relate to the symptoms of GSM, the genitourinary syndrome of menopause. We used to talk about vulvovaginal atrophy or VVA. The new term GSM recognizes that the drop in estrogen levels does not just affect the vulva and the vagina, but also affects the urinary tissues. So we want to know about vaginal dryness or pain or sexual concerns, and we also want to know about bladder issues or incontinence. Very important to ask these questions. First of all, whereas hot flashes may last anywhere from 5 to 12 years or more in patients, in almost all patients, VMS or vasomotor symptoms will eventually abate. However, GSM, if these symptoms start, these will go on lifelong. And if 50% of women are having those, that's a big cohort. The other concern is that women are often embarrassed to talk about or ask about these types of concerns. So it relies on us to open the conversation by asking. Fifth question is, how's your sleep? We want to know if there are new or different sleep issues common in the perimenopausal and menopausal times. And lastly, how is your mood? The perimenopause in particular is a high-risk time for emergence of anxiety, depression, irritability, and recurrences of major depressive episodes. So these are the 6 questions. As you see, we can ask them very quickly. This is written, as I said, with open-ended questions in mind. So there is a binary version that you will find, actually a few of them on the website, where instead of asking the questions in this way, you can ask them in a yes-no fashion. Handy in case you wanted to provide a copy of the questionnaire to a patient before a visit, or you wanted to import this as a stamp into an electronic medical record and wanted to have yes-no answers. I think you don't quite get the same richness of answers doing that, but there are PDFs which you can download, print out, save for healthcare providers, also a PDF for women, I'll show you in a moment, and also another version of this binary tool for use on mobile devices. You can access these tools all over the website, but the best place to go is actually under the MQ6 assessment tool button. And on that page, you'll see there's actually 3 buttons for different versions of the tool. So this is for healthcare providers, and it's just got the binary tick boxes. This is the one for women. The one for women has got some footnotes that provides a bit more explanation as to why we're asking these questions. You may choose to use either of those. And then this over here is the mobile-friendly version. So you can access this if you want to be able to download this tool when using a mobile device. So after we ask the MQ6 screen, or those 6 questions, we now are going to want to decide what to do with that. So we do have the accompanying treatment algorithm or decision tool. It has been updated from 2017 this year for a few reasons. One is to reflect new products that are available, new information and new guidelines, and also just to rework the logic of it ever so slightly in terms of the order that we ask the questions to make this just a bit more efficient. You can see you add the MQ6 tool at the beginning, you ask the 6 questions, and then it takes you through these steps through the treatment algorithm. I'm going to go through that with you. It's a little bit hard to read, but I do want to explain the rationale for the questions and how it works. So we've asked our assessment tool. Now, first question, is menopausal hormone therapy indicated? Indications would be vasomotor symptoms, GSM, early or premature ovarian insufficiency, and bone protection. If the answer is no, there's a table here of non-hormonal medications that may still be relevant for that patient. If the answer is yes, we go to the second question. Is GSM the only reason for treatment? So if those local below the waist symptoms are the only reason the patient is seeking treatment, then we can go directly to the GSM specific treatments, which would be vaginal estrogen therapies, vaginal DHEA, or an oral serum pemifene, which these are the Canadian products because we are a Canadian website. And I respect around the world, things can be a little different. The next question, assuming that GSM is not our only issue, we want to know are the contraindications to menopausal hormone therapy, and they are here. If yes, we go back to the non-hormonal medications table. If no contraindications, we want to know are there comorbidities. Comorbidities are medical conditions that, in general, for the purposes of this algorithm, really, for the most part, increase your cardiovascular risk. And the guidelines recommend that when available, the use of transdermal estrogen over an oral estrogen is preferred because you avoid that first pass metabolism through the liver, and therefore you're less likely to get an increase in the clotting factors and an increase in clotting. And when patients are at higher cardiovascular risk to start, we don't want to make them more thrombogenic. So if there are comorbidities, transdermal preferred, otherwise any estrogen would do or any product. Fifth question, has the patient had a hysterectomy? If they have, we do not need to provide endometrial protection, and we just can give them estrogen alone. But if there is a uterus, we do need to protect that endometrium, and therefore our options would be estrogen or a TSAC, which in Canada we have something called Dulavie, which is conjugated equine estrogen, along with beta-doxyphene, which is a SERM. And the other product we have is a steer. This is a sex steroid. It's Tibolone. That has androgenic, estrogenic, and progesterogenic effects. Last question, when was the final menstrual period? Was it more or less than a year? Is the patient perimenopausal or postmenopausal? Because a postmenopausal patient, i.e. it's been more than a year since the final menstrual period, they could tolerate a continuous regimen. They may still get some bleeding or spotting. However, that will go on 3 to 6 months at max, and it usually will settle down on its own. But if you try and give continuous regimens to women who are still cycling or just stopped, i.e. within a year of final menstrual period, they are much more likely to not tolerate a continuous regimen, bleed when not expected, and then stop. So we recommend a cyclic regimen for those women. After a year, you can try and switch them to continuous regimen, see how they do. So again, there are 6 steps in this algorithm or decision tool. And then there is a consideration at the end. We bring you back to just revisit the question. So maybe your patient needs some bone protection, has vasomotor symptoms, but also has symptoms of GSM. We know that we start with lower doses of medications now, hormones in particular, versus years ago. And we know that when you're using lower doses, you don't always get a lot of benefit from those systemic hormones below the waist to the genitourinary system. So if a patient is going to be prescribed less than what we consider standard doses of hormone therapy, so that would be the equivalent of conjugated equine estrogen 0.625, estradiol oral 1 milligram, or 50 microgram patch, by example, and it's written in the box here. If you're going to start them on a regimen with a lower dose than that, you may want to, at the beginning, also consider adding some additional vaginal estrogen therapy to treat the GSM. So this is the exciting part. We've had the algorithm and the assessment.
Sorry for interruption. As I see, all the things are not clearly visible on the slide. So all of you can go to the website, which is nq6.ca, and simultaneously you can see all the things on your phone while the lecture is going on.
Full published, but when we really did this website was I really wanted to build the equivalent of an app, so that rather than having to print off the algorithm, which you can do, you can actually just do this very quickly in an app-like way on either a computer or on a mobile device. And so, if you go to the For Healthcare Professional button and you scroll down on the drop down to interactive treatment algorithm, you will come to this page. You click on interactive treatment algorithm, and you will get to this start button. And this essentially will take you through the steps of the algorithm I just described. It's just doing it online for you. So you click start, and the first page you get is question 1 from the decision tool. Is menopausal hormone therapy indicated? Gives you the indications. There's some hovers with some extra information. And you'll either answer yes or no, just as you would have if you used the decision tool manually. And then you'll go to the next question, and you'll click yes or no 6 times. And at the end of that, you will get to a page that says treatment recommendations. And I fear that my picture is on top of that. I'm going to move that over so that you can see that. So this is the answer pages, and all the answer pages are individualized depending on the answers to the questions that you provided. And what these answer pages do is give a recommendation. So for this patient, consider prescribing any oral or transdermal daily estrogen therapy. I can tell from that this is a patient who does not have comorbidities, so any estrogen will do, and who does not have uterus, so she doesn't need any endometrial protection. But in any case, at the bottom of that page, it will give you the 6 answers to the questions you just answered. I just can't show it to you here. But what it does do is give you the rationale for the recommendation, extra considerations, reminds you to consider whether or not you need to treat GSM in addition, and then you have this button here. If you click here, it will take you to a table of treatment options that are relevant to the recommendation. So in this case, because this was an estrogen-only recommendation, it will take you to the estrogens table. So I hope that you will find that helpful because it's very quick. You can do it online from your phone, from your desktop. And now, the best part of this is you can actually create an app by creating either a shortcut or a bookmark on your home page, on your phone, or on your desktop or laptop. So if you go to the interactive treatment algorithm page, you'll see a section here with a picture, and that will describe how you can very quickly create an icon or a shortcut so that you can then just sort of press that button and you get to the start button right away. I have it on my phone. This is what it looks like. I'm going to show you very quickly how to do it on iPhone because that's the part that I know. But now if I click on this, which is on my screen on my phone, it takes me right to the start button of the algorithm. So essentially, if you're on your phone, you go to for healthcare professionals, drop down, you go to interactive treatment algorithm to that page, you scroll down to the blue button, remember we did that, and it gets you to the start page. And now you go down and look at the bottom of your screen on your phone and you see the share button. So if you click on that share button and then you scroll up, you'll see you'll get to this menu that says add to home screen. And when you click on that, you'll end up with that little icon on your phone. Alright, so we've talked about the MP6 assessment tool, we've talked about the treatment algorithm in the PDF form, and we've also talked about the interactive online decision tool that you can turn into an app. What else can you find on the website? So there are EMR templates for the MP6 assessment tool for a number of different EMRs that you can import. There are medication tables for both hormone and non-hormonal options for menopausal therapy. There's a counseling sheet. You can see a copy of it here to your right. I find this a helpful tool because there's lots of things to remember, particularly for my primary care physicians when they're counseling around prescribing menopausal hormone therapy. But what I really like is this is also PDF. You can download it, you can print it out and give it to the patient. You will also find on the website some general information about menopause, including an overview of the updated findings from the WHI study. There's a frequently asked questions section as well under the for healthcare professionals, and those are little tidbits and tools and tricks when you are prescribing, just to help you with some of the subtleties. There is a button for women, as I said at the beginning of this talk, with some general information for them. And one of my favorites is the button that you can find this page throughout the website. You can get at it different ways, but there also is a button for health promotion right at the top of the menu. It says menopause health promotion, but truly it's health promotion for everybody. And it focuses on getting preventive screening done, but then bone health, brain health, and heart health. What I really like as a primary care person who does a lot of physicals or annual health exams, I counsel patients about this stuff. They always forget about it. And so now I just tell them, go to mp6.ca, go to the button on the far right that says Menopausal Health Promotion. They can reread it and it will remind them about healthy living. Two really valuable, in my opinion, pieces here is there is a button under Bone Health. If you click here, it will take you to Osteoporosis Canada website, and there is a calcium calculator right at this link. So when I talk to patients, do you get enough calcium in your diet? They don't usually know. I say, click here, fill it in, you'll see how much calcium you're getting in your diet on any given day, you'll know how much you need to supplement. Similarly, under cardiovascular health, there is a place to click for Life Simple 7, which is the American Heart Association's recommendations for healthy living. And that essentially is what you can find on the website. I hope that you'll have a look. I hope that you will find the tools helpful to make the provision of menopausal care more robust, make it simpler, easier, quicker for you as clinicians and healthcare providers. That's my hope. I want to thank the Canadian Menopause Society again for an unrestricted educational grant who create the website and to my content reviewers. And thank you for listening and for inviting me to speak today, and wish you all the best.
Website and algorithm has been created so that we can have customized treatment plan and management plan for our patients, considering all the factors, indications, contraindications, and risk assessment. Gauri ma'am would like to say a few words about this.
Sunday morning to listen to menopause, and just that is what I was talking to Dr. Meeta. She said that this Nashik OBGY is a very academic and enthu crowd, so we have so many people here, so thank you so much. I just wanted to talk about this algorithm. Actually, I spoke to Dr. Susan and she has conveyed her apologies because she had some commitment, otherwise she was going to join us online. So this was the best that we could get this algorithm, because if we want to treat menopause in a systematic way, we have so many options that we are going to discuss through this morning, that it is really confusing where and when to stop and which to give. So this has been really made, and it's a validated tool. So I would request, I have sent it on the official group I have sent the link to everyone, so you can go back home and go through this. One question, so this is coming from the International Menopause Society has also agreed on this tool. So I would request all of you to go through this tool and make use of the tool in a systematic way when we are dealing with our menopausal patients. And let's hope that we have older and happier and more energetic menopausal population in the city of Nashik. One question that I had for Dr. Meeta and Mayuri actually, that we are talking about menopause. Some women will come with lot of vasomotor symptoms, some will come with no symptoms. So is there some secret source of estrogen other than the ovaries that is functioning in the women, other than the ovaries, even after menopause? Is there some place, because we've seen women who exercise, who are working out, they don't face this as much. So is there some secret source that our women and our doctors can tell our patients that is there some place where we can find estrogen even after menopause?
Hello, very good morning to everyone. So probably I'll leave that answer during my presentation so that the flow is there. I think that's an excellent question and I'll definitely answer that.
So we'll wait for the answer.
Next session, which is Locha-e-Hormones. So deliver a talk on optimizing hormonal replacement. We have a very eminent faculty, Dr. Meeta Singh ma'am. She is a director consultant and menopause consultant at Tanvi Hospital, Hyderabad. She is founder chair, Indian Menopause Society Registry, which is formed in 2021. She has got numerous awards. She is the editor of Journal of Midlife Health 2020 to 2022. And she is a chair clinical practice guidelines on menopause, chair clinical practice guidelines on postmenopausal osteoporosis. She is a past president Indian Menopause Society in 2012, founder chair research committee of IMS, founder patron Hyderabad Menopause Society. So I welcome Dr. Meeta Singh ma'am on the dais.
Thank you, Dr. Gauri and Dr. Mayuri. That's rhyming, isn't it? And the Nashik Society for inviting and to have a crowd to listen to menopause on a Sunday morning is a big pleasure. Because when we started working on menopause years ago, maybe about 20 years ago, we would just have a handful of doctors coming in. And slowly the people who were going through it got interested. But now we find youngsters coming in after the CIMP exam. The Indian Menopause Society holds a credential exam every year. And earlier it was a physical exam which would be held on the meetings. But now we have this exam online every year in February. And the website for menopause is www.indianmenopaussociety.org. So people who are interested in learning more about menopause can just go onto the site and you get all the information. And if you still need to know something, you can get in touch with me. And this society has been there for more than 25 years now. And we have all these guidelines to work on. And I congratulate Gauri to have brought this, the menopause tool. Because I think the whole world was actually in a confused state as to how to, you understand about menopause, you understand about everything. But I remember Vera when we were in those initial stages. And it was confusing to understand how to stage it, how to stage menopause, or how to make it communicable to each other, or how to implement it in practice, because it's a huge thing where you get lost. It's like a maze. It's like the Jaipur gullies that you go in like that. So we used to always say that it is something like we have to do something like how you stage labor. Imagine if you didn't have stages of labor. Imagine if you didn't have the protocols. Would you function as efficiently as you are today? And now you know exactly what are the stages of labor, and then you know when to do what. And then you can audit your work, and then you can do better. So similarly, in menopause, staging becomes very, very important. And I think Susan has done a fantastic job, because till now, that was one of the major hitches for people to get into menopause. Because even I started the registry, I'm going to take a little extra time because all this is not part of the presentation, but I think this is a very important primer. Because when we started doing the menopause proforma, it runs in 4 pages. So when I started the registry, out of 4,000 IMS members, there are only 15 who are with me, and we're doing it very regularly for the past, so that means it's not that people are not interested, but out of your busy practice with other things, to fill up a 4-page form is not easy, unless you're only doing this. So that was a challenge. I think this is going to be a game changer now, because at least the primary care, you can kind of get into this, and every obstetrician and gynecologist will be able to do this much. But I suggest that giving hormone therapy only for those who don't have any contraindication should be done by a generalist. But whenever you have a doubt, refer to a specialist. Don't take it up. I think that's how things are going to be. So today, the entire lecture, and I congratulate you, Mayuri, and Dr. Ujwala also, because I think they have really gone into the depth of it and planned up the CME for today, so that all the good messages go on. So today, we have captioned this talk as optimizing MHT as to how to use it efficiently. And so this is the Himalayas. So yesterday night I was a little free and I saw that movie Unchai. I don't know if anyone of you have seen it. It's a beautiful one. And this is a picture, so this reminded me of the Unchai. For me, it was learning about menopause, and I achieved my goal. And I thank Abbott for this sponsorship of this program. Yes, they have sponsored this whole program for us. And so menopause isn't that bad, and you can overcome it. So the discussion is first some take-home messages, so that even if I run short of time, I know you're alert enough to know what these take-home messages are. Then some new update, what is really part of the news. When to give, whom to give, what are the precautions, what are the vigilance, and how long to give. So I'll take you like that, and the take-home messages, the target population for initiation of hormone therapy is usually within the first 10 years of menopause, and that is period. That means you're not going to start hormone therapy after 10 years of menopause. There are many reasons, so I'm not going to go into that, but this is what you have to remember. Hormone therapy initiated in the early menopausal period in healthy women is safe, very safe, unless there is a contraindication. Like all medicines, hormone therapy needs to be used appropriately, and it is essential that you work through it. And of course, it's an informed choices. It's not like diabetes and hypertension where it's a do or die situation and you have to give the medicine. Of course, there are situations like POI where you have to treat it, then it becomes hormone therapy. Then you're not calling it menopause hormone therapy, there you're calling it hormone replacement therapy because you're replacing something which has been taken off at a very young age. Whereas at menopause, it is a dialogue between you and the woman, and then it is accepted. So that's why it is a menopause hormone therapy, and it has to be used appropriately. So individualizing is the key recommendation from all the guidelines. So we have a lot of guidelines from the international, from the Canadian, from Australian, from the Indian Menopause Society, but all of them agree on that in the premature ovarian insufficiency, you have to give hormone therapy unless contraindicated up to the age of menopause. And there's a lot of talk and information also coming in about early menopause. Early menopause for us Indians is between 40 and 45. So 40, less than 40, actually for us it's less than 38 because we age earlier. So less than 38 becomes pre-POI. So between 38 to 43, these women, if they have, we have a lot of women going in for menopause less than 43, less than 45, they don't even go up to 47, and these women also may need hormone therapy. After 46, it is the natural age of menopause for India, 46.7. So between 40 and 50, if somebody needs hormone therapy, it is pretty safe to prescribe. So even a generalist can prescribe. But if you are going to plan something within 10 years of menopause, then you have to think twice. Whereas beyond 60, if you are not going to start hormone therapy 10 years after menopause, because you see the indications are very few at that time. But even at that time, if you're looking at bone health, and you want to start something and they are not interested in taking the bisphosphonates or the the newer ones that have come in, the injections and all that, the teriparatide, and you feel that hormones are good, in the Western countries they are still confident about it because there have been some old-time researchers where only hormone therapy was available for bone health at that time, and they would start hormone therapy at the age of 60, 65, 70 also. So there is some confidence and some evidence where hormone therapy was given for bone health even in the older women, but you can forget about it for today. For today, for us, hormone therapy don't start beyond 10 years of menopause as of now. It may change over a period of time, but today we have to follow that. So the whole grey area of hormone therapy, where it should be given, when it should be given, when it should not be given, actually is thanks to the WHO Act, that is the Women's Health Initiative. And that's how came the timing hypothesis, the window of opportunity that we keep talking about, or the timing hypothesis that we talk about. And this is what it shows, that within 10 years of menopause, that means the woman, once she enters from the perimenopause to the menopause, a lot of hormonal changes are happening, very beautifully described by Mayuri. Very quickly she has put everything in place, where your estrogen deficiency starts happening and your FSH and the LH starts rising. But the androgens actually don't fall so much because the androgens are coming from the stroma and your estrogens are coming from the follicles, so that goes down. But the stroma still continues to produce the androgens. And if there are a lot of infertility people, then you understand the endocrinology better, and you know that these androgens are coming from the ovary in the post-menopause. I'm answering your question now. So you have the ovary. That is why we say, though the estrogen is not coming from the ovary, don't knock off those ovaries, because the ovaries are an indirect source of those estrogens. And the stroma gives rise to these testosterons, and we know that there is something called aromatization. And that's how the estrogen gets from the androgens from the ovary, that is part of it. Only 40%, 50%. The majority are coming from elsewhere. And which else organs produce this androgens? It is the adrenals and the fat. So the fat in the body, that produces again the aromatization. So estrogen doesn't come de novo. So probably the stories from the Christian mythology where the woman is from the man, comes from this. So the estrogens are coming from the in a postmenopausal woman, it is coming from the testosterones. So that's where it comes. So that is why we find obese postmenopausal women are more at risk for endometrial cancer, they are more at risk for breast cancer compared to fat women in the premenopause. So who are fat and premenopause are not so much prone for these cancers compared to the fat women who become postmenopausal because the estrogen content increases. But what is happening is, the estrogen that you are getting over there is mainly from the androstenedione. So that means it's more of the estrone. So all of us are aware there is something called 17-beta estradiol. So we have three main hormones working in the body, E1, E2 and E3. E3 is the end product. E1 and E2 are interchangeable. Whereas E1 is very less potent. E2 is very potent. So, I mean, this is something which is one of my favorite statements, which I have also put it in the guideline, that God, in fact I put it in big caption, saying that how wonderful God has created a human being and made these hormones which are very particular for each stage of life. Say in pregnancy, what do we measure when you're doing your triple marker test? Once upon a time you would do the triple marker. If anybody over here was doing the triple marker, now we do the double marker. So we used to do the triple marker once upon a time. And one of the estriol. So you see, if it was not estriol, and estriol is the least potent of the hormones, isn't it? So if it was not estriol, and we had 17-beta estradiol during pregnancy, what would have happened? Gone. So many breast cancers. Everybody would end up with a breast cancer, isn't it? So you had the least potent hormone during your pregnancy. And what happens at menopause? During your reproductive phase, all the organs are well maintained by this potent 17-beta estradiol. And once the menopause sets in, it is the lesser amount of potency, that is the estrone which comes in. So you know why I'm going to the depth of this is, because if you understand this concept, prescription is very easy. Because you understand the potency. You understand when you should give what. And at what age, what kind of medicine you need. If you're going to give for a POI, an estriol therapy or an estrone therapy, that kind of potency, it may not work because the body needs more at that age. Whereas if you're giving an 80-year-old 17-beta estradiol, what has happened in WHI is going to happen. That means the wrong drug at the wrong age. So hormone therapy is something like your homeopathy. You have to tailor the dose very, very minutely. You have to choose and pick your woman, and each woman is different. So somebody may respond to some amount of drug, the other person may respond to a different amount of drug, because it's not only the estrogen coming from the ovary, but then it is also the absorption from the intestine, and that is why the Japanese do very well, because they have the equal. All women are not equal producing. Some may be equal producing, some may not be equal producing. So then you have so many factors which actually have an effect on the estrogen at the tissue level. So one is the absorption from the intestine, the transport by the sex hormone binding globulin, and you know how this forms a very important molecule, because the higher it is, the more amount of the testosterone and estrogen are absorbed to it, and very little is there in the blood. But if this is less, like what it happens in your PCOS, the sex hormone binding globulin is less, so your estrogens are high, and your even the androgen becomes high. So this becomes very vital. So your tissue levels, then at the tissue level, it's at the receptor level. So there are many cofactors acting over there. So each woman may have different types of cofactors acting there. That is why hormone therapy results in all the trials may be different for different women. And that is why we Indians may be different from the Caucasians. So everything that they're doing over there may not totally apply to us, because ethnicity or food and everything matters. So timing hypothesis becomes very, very important, because each woman is different, age is different, but these are the problems at menopause, and what are the problems of aging. Problems of menopause, I'm sure all of you know this, and problems of aging are different. So the NAMS, this is very interesting, NAMS 2020 guidelines, because after the WHI, everybody kept saying minimum amount of medication for a minimum duration of time, That means don't give for long. Give for 1 year, 2 years, stop the medicine. Maximum amount is 5 years. But now what the NAMS has taken about now, and they say hormone therapy need not be routinely discontinued in women aged older than 60 or 65 years. That means if somebody has been in therapy at menopause and they continue up to 60, and at 60 they feel for the bone health or for the menopausal symptoms, they want to continue, you need not stop because they have information. We have evidence to say this somebody who's already on therapy can continue. But if somebody has not been on therapy, you're not going to start it at that time. So there's a difference. So this is what it means. Longer duration or extended use beyond the age of 65 should of course include the regular checkups, and you should understand when to continue and not to continue. For the GSM, low-dose vaginal therapy can be used for an extended period of time, and there is no contraindication. So we need to understand that there are 3 indications which have stood the test of time, and that is symptom relief, vasomotor symptoms or menopausal symptoms, whatever you say. Then you have the urogenital, and then you also have the bone health. So bone health is very, very important, which we don't understand. So bone health, POI, early menopause. So these are the basic indications that you are prescribing your hormone therapy. And then the other things which may also add on are the somatic symptoms, the sexual dysfunction, possible benefits. Again, now we're talking about, no primary prevention, no secondary prevention. We thought for cardiovascular, but you're going back again and you're thinking probably it may benefit CVS, it may benefit cognition. We're not talking about dementia. They're 2 different things. Cognition is different, dementia is different. We're not talking about Alzheimer's. We're just talking about cognition, because all your menopausal women say, oh, suddenly I feel I'm not able to concentrate, I'm not able to recall, short recall memories. So these are all the cognitive things. I'm not able to grasp as I used to, I'm not able to really do my work like I used to do earlier. So these are the cognitive functions which are different from dementia, different from Alzheimer's. So these are different areas, and sleep also gets affected. And the skin, the mucosa, all over, it helps. So these are the other benefits of hormone therapy, and some cancers are in fact reduced. Colonic cancer in the WHO trial, they have shown that there is a reduction of colonic cancer for women who are on hormone therapy, and estrogen therapy alone, there was a reduction in breast cancer. So compared to what people used to think, estrogen alone can actually reduce the breast cancer, unlike what we always have in mind that it increases the breast cancer, isn't it? So estrogen remains the most effective treatment. These are all what all the guidelines are saying, and all of them agree when to stop, when to initiate, when to stop. So now no mandatory limits. Actually, way back in 2012, based on all the evidence that we had collected, even at that time we had said that there need not be a mandatory time limit. What the NAMS is saying today, we had said that statement in 2012. And now they say yes, initially 60 years, this was the earlier NAMS report, but the 2022 says no mandatory limit, and the International Menopause Society, no mandatory limit. And of course the lowest dose, any medication that you give, would you offer a higher dose or would you go for a minimum dose, be it hypertension, be it diabetes? You would start with a lower dose. So I think it's the same, it's nothing different for hormone therapy, you just have to follow the regular rules. So it also has to be individualized, and I think this is also not strange from the other medications that we use for chronic conditions. Come back again to your diabetes and hypertension. Don't be individualized therapy. Some people do well with one kind of anti-hypertension, or some people do well with some others, because there are so many other adverse effects involved, isn't it? So you definitely have to individualize your therapy, and these are the crux of all the prescription. So now you understand that hormone therapy prescription is not as easy as what you saw with Dr. Susan's performer. That is good enough for a general practitioner, but not good enough for a specialist, so it has to be different. But it is very good for the general practitioner because you're picking up a problem, and then it's easier for us to send to a specialist. So I have formulated this with a case discussion so that you really go back how to follow up a case. Now this is a very typical case, a 44-year-old lady at menopause transition, para 2, and she lactated well, and then she had all the symptoms, and she has short cycles. Very rightly put, we don't need any investigations to prove that a woman is undergoing menopause, because National Library of Sciences, it's not a pathological condition, it's a physiological condition. Do you agree that antenatal is also a physiological condition? Of course, now all over the world and the metropoles have made it a disease. Pregnancy is converted into a disease. So much of fancy around it and so much of money making, it's become a business actually. So menopause also is a physiology, but we have to tap the pathological parts of it and then treat it. So now this lady uses condoms for contraception, and she had DDM in pregnancy and well-controlled diabetes for the past 3 years. She has dyslipidemia, and mother had a stroke at the age of 65, so there is a history. But she's well maintained because she's seen her mother develop the stroke, and she had DDM, and then she's got diabetes. So she's pretty well maintained, her blood pressure is good, her weight is good, and she's well informed. So what stage? It's very important because we have to understand what stage of reproductive aging is she in by the Strock classification, by the Barron classification. Late reproductive phase, transition, early, late, early menopause. So why do you think this is important? These are all important. So though I put it as a question, it will be difficult for us to have the question and answer session, which would have been very interesting. But I'll also tell you the answer straight away to save time. So she falls into the early menopause transition. That means she has not yet got her menopause and she's just entering into menopause, because this will give you what kind of investigations to do and what the problems you're going to expect and what is the treatment plan for her. So that is why it's important to have this. Now she falls into the early menopause, and so a very important question that Susan had asked is, how are your periods? Less than 3 months, regular period, pre-menopause. That means she's in the reproductive phase. Less than 12 months ago, irregular bleeding, late menopause. More than 12 months amenorrhea, then you have put her into the natural menopause. So in between the 3 months and 12 months, she is going to be early menopause transition. And if somebody doesn't have periods for 3 months, then also at a younger age, you're going to start investigating for POI. That's one catchment area. Always remember, a person who had regular periods throughout her life, not a PCO, and suddenly she has stopped periods for 3 months, think of POI, think of early menopause in those women. So these early changes are biomarkers for menopause. The estimated average age is 46.7, and it is definitely lower than that of the Caucasians. But why is it important to know? Because all the diseases happened 10 years earlier. And when you look back, over a period of years of being an obstetrician primarily, I realized that most of our women don't do well as post-dates. Because I remember 25 years ago, the Western world would wait up to 42 weeks for deliver, but we never waited, even at that time. The minute the woman goes 3 days, 4 days earlier, we would have earlier right and utero for whatever reasons. So we have an accelerated bone loss, we have an accelerated increase in cardiovascular disease, the cancers occur earlier, the diabetes occur earlier, so everything happens 10 years earlier. That's why this slide just says that, and it's all there in the guidelines. There is an executive summary, you don't have to go through the entire book, but if you go to the website, there is an executive summary guidelines from the Journal of Midlife Health 2020, and you can download that executive summary for your menopause as well as your osteoporosis. It's a good reckoner for you as a primer. So we do have a lot of these chronic problems which we need to deal with, and as 77 and by the 2050, your average age the woman expected to live. So from 46 to 77, so there are going to be so many women in this time where we need more doctors taking care of these women, and the symptoms are definitely there. But this is what it is. This is a very interesting slide which says that out of 780 women, 50% of them did not seek help. But those who went to seek help also, the doctors were not in a position to diagnose it or treat it. So that is why the primary health care and following that MQ questionnaire, I think becomes very, very important in India. So there is do we need to do any test? Yes, maybe a pregnancy test anytime when she comes to you first time. You never know, even at the age of 50. Just now I have a 53-year-old who is pregnant for the second time. She had a number of failures, And at the age of 50, 1 year of amenorrhea, and she came with postmenopausal bleeding. And when we did a scan, it was accidental hemorrhage. It was a huge surprise for her. She had a POI, and then so many IVF failures, IUI failures, and she didn't know she was pregnant. And we delivered her at 31 weeks, and of course 3 months with a small baby. And the pleasant surprise is 2 years later she got pregnant and she came back at 53. So it's very, and now she's in the 5th month of her pregnancy. And I tell you, these are the cases where you know that you are just an instrument. And there are no explanations for many things. Yeah. So answer is, of course, we don't need to do anything. And you have to remember this slide. Serum FSH more than 40. If at all you need to do, say there is some serum hyperprolactinemia, early menopause, POI. So there are certain conditions where you are going to do the blood test. Serum estradiol less than 20. AMH inhibitor is very low. Ultrasound less amount of reserve. This becomes very important when you are working out for your infertility. So this is the test that you need to do only in those conditions, not for diagnosis. So we come back again and we know this lady has symptoms, short cycles, early menopause, she has got diabetes and she is healthy. So what do we do with her? So what is your role? The role is not always hormone therapy. So thank you, Mayuri. I like that slide. In fact, I put it up. I took a picture and put it up in the Indian Menopause Society because Dr. Amma, who was the founder, Dr. Amma and Dr. Ashok Vaidya, fantastic researchers. They have actually, she always said, IMS don't make it into a hormone therapy advocate. For us, it is a holistic approach, and so I put that up in the IMS group just now. So symptomatic, asymptomatic. So first, always look at those women who are asymptomatic. Preventive therapy is more important, and then comes the care. So now we understand that it is, how do we go about that prevention? Because you're going to do the risk assessment for all the diseases, right from your clinical examination, right from checking the blood pressure, right from doing that simple breast examination for every woman who walks in, doing a pap smear for everybody, doing a waist circumference for everybody. This is a risk assessment. So you have to do a risk assessment right from your history, right from your clinical examination, and then move on to the investigations and do a complete risk assessment form. And then you create a management plan for your woman. And how do you create that management plan? That is, you divide this woman who is walking into your clinic into an asymptomatic woman. So all 40 plus women, we do this. So it's not only catching them with those questions. So all 40 plus women, you put them into symptomatic or you put them into an asymptomatic group. Symptomatic are the ones who have got, say, irregular cycles, or who have got vasomotor symptoms, or who are at a risk for, say, osteoporosis. There is a strong history, risk for cancer. So all of them get into your symptomatic group. The asymptomatic are perfectly healthy. So you institute preventive care. That means you talk to them about lifestyle, you talk to them about healthy aging. And those with the disease, with risk factors for disease but no symptoms, again healthy care. With symptoms, without symptoms, the end is the same. That means comorbidities, again you're going to treat. So at this time, even if they have come to you without symptoms, there are many a times, I'm sure all of you will vouch for it, that that's the first time they'll say, oh, I didn't know I had blood pressure. You check your blood pressure, they'll say, I've never been to the gynecologist after my delivery. You do a pap smear and then she may be having something over there which you need treatment. Or you may, do blood test and suddenly they say, oh, hypothyroid or a diabetes, which you as a gynecologist are picking up. And I tell you, these are all the things which give you immense pleasure. Picking up a problem, putting them onto this preventive therapy. So it's not always hormone therapy. Hormone therapy is only 7 to 10% of the women who come to you. So if they have hormone therapy, if they need, then it becomes different. Then the treatment manages. So you have to go through this entire process of height, weight, breast examination, waist circumference, blood pressure, basic blood test, pap smear, and an ultrasound. Most of us have waist circumference, don't forget. I feel now waist circumference is much more important than the BMI. So do the waist circumference at the level of the area crest, and that's what becomes important. Teach one of your paramedical sister, anybody, any non-medical person can do it for you. You don't have to do it yourself and waste your time. Then bone mineral density, if it is possible. There are clear indications when you have to send them for it. But these are, and the mammogram. So these are the basic things that you need to do for a woman, and these are the MHD checkups as well as for any woman who walks in even without symptoms. So the tests that we do are almost the same. So we have this risk assessment models. These models help us to pick up the problems. One is the breast, and then we have the CVD, we have the osteoporosis, and I'll talk to you about it. So the risk model is again a Gale model. Because we don't have any risk model for India, we have adopted the Gale model, and maybe it overdoes it. That means maybe we may have more number of women who may turn positive, maybe the false positives are more, but yet it gives you, it sensitizes the woman that there's something called breast cancer which you have to be aware, and you make them understand that they have to do their self-risk examination once a month, come to you and at least do your ultrasound, if not the mammogram. So whatever is available, we should keep doing, and don't think just because you don't have a mammogram facility or somebody cannot afford a mammogram, cannot do anything. You can downstage the disease, so please do it. So at least a visual inspection of the cervix is important if you're not doing the pap smears, but I think pap smear is there everywhere. If you're not in the HPV, at least do this. So these are the things that we have to do which you cannot say you're not doing. So breast risk assessment, so you categorize it as low risk, moderate risk and high risk. And this is going to help you when you're going to treat. So less than 1.6, the Gale model says 1 year or 5 years or a lifetime. Anything more than 5%, it becomes severe. So if it is low risk, you can give your MHT. If she is moderate risk, borderline, you have to have a dialogue and give. If it is high risk, you avoid. So that is how the safety of your MHT is there, because you're confident when you're prescribing that you're not doing anything wrong. So high risk cases, you do the mammogram. If they're really bad, after a dialogue you may give, but that has to be after counseling and taking proper consent. Low risk and moderate risk, yes, you can give your hormone therapy. CVD risk assessment, we are using a very, very simple model by the WHO and International Society of Hypertension, ISH. This is a simple cards. There are 4 cards with diabetes, without diabetes, and with the cholesterol values, without the cholesterol values. So you can imagine you're just taking the age, you're taking the sex, you're using the non-smoker, smoker, the systolic blood pressure, not even the diastolic blood pressure. So these are ready-made cards. So we have these cards, you can keep it on your table and just mark it over there. Even if you don't have a cholesterol value, you can do it. But of course all of us do our lipid profiles, and then it becomes easier, it adds value when you're adding the cholesterol, and then you again divide them. VT risk, simply by your history taking, you don't need to conduct us to understand the VT risk. So you do the VT risk, do the CVD, and then you know that low risk, safe, moderate risk, go for transdermal, high risk, you're avoiding. And if somebody has cardiovascular disease, definitely you're not going to start hormone therapy for those women. So this is how very, very easily you can understand whom to give. Osta, this is for bone health. So if you don't have, if you have this, you can do this very, very simple just by height and weight. But if you are doing the fracs, excellent, you can go online, do the fracs model. And if you have a BMD, you add to it, then you know where this woman stands, whether she has a problem or no problem. So now this woman, coming back to this woman, so you have to now chart in your mind, after you collect all the information, what is happening to this woman. She is in the early menopause transition, she's got symptoms, she's got diabetes, she's got dyslipidemia. So she falls into, we have staged a management plan without symptoms 1, 2, 3, 4. So you know in your mind that she is group 2, that means with symptoms, and she is with problems, she is group 4. So your MHT has to be tailored according to the group that she is falling into. So you see, again, I come back, if you're just following the simple algorithm, you may not be able to treat as well. So these are all the low risk, intermediate risk and high risk. And high risk you're not going to give. Intermediate risk, most of the time it is transdermal. Low risk, you can choose. Oral or transdermal, doesn't matter. You can give anything for that woman. So in your format, the proforma that we have, finally we put the diagnosis like this. That is the IMS risk score. We have a software for this. So we enter the Gale model, then we do the WHO ISH for your cardiovascular, then we do ASTA for the bone, then there is something called SART-F for muscle health. People forget muscle health. Fractures are not only bone, fractures are muscle frailty, which is much more important. So if somebody is just walking in nicely, able to sit, get up from the chair, just put normal. You don't have to do anything more. Only if somebody is not able to get up from the chair properly, then you go for the SART-F questionnaire, which are 5 questions. And then you conduct some more tests. And there also DEXA helps for the muscle health. then you do the dynamometer test, a little more detailing into this. So you understand menopause practice is not just about hormone therapy. There is much more to it. So we have to do all of them. Then you put a diagnosis. Again, like I said, the diagnosis is very important. There are 3 diagnoses there. One is life stage, reproductive phase, late menopause. Whether she is asymptomatic, symptomatic with all the 4 groups. Then you have a provisional diagnosis without the investigations when she has come to you. Just like your FIGO, you have palm coin, yes, no, question mark, isn't it? Are you all following that for your AUB? Yes. Yeah. So it's very interesting because it makes it very easy in your mind as to how to treat this woman, isn't it? So similarly, you have a provisional diagnosis that she is symptomatic with this disease, with latent factors or whatever, and which part of the menopause she is finding in. Weight becomes very important because if she is obese, we may go for transdermal and not the oral therapy. So weight is very important because you're also going to talk to her about the lifestyle. Then comes a final diagnosis when you have everything in place. So that's how we put it, and then you have the treatment plan. There are all the options, but MHT is the best. I'm going to rush through these slides. I think we're running short of time, I'm sure. So as you see in this, MHT gives the best results compared to all the non-hormonal therapies, which are little better than your placebo, slightly better than placebo. So only MHT is the one which is the gold standard actually for vasomotor symptoms. And so you have to do a risk-benefit analysis. These are the algorithms which are there, and this has been there in the guidelines from 2012. So the council then that I'm sure after the WHO, all of us have started talking about the rare risk, common risk, uncommon risk, very rare risk. So MHT generally falls into a rare risk. That means one person in a small town, that is out of 1,000 to 10,000 women, you give this medicine, maybe about 5 to 8 of them can have a problem. So it's much better than going out on the road and getting hit by something. So the risk is only as much as that. So that's how you can counsel it. So this is a very interesting slide because people are scared of breast cancer and hormone therapy. Breast cancer as such is on a rise, so we have to be careful about that. At least in the metropolis it's very high. I don't know about Nashik. Do you think the breast cancer is rising? And do you think we're finding them in a younger woman? We're finding them in 30s in Hyderabad, in 30s. And which is really very shocking. Yeah. And I had a teenager with a malignant, horrible breast cancer. Yeah. So we are having at a younger age, which we never used to find maybe 25 years ago in my younger days. Now you see overweight, you have in the red 24 more cases of breast cancer if somebody is obese, more than 30. But estrogen only therapy actually reduces by 4 cases. And combined therapy increases by 4 cases. So what is more dangerous, MHT or obesity? But do we ever talk about it? Everybody talks only about MHT and breast cancer. WHO also talks about breast cancer and MHT saying hormone therapy is cancerous. I think they have to do an about turn and get that off. They must say obesity is actually more cancerous, and that's more important for us to deal with. But exercise, at least 2.5 hours of moderate exercise, 7 fewer cases. So we have to be promoting that. And I think, of course, lifestyle has become quite a talk and people are taking care. So she has accepted MHT. Is diabetes a contraindication?
No.
Yeah. So when is it a contraindication? When there is an end organ damage. If there is an end organ damage, you're not going to give MHT. Otherwise, it's safe, it's under control. You can give MHT. And these are all the backup for that. And so once it is accepted, dyslipidemia, is it a contraindication?
No.
Yeah, when is it a contraindication? Yeah, when the triglycerides are more than 500, then you're not giving oral. It's not a total absolute contraindication. You're giving transdermal. And of course, you're going to put them on treatment then and there. So these are again the backup slides to say all the oral, the transdermal, everything helps. But the oral helps more. Oral increases the HDL much more. Oral reduces the LDL much more. It's not given over here, but oral also reduces the lipoprotein A. But the only thing oral does is it increases the triglycerides. Whereas the transdermal is neutral for everything. So it may not be beneficial for people who have got, high LDL and low HDL, which is very common in India. We find that for many of our women where the HDL is generally low and the LDL is high, and that is where the oral therapy is going to help. And this is what the long-term influence of different hormone therapy regimes on serum lipids and the shows. The the different ones, the oral, the transdermal, the blue is the tibolone and the control. Control nothing, at menopause transition, dyslipidemia sets in because of menopause, not because of aging. Because of deficient estrogen therapy, there is going to be dyslipidemia, very well proved in the SWAN study, so there is going to be dyslipidemia. To counteract that, you need a little bit of this estrogen. Oral estrogen helps the maximum, transdermal, okay. Tibolone also helps, but the only problem with tibolone is it reduces the HDL, but it increases decreases the LDL and the lipoprotein A. So on the whole, it is beneficial, even tibolone. The route of therapy depends upon what you want to do. So this is again the algorithm where you decide, rule out the contraindications, use with caution, and then decide what you have to give. And this is the WHI, which again, talks about the timing hypothesis. And so the prescribed in this case was ultra low dose tibolone or estrogen with progesterone or only estrogen. Because she has got a uterus, you have to give a progesterone. So the option. Do you think we can give tibolone in this particular woman? No. Why not? Yeah, you generally would not want to give tibolone in this woman because then she'll start getting erratic bleeding. Because it's got estrogen, progesterone, androgenic, and we don't have control over it. So you give it only 1 year after menopause. So tibolone is prescribed only 1 year after menopause. And so we have to give a progesterone, otherwise, unopposed estrogen can cause 1 in 100 cases of endometrial hyperplasias and cancers, 1 in 1,000 in postmenopausal women. So you have to give your estrogen therapy. How is it given? Very simple. Just remember three methods. There are n number of methods. Earlier on, they used to talk about long term and cyclical. But cyclical doesn't work because at menopause transition, whenever somebody has a symptom, it is every day of estrogen. And only last 14 days of progesterone, that is called continuous sequential regime. You say continuous because you're giving continuously every day your estrogen. Sequential because you're adding the progesterone only once in the last 14 days. Continuous combined is every day you're giving a fixed combination of the estrogen and progesterone, and that is given in the post-menopause. Just like tibolone, you're giving the continuous combined regime after 1 year after amenorrhea, whereas you're giving a sequential regime when the woman is still cycling and she needs the therapy. When there is no uterus, then you can give your estrogen. But even without the uterus, you need to give a progesterone in cases of endometriosis. You need to give when some ablative therapies have been done, because ablative therapies are generally done for hyperplasias, and you never know where you have missed in situ carcinoma or an atypical hyperplasias in those cases, and you may just by giving just the estrogen you may have a problem. So it's very, very important. Dydrogesterone protects endometrium. So the amount that is necessary is also given over here, and there have been studies, the success rate is, so that means it suppresses the estrogen with the dydrogesterone and the natural progesterone. Both of them are effective. So nowadays we are giving only 2 kinds of progesterone in the menopausal hormone therapy. One is the dydrogesterone and second is the progesterone. So we have moved away from the NETA, that is the testosterone molecules, and also the medroxyprogesterone which we were giving earlier. So these are the 2 regimes. So here you would like to give the continuous sequential regime is what we are going to give. And this is why we are going to do it. Uterus present or not, this I have already spoken about how we do it. So all the guidelines now say that for all women, hormone therapy or no hormone therapy, you are going to do the pre-hormone therapy risk assessment. Initial follow-up is first at 1 month just to see how she is doing, not at 3 months. And then for the 3 months, then after that it becomes yearly, because it's a long-term therapy. And every time you have to do the physical examination, you have to do the risk assessment and some basic tests again. Always discuss on the lifestyle. No indication for increased mammogram over and above what you're doing. So what are the protocols to do for your breast, for the cervical screening, for your diabetes, whatever, you continue with the same. Nothing special just because you're giving hormone therapy. Whatever is being done for that woman, you need to do it. So the tips on using, the best way to use hormone therapy is hysterectomy. You can use only tibolone, which has got, because though I've written hysterectomy, actually it means surgical menopause. That means you remove the ovaries. If you have removed the ovaries, Tibolone probably would act better. Only estrogen, progesterone, they will not feel very happy, most of them. Perimenopause, cyclical or the OCPs. That means people who are in the reproductive phase, there you need the therapy, either of the two. Early menopause, you give more estrogens. Later menopause, you are giving low estrogens. Post menopause, when there is decreased libido, again you can opt for Tibolone. Premature menopause, you can opt for OCPs that you have or the hormone therapy, both are acceptable. Urogenital atrophy, you don't need to give systematic therapy, you just give local therapy and that should be enough. And so this is the take. The option of MHT should be available to all recently menopausal women, and no woman has to suffer from menopause-related vasomotor symptoms. Each one of us should be either prescribing it or refer to somebody whom you feel is confident enough in prescribing the therapy. No woman needs to suffer from GSM. GSM anybody can write, even the general practitioner can write. As long as they have some idea about it, it's very, very important because it gives a lot of prevents all this recurrent UTIs, even prevents the pyelonephritis sometimes in the older people. Then it is appropriate for the prevention and treatment of menopause-related osteoporosis. I've really not touched osteoporosis, it's a big thing, and I think MHT is one good medication for this. And it does not cause breast cancer. The risk of DVT and stroke is very, very little, and we can detect it early and we can manage it. Even if 1 in 2000 somebody gets a problem, you don't have to worry about it. You detect it early and you treat it. You don't have to be scared because of that. So the conclusion is, yes, again the same thing. It's safe, it needs to be given the right woman, right age, right hormone therapy, right dose and right route, and of course the right doctor. It's very, very important. So thank you so much. Doing the same thing over and over again and expecting different results. This goes for hormone therapy.
Thank you very much, ma'am, for this wonderful, thorough explanation of management of menopause overall. So, by your talk, we understand that managing menopausal patients is way beyond just writing an estrogen prescription. Another thing, menopausal hormonal therapy is safe, provided the risk assessment is done thoroughly and correct drug is prescribed and holistic approach. So I thank you once again for your wonderful talk. For question and answer, we are running a little short of time. So we can have a few questions.
We can have the questions after the interview. I think that's better.
Yes, we can do that. Yeah. Yes. What holistic approach to give us an idea about endocrinological aspect of menopausal management. I invite Dr. Yashpal Gogate. He is a consultant endocrinologist, director at Harmony Health Super Speciality Clinic, Nashik. He is an author of book Clinical Grounds in Endocrinology, which is internationally published, and he also has numerous national and international publications. Welcome.
Good morning, everybody, and I would like to thank Nashik, Obstetrics and Gynaecological Society to give me this chance. And as Madam started that rhyming Gauri and Mayuri, similarly with bones, things are thin and strong. There's another rhyme that comes in, and everybody has heard about that is nothing but a funny bone. Do you know which is the most funniest bone? Probably it's the humerus. So jokes apart, let's shift to the diagnosis, or let's talk about osteoporosis, or the bones that we are going to talk about. So what is osteoporosis? So it is characterized by low bone mass, microarchitectural disruption, and increased skeletal fragility. Now, as can be seen in the two images over here, I can tell you that it can be very well visualized in a histological section. So A, B, C and D are histological sections of different people at different ages. So A is a histological section of the bone which shows a conspicuous presence of all the trabeculae that are can be seen. So in the A section, I think the trabeculae, they are seen in very proper rectangular or proper pattern. And as we progress in slides C and D, not only is there a loss of the trabeculae, but also there is a microarchitecture that is disturbed. So that's the characteristic definition of what osteoporosis is, and that's what we are going to pick up of osteoporosis when we talk about bone mineral density. So when we talk about bone mineral density, this is what we are looking at, and this is what we are picturing at. So how to diagnose clinically? What are the options that we have? So for that, I'm going to present 3 cases who actually are clinical round patients that I had seen in past few days. So this is the case 1. She is a 56-year-old female, no previous history of any disease. She has no diseases. Had a medical camp that was organized by a local seniors group that was there, and there she underwent some food test, and with that she was told that she has weak bones or osteoporosis. So with this, there are some questions that are raised. So first of all, what are the clinical manifestations of osteoporosis? What are the diagnostic modalities that are available to treat this particular osteoporosis? And is there any screening test that is available to treat this? So what are the clinical manifestations? Unfortunately, majority of patients are asymptomatic. So I think, as the earlier speaker said, that 50% of patients don't look at the osteoporosis or don't consult a doctor. I think it is important that we as physicians, at any point of time, if we come in contact with any patient who has particular high risk tendency, I think we should advise probably at least a screening tool, which we will talk about later on. Anybody with fragility fracture of spine, hip, wrist, humerus, rib and pelvis. These are the characteristic bones that are seen. Rest of the bone fractures, all of them are not fragility. If you fracture the finger bones, it's not fragility fracture, but characteristically spine, hip, wrist, humerus, rib and pelvis. Now what do you mean by fragility fracture? Fragility fracture means fracture caused by fall from less than that of a standing height. So if somebody's height is say about 5 feet 6 inches, so if the patient falls from the height that is less than this height, then that would label him to be a fragility fracture. In further, bone aches and pains are not the clinical manifestations of osteoporosis. They probably are an indicator of some underlying pathology that is associated with osteoporosis. The most common pathology that is associated with osteomalacia, that is vitamin D deficiency. But simply bone aches and pains, go and get a DEXA scan done, is not the characteristic or the right way to do. So what are the diagnostic modalities that are available? So there are multiple diagnostic modalities, but the commonly done is the dual energy X-ray absorptiometry, or commonly known as the DEXA test. So how it is just like a orthopedic table. So I think the patient is lying over there, you have a C-arm radiating the X-rays, and then it is compared with by a algorithmic formula to a T-score value and a Z-score value of different individuals. So what are those values? First question comes is radiation exposure. So each time if I give my patient to a DEXA scan, do I submit him to a high amount of radiation exposure? No. So radiation exposure is very small and it is similar to that of the background magnitude of daily background radiation. What does DEXA measure? It measures the actual aerial BMD. If you want to really measure in clinical scenarios where we use the QCT, that is the characteristic measurement, but for majority clinical ground measurements, I think DEXA is more than enough. It measures the aerial BMD in that particular area. Based on this BMD value, you calculate what we call it as a T-score. So now what exactly T-score is? T-score is simply comparing the bone density that you have to a person who is same or younger age as compared to you. So a bone density yours is compared to a young patient who is a younger age healthy female. Sorry, not patient, but a younger age healthy person. Whereas Z-score is something that is with age, ethnicity and sex match difference. So T-score is a young female if we compare the bone density, whereas for Z-score we compare with elderly female. Skeletal sites where DEXA is done is just lumbar and both hip. In particular, if you really want to save the patient's money, do you know which bone is commonly fractured? Yeah, hip bone is one of the most commonly fractured, but which side, right or left?
Right side.
So it's exactly opposite. In the right-handed individual, it's the left bone, and in the left-handed individual, it's the right bone. So if you really want to restrict doing, because DEXA is very costly test, so if you really want to do a really strong test in the right-sided patient, I think just go for the left-sided. If at all one test you have to do, because they charge based on per test. So in particular, if you do just one test, that's more than enough. So this gives a small indicator how we can differentiate. So T-score, we can differentiate based on osteopenia, osteoporosis, and something about severity. So this is the classical DEXA report. Now I think you can see over here the T-score values are written, the Z-score values are written. So this is reports I think everybody would have seen at least once. So how do you interpret these reports? So T-score that is greater than or equal to -1. So anything that is more than -1. So in short, if you have a bone density that is comparable to a young person, you are normal. If it is -1 to -2.5 times less, that is lesser standard deviation, it is osteopenia, and less than -2.5, I think you are talking at osteoporosis. So what do you come to this female? So what did she undergo, or which test did she go? So I think most importantly, did she really do a DEXA scan?
No.
No. So that test that was performed was based on a ultrasonographic method that calculates the heel or calcaneum ultrasound based method. This is not at all a good test, as it tends to over or underestimate. And more importantly, you need to realize calcaneum is rarely fractured in osteoporotic patients. There is no point in I think that's why it's called as the Achilles heel. You would have heard the story about it. Alright, so it's a very rarely fractured bone. So it's not a good indicator of osteoporosis. And more importantly, lots of patients tend to have calcaneal spur. They also tend to have lots of other soft tissue depositions because of the obesity and other reasons that can be there, which can actually underestimate or overestimate the association. So heel ultrasound, if anybody is doing, I think you need to tell them, फोकट में कुछ नहीं मिलता. There is something actually there in फोकट. So what is that? It's the Frax tool. So Frax tool, and it's a very easy test. It's a downloaded app as well. It has a classical India specific data. You don't need to do any imaging study. Now this is the example. So you can even search Frax score and you directly get the access. You also have it in the form. Now, unfortunately, this country, instead of UK, you will have to go for India. But there are questions that you can put, and you don't need to actually put the BMD value. So you just need to tick questions. If the patient has previous history of fracture, if there is a parent fracture history, and that actually estimates your probability of major osteoporotic fracture. So if it is more than 3% and more than 20% for hip fracture, the patient has high probability. And this is so simple that even patients can do in your OPD when they are waiting outside in the OPD chamber. So it's that easier test that will actually guide you, and it's completely free. So coming to the second case. So this is a 47-year-old female who sustained a fragility fracture where she slipped in her bathroom and fractured her forearm. So she was advised to undergo DEXA scan. The DEXA readings were hip -2.9, Z score -2.5, L1, L4 it was -1.8 and -1.3. So now this is always the question that is there, because somewhere, now you can see over here, the hip is telling you osteoporosis and L1 to L4 is telling you osteopenia, and you are confused. That's the common question. So what do? So the diagnosis is, or the guidelines are very clear. The lowest T-score of all sides is used to be considered a diagnosis. So to make a diagnosis, look at the lowest T-score whichever you can find. So in this case, I think the hip score was the lowest, and that made a diagnosis of osteoporosis very simple. In her case, the fragility fracture itself was a diagnostic tool. So you don't even need to go for a DEXA scan to make a diagnosis, because fragility fracture itself is an indication. And surprisingly, India, now we are talking about mostly female population, but India is one of the few nations where actually men fracture equal to that of women. So that's an important finding that has been associated, found especially in the Indian setup that is there. So an importance of Z score.
Reason behind?
Probably genetics, because there was one study by Marwa et al. Which showed that army jawans who were referred to the RNR army hospital, who were young individuals, they actually had BMD values that were lower as compared to healthy American females. So I'm talking about healthy jawans. their BMD values were comparatively lesser as compared to, so probably your genetics. So that's why we are devising a more India-specific BMD values. So that will help us to guideline. Second probable contributor probably is protein intake, associated calcium intake, and can contribute to that. So that's an important point. So importance of Z score. Now you can see over here, even the Z score in this case is low. So Z score is of the same age-matched individual. So if Z score is low, that means you are looking at secondary causes of osteoporosis, and this needs a detailed evaluation. So what are the minimal investigations that are needed? A complete blood count to rule out majority hematological malignancies, TFT to rule out especially hyperthyroid or thyrotoxicosis related conditions, calcium, phosphorus, alkaline phosphatase, vitamin D3 and PTH. A PTH I would like to note over here is, and same with calcium, calcium assays are very specific. Unfortunately, I have a collection of different lab reports that are there in Nashik, and majority show calcium that is on lower side. Please don't take it in the right value because those values are wrong. Right. Same is with PTH, because PTH has to be collected in the proper manner. It has to be sampled, it has to be kept refrigerated or treated at probably -20 degrees, and so make sure that PTH is collected in the right way. Similarly, I have reports where PTH came with 1 today, 50 tomorrow and 200 the day after. So 200 was the right value, but unfortunately the patient was referred because PTH was less than 1. So renal function test is important, creatinine is an important parameter, liver function test, case-based workup, wherever you need FSH, prolactin, celiac workup is necessary, you need to look at it. So in this patient, so classically she had osteoporosis, we have to look at the lowest P score value. Coming to the third case and the final case. So this 55-year-old female, no previous history of any medical disease. She went to the for a medical workup, because that's now a common thing that you go for. Just like as you go for Ashadi and similarly every once a year, I think you go for the best medical checkup that you can go for. And there she got these reports. So DEXA scan was done, and she has no history, she has no other associations. And what do? So she is classically osteoporotic. So blood work was done and found to have no causes. Vitamin D3 was low. Everything else was absolutely normal. So first question comes to mind is, are calcium and vitamin D3 enough to treat osteoporosis? Which is the best form of calcium, and whom do we treat further for osteoporosis? So because of short of time, we will be slightly running ahead. So calcium and vitamin D3 supplementation. So adequate, when do we say adequate? 1200 milligrams per day from diet. No need to add an additional calcium. So I think my job was made easier by the one of the previous speakers. I think they have introduced a menopausal kit where you can ask your patient to go and put in their calcium values, and you actually get a values that menopausal kit. So that's an interesting thing. But overall 1200 milligram per day. So milk, ragi, rajma, beans, gobi, full and patta both. Almonds are good sources of calcium. Same is with non-vegetarian sources of food. But always remember this, and it's important. Food consumption is associated with increased consumption of calories. So that's the reason why we supplement our patients with calcium. Because food consumption itself is associated with increased consumption of calories. So ragi is a very good source of calcium, but ragi also has a comparatively, and that's a misconception everybody has, it's not a low glycemic index grain. Alright, so it's not a low glycemic index grain. Okay. So wheat and ragi stand head to head. There's no difference between both of them. And as per available data, majority of Indian women, they lack adequate calcium in their diet, and that's why they need supplementation. So there are some questions that are there. So is calcium supplementation associated with increased cardiovascular disease? The question is yes as well as no. Because there is no definite trial that will tell you. Because majority European data where the consumption of dairy as well as consumption of overall meat-based products is significantly high, show a very high risk of association with cardiovascular disease. Whereas a little bit of Asian data that is coming, where comparatively we are basically carbohydrate eaters, not that much dairy is there but not that much, and comparatively not that much amount of meat, there doesn't seem to be an association. So at the moment, is data associated? So at the moment, you can tell your patient to take the best benefits of both. So I think calcium adequate, that is 1200 milligrams should be provided. and you should not stop telling the patients that you have got a cardiovascular disease, stop taking calcium. So at the moment the answer is still no. So again the second question, is this associated with increased risk of nephrolithiasis? So dietary calcium is not associated. Pharmacological calcium probably is associated with a slightly increased risk, but again the increased risk is negligible when you compare it to its bone health benefits. So that's why stop telling our patients that calcium causes increased renal stone disease. So that's something that is not completely unfounded. So which calcium can you go for? So these are the calciums that are available. So think of that which is there. So calcium carbonate is the most cost effective. Why? Because it provides the highest amount of calcium per gram of amount. So it's the least expensive, and even probably a one tablet of calcium carbonate and a overall added oral intake can take care. Calcium citrate is expensive, but it has least GI adverse effects. So if you really have GI adverse effects, but if you look at the calcium value, so calcium citrate just provides 210 milligrams. So you need to take maybe 2 or 3 tablets of calcium citrate. So that's a trade-off that patient has to do. So based on that, this was specifically I have mentioned the brands because to exactly know that what actual content is there in each brand, and these are the commonly used brands. I don't promote any brand, this was just for your knowledge. So is supplementation with vitamin D3 and calcium enough? No. Patient with osteoporosis definitely need calcium and vitamin D3, but in addition they need treatment for osteoporosis. So who all need to be treated further for osteoporosis? All with a single fragility fracture need to be treated. All with T-score less than -2.5 need to be treated, and those with T-score between in the osteopenic range, that is between -1 to -2.5, and having a high fracture risk as per FRAC score, they definitely need to be treated. So what are the treatment options that are available? I wouldn't go much in detail, but just to mention, so there is something called as initial therapy and something called as patients who are at high risk. So why I am dividing it? Because there are two kinds of bone cells that are present. One is the osteoclast bone cells and the other is the osteoblast bone cells. So why we have to divide it? Because the treatment availability that is there are 2 points of treatment. One is one that stop the bone resorption. So bone damage is stopped. So it's just like pressing a pause button in the song that is going on. Whereas there are few treatments that are bone forming treatments that are called as anabolic treatments. So it's like playing a differently new tune and formation of a new bone. So there are 2 different treatments that are options. So initial therapy in absolutely asymptomatic patient just with T-score that is less, the treatment would change. But in high risk patients, who are high risk patients? Patients with fragility fractures, patients with very low T-scores, that is -4, -3.5, with secondary causes of osteoporosis after you have treated the secondary causes. In such group of patients, the treatment would differ. So initial therapy would be bisphosphonates in patients who are asymptomatic, who do not have any associated risk. Oral and injectable therapies are options are available. Oral, I think all of you know bisphosphonates that are there, alendronate, isodronate that are there. Injectable we have ibandronate as well as zoledronic acid, but I think it's the usage per se, it's mostly based to oral. So I think, do you use bisphosphonates actually in your practice? So just a question that.
No.
Yeah, so some of you use oral bisphosphonates. So there's something that I think all of us know that it causes reflux esophagitis. So that's why it has to be given in the morning. But a simple treatment for that, or a sideline treatment that you can use is zoledronic acid. Zoledronic acid is cost effective, can be given once a year, that can be easily used. The only associated risk with it is atrial fibrillation, but that too very rare association with it. Otherwise, it's a very good alternative if the patient doesn't want to take it on a regular basis. So once a year, and for how long do you give? So ideally there's no recommendation for that. So normally what do I practice in I follow in my clinical practice settings, and that's what there's a consensus guidelines that come out around when people talk about it. So you can give the treatment for 3 years, and after that you wait. What do you wait for? For the patient to fracture his bone. So you hope the best for the patient, but still, if at all the patient fractures, then you need to do something else, or you need to add on a different therapy. So in high risk patient, teriparatide, which is to be used daily, it can be given subcutaneously or denosumab. Denosumab and teriparatide, both of them are high cost-based therapies, whereas the bisphosphonates are comparatively cheaper therapy alternatives that are there. Teriparatide needs to be taken subcutaneously just as you take insulins. Denosumab also can be taken subcutaneously. Denosumab needs to be given every 6 monthly, whereas teriparatide needs to be given every day, daily that the patient needs to take. So how do you monitor such patients? So conduct EMD every 2 years. Now I have seen few patients they are doing EMD every 6 monthly. That's not going to tell you. Even after 2 years, lots of patients they expect that their -4 score is going to become suddenly -1. That doesn't happen. So what we are looking at, we don't want worsening, or we just want stability of the T score. So even stability of T score, it is achieved, that's more than enough. If the betterment is there, significantly that's good, but stability of T score is what we are trying to achieve, and we are not looking for betterment. Bone tumor markers, but it's very costly deal, and there are few indications, but that's only for particular super specialists where we need to look at some therapy that's not managing or refractory therapy. But routinely, I think DMD every 2 years is something that you can do. Coming to the non-pharmacological measures later, because that's what we will be ending our topic with. So smoking cessation, I think I would like to highlight over here, I think all of you would agree, somehow men have stopped smoking but women have taken it up. I think so that doesn't qualify a symbol of gender equality. I need to tell that smoking cessation needs to be stopped. It's not good, including hookahs, everything that contains tobacco probably needs to be stopped as much as possible. Protein consumption, taking about 1 gram per kilogram of protein per day is something that would be reliable. Majority Indian data shows that we don't consume that much amount of proteins. Please stop telling your patients with high uric acid, stop eating dal, no, that's not the right way. So absolutely, it also comes from the physicians and it comes from everywhere. Alright, so uric acid or hyperuricemia is a marker of metabolic syndrome. That hyperuricemia is just a sign of malnutrition but in the wrong direction. That is excessive nutrition. So you need to mention about it that don't stop protein intake. Yes, you can restrict the consumption of animal protein based products partly, but veg protein based products the patient can easily continue. Strength training versus cardio, there is little evidence that says probably strength training, but strength training has an advantage because it provides muscle stability and it prevents sarcopenia, as earlier speaker ma'am was telling about SARC-F score that we do, and sarcopenia is something that we need to talk about. So strength training provides it, and cardio exercises also are equivalently beneficial, but 30 minutes is enough. And with this, thank you for your patient listening. Thank you very much.
I'd like to felicitate you with a small token. Andrologist, kidney transplant surgeon, and consultant urologist practicing since last 12 years. He has got gold medal in his pocket in general surgery from Pune University, and he has a very interesting record, which is he has done maximum 15 surgeries in 5 years only. So he will be talking about urinary incontinence and all the urogynecological symptoms.
At the outset, let me thank you, President Ma'am and Secretary Ma'am, for this lovely opportunity. So next 15 minutes or so, we will be discussing incontinence in females, especially the stress incontinence. We'll be talking about what are the various types of incontinence, the philosophy behind it, and thus the treatment and outcome behind it. So, the details of definition, everybody knows about it. What are the types of incontinence? I think this is important slide. So this genuine stress incontinence, urge incontinence, there is one entity called as mixed incontinence, and this is very important. There is one rare thing is chronic retention of urine and leading to overflow incontinence. There are various reasons for functional incontinence and all. But we will stress upon the stress incontinence, urge incontinence and mixed incontinence. So what are the types? As I said, you can see the prevalence or incidence is 30% each almost. I mean the stress incontinence is around 30, the urge is 30 and mixed is also 30. So these types are important as far as your treatment and outcome is concerned. So what is stress incontinence? It's a complaint, involuntary leakage of urine on the effort of exertion or sneezing, or whenever there is increase in the intra-abdominal pressure, for whatever mean, the patient would leak. Most common, say less than 70 years of age. Two things I would like to highlight over here is why this occurs. I'll let you know in detail, but first there is two things are there. One is hypermobility of the urethra, and the second is intrinsic sphincter deficiency. I'll tell you in detail, but in 80% of the cases there is hypermobility of the urethra, and in 20% of the cases there is intrinsic sphincter deficiency. These two things are important. I'm stressing. The reason is, again, it is important as far as your treatment and outcome is concerned. So what is intrinsic sphincter deficiency? So there is a deficiency in the sphincter. There is no weakening of the the supports of the urethra or supports of the vagina. They are all normal, but in de novo there is intrinsic sphincter deficiency, and there are various causes. This is again a entity called as urge incontinence, and this is again important one. This is loss of urine due to an involuntary bladder spasm or contraction. It is complaint of sudden urgency, frequency, and patient would tell you, doctor, I leak before I reach the bathroom. So as far as stress and urge is concerned, it is very easy to discern between the two in the history itself. You don't have to go for any fancy test, to differentiate between the two. You ask your patient, when patient comes to you with a urine leak, you ask her, you are leaking with any efforts, like with coughing and sneezing? Okay, yes. Along with that, you need to ask her whether there is any urgency or urge incontinence, sudden desire to void, So you can differentiate in history part itself. As I said, there is 30% of the cases there is mixed incontinence, and this entity is very important. So when a patient comes to you with a stress incontinence, the patient would tell you, doctor, I leak urine while sneezing and coughing. But along with that, you just go there in the direction of stress incontinence. Along with that, you need to ask whether there is urge or urge incontinence along with the stress incontinence. Now, how do you quantify it? I always ask my patient, which are the predominant symptoms? Whether the urge incontinence is predominant or stress incontinence is predominant. If my patient says, hey doctor, my stress incontinence, that is actually bothering me, urge and urgency incontinence is not that bothersome, in that case, I would ignore the urgency part and I'll focus my treatment on the stress incontinence. That is the reason this mixed incontinence is important. If the patient says, "No, doctor, my urgency part and urge incontinence, that is what is bothering me. Stress incontinence, my quantity of leakage is very small, and once in a while it leaks. So I would ignore the stress incontinence part, or rather I would subject it to the non-surgical treatment. So that is the reason this entity is important. As I said, you can differentiate between the two, the stress or the urge, in the history itself. You don't have to go for any test. So what are the causes of stress? And you all know the external factors. These are important, like pregnancy, childbirth, aging, and hormonal. All these things are there. As far as parity is concerned, number of deliveries are concerned, Previously we used to say, number of deliveries, the chance, the risk of future incontinence in that female would be more. It is not so. A first pregnancy is the risk factor for future incontinence and not the number of parity. So this we need to think about. Before we move on, we need to go through our anatomical pictures. We all know, bladder and the urethra and vagina is going through, and they are supported by the levator ani. Same thing. You can see the urethra, which the vagina is supporting the urethra, and the urethra is attached, and the vagina is attached to the levator ani with this musculofacial attachments. And these are the attachments. These are the culprits. If there is a weakening in these attachments, these are the culprits for stress incontinence. So the urethra is supported, and the main thing is urethra is supported by vagina. And the main culprit for the pathophysiology behind stress incontinence is there is a weakening of supports of vagina. So where is the culprit? Where is the pathology? Vaginal supports and not the urethra. So it's like hanging bridge, cable bridge. So these are supports of vagina. So anteriorly, the vagina is supported by the fibers coming from the pubic, pubovaginal ligaments and all. As I said, laterally the anterior vaginal wall is attached to the levator ani with the musculofacial attachments. So these two attachments are important. Anything wrong in these attachments would lead to stress incontinence. So that's what I mean. Laterally, the vagina is attached to the levator ani pole. So during whatever the causes are there of the stress incontinence, that would actually peel off this vaginal wall from the levator ani. And that would lead to sagging of vagina. There is loss of support to the urethra, and this would lead to stress incontinence. So there are plethora of theories behind SUI, stress urinary incontinence, but the common theories or the popular theories are hammock theory and integral theory. So we would stick to the hammock theory. Again, you can see this vagina, and that vagina is supporting the urethra. Okay, you can see that the urethra is there and it is resting on the anterior vaginal wall. The anterior vaginal wall has got various supports anteriorly and laterally, as we discussed. So this is the theory. What is happening in normal females? So whenever there is increase in intra-abdominal pressure, the pressure would get transmitted to the urethra. Urethra has a backing of vaginal wall, it's like hammock, and it gets compressed on the vaginal wall, and that is how the urinary incontinence is prevented in a normal female. The intra-abdominal pressure is getting transmitted on the urethra. Urethra is getting compressed over the anterior vaginal wall, and that is how the urine leak is not there. So whenever this hammock or this backboard, there is weakening, by whatever reason the weakening is there, that would lead to incontinence, stress incontinence. So if you know this slide, it is very simple to understand and very simple to understand the treatment and outcome of this stress incontinence. Patient evaluation, everything. As I said, you can evaluate, you can discern stress and urge and mixed in history itself. Post-void residue is important if you are contemplating the surgery in a patient with stress urinary incontinence. The reason being, if the patient is retaining more urine, post-void urine, in that case you need to evaluate the urethra, whether this urethral obstruction is there or not. So if it is not so, you can directly go for the surgery. So that's why post-void residue is important as far as your evaluation is concerned. As I said, storage symptom. Bladder has got two functions, storage and voiding. Right now we are sitting over here, right now our bladder is storing the urine. Right? Bladder is calm, it is whatever the urine is coming from the kidney, it is getting accumulated in the bladder. So there is no contraction in the bladder is very relaxed. So those patients in whom whenever there is, by whatever reason, there is sudden contraction when the bladder is storing the urine, patient would have sudden urge to pass the urine. And that is the reason for this urge urinary incontinence. So you need to ask whether there is frequency, urgency or urge incontinence. There is not. Voiding symptoms, you need to ask how is the voiding, how is the flow. If the patient says my flow is very poor, I am not able to pass the urine properly, you need to evaluate further. Physical examination of, again this is simple test, but this is very important. This would give me a variety of information. Standing, you can do it in standing or supine position, but one thing is the patient need to have enough urine in the bladder. Often the patient comes to you're consulting with an empty bladder and you ask her to go for the cuff test and the result would be negative. Okay, so ask her to drink enough water. The bladder has to be, half full actually. So that is important for this test is concerned. Again, one more test, the important thing in this test is, you need to see, of course, whether urine leak is there or not, but along with that, you need to see whether the urethra is descending down or not. Okay, this is what I mean when I say hypermobility of the urethra. Okay, because that is important while choosing the treatment. So you will often see, in 80% of the cases, the urethra actually moves down and then there is leakage of the urine. So this is actually urethral hypermobility. If the patient is leaking without hypermobility, first thing that is intrinsic sphincter deficiency. Okay, again, that's the reason I am saying this is a simple clinical test, but you need to look for this, whether the urethra is descending down or not. If I see the patient with the urethral hypermobility, my treatment is simple. Okay, the outcome is good enough. So that's why I say this simple test is very important. Q-tip test, it has got academic interest. Q-tip test is again to know the hypermobility of the urethra, but nobody does it nowadays. Pelvic muscle assessment. This is important because if the symptoms are mild one, I am going to advise the pelvic floor muscle training. So this is actually important when you go for the evaluation of stress incontinence. So you need to see whether a patient is able to contract the muscles or not. How much is the strength and how much is the duration. I have seen, 1/3 of the patients, they are not able to locate the pelvic muscles. When you ask them to contract, 1/3 of them are not able to contract it. If that is the case, in that case, don't contemplate, conservative treatment. I would ask her to go for surgical one. I would skip this voiding diary. What is the role of urodynamic? Whenever the patient comes with the urinary incontinence, especially the stress incontinence, if you are contemplating surgery in her, then you will go for, chalo, let's go for urodynamic. You need to go for urodynamic. Is it required in each and every patient? The answer is big no. It is not required. So in which cases it is required? Say if the patient is saying, doctor, I have urinary leakage with the stress incontinence and on physical examination you are not able to demonstrate it. In that case, I would go for the urodynamic evaluation. Any patient coming to me for the redo surgery, failed surgery, I would go for urodynamic test. So it is not required in each and every patient.
So sorry sir, last 2 minutes.
Sorry?
Last 2 minutes.
Yeah. Treatment options. I won't go in behavior and pharmacological, everybody knows about it. We'll directly go to the exercise part. We often say Kegel's exercise. Actually, don't say Kegel's exercise. It's a very small word, Kegel's. You need to say pelvic floor muscle training. Because you need to train each and every muscle of the pelvis. It's not just Kegel. Kegel's is there just for, sphincteric this thing. So, always say Kegel's exercise. PFM. What are the surgical options? Okay, mid urethral slings are there, pubovaginal sling is there, and Burch Olper suspension. There are various other plethora of treatments, surgical options are there, but nowadays we are doing either DVT, TOT or Birch Calper suspension. So this is a slide for TVT. So what, I'm not going to go in detail because of time constraint and all. That in TVT, what are we doing? Again, as I said, if you know the pathophysiology, you'll get to know the treatment. You just have to give the backbone for the urethra. So, but whatever mean, whether you give it by TVT or TVT, you just have to give, you don't have to, pull the urethra up. You just give a backbone to the urethra, so whenever there is increase in the abdominal pressure, it would get co-opted during that pressure. So, give it by either with TVT or TOT. Just we are giving a backbone to the urethra. So, this is TOT. In TVT, actually it is going perpendicular. In TOT, it is almost parallel or horizontal. So these are needles for TOT. Everybody knows about it. So the difference between TOT and TVT, as I said, the needles are coming from behind the pubis, but they are perpendicular. So they are coming actually at the suprapubic area. Okay. And as far as TOT is concerned, it is 2 centimeter. The incision side is 2 centimeter lateral to the clitoris. Okay. So because it's a horizontal one. The same one. Coming to the Birch Calper suspension. I think this is anatomical repair. And if somebody asks me, sir, what is the gold standard for the treatment, or whether you go for TOT, TVT or Birch, I would say there is no gold standard as such. But if someone asks me to choose between the sling surgeries and this Calper suspension, I would go for the Birch one. I'll tell you why. And you all know, the anterior vaginal, as I said, there is loosening, and the support of vaginas are loose. You need to stretch it up for the backbone. So that is the reason the vagina on either side of the urethra is pulled up to the Cooper's ligament, either with the 2 stitches on either side or 4 stitches. If the space is there, you can put 4 stitches. But what are the results? You often ask, as I said, the results are equal. You go for TVT, TOT, Birch or whatever, the results or outcome are equal. Okay? But as I said, long-term outcome, the Birch fares better than the others. So if someone asks, the athlete or gold standard guy, I would say Birch. And Birch I would again go for, if someone is contemplating abdominal surgery and along with that the stress incontinent, people often call me for, sir, I'll first go for abdominal surgery and then you can, and then you do the TOT and all. In that case, I would suggest, don't go for TOT. If you're contemplating abdominal surgery, I would come there and I'll go for the Birch Calper suspension. What are the complications? If the sling is too tight, patient can have obstructive urinary symptoms. If the sling is too loose, the results are 0. And dreaded complication, which is there in less than 1% of the patient, is erosion of the tape. So this erosion can be inside the urethra, we call it as an intrusion, or it could be on the vaginal side, it could be called as extrusion of the tape. If there is intrusion of the tape, you need to remove the tape. If there is extrusion, you can manage it conservatively for a few days. If it is not, then in that case, you need to remove it. There is growing concern in the Western world regarding mesh in the body, especially in the vagina and in the pelvic region. As a subject of debate, it's a subject of legal lawsuits, and the reason behind it is, if you go on the FDA, this thing, it's the last slide. If you go on the FDA website, they have written it. If you are using mesh for pelvic organ prolapse, it is mentioned under high risk category. If you are using tape for urinary incontinence, it is mentioned under low risk category. So because of this high risk category, because of this media hype and all, the lawsuit has started coming against the urologist and the gynecologist who are doing stress incontinence surgeries. So the world is shifting. Probably in the future we might have to go away with the mesh, and we'll have to go for the anatomical repair. So those professors who are sitting over here, I have a request that you need to train your trainees with both, the anatomical repair and of course the TOT and TET. So make sure your patient understand that it might have to be tightened, the mesh might have to be tightened, might have to be loosened, or you might have to replace it. Okay? And of course there is no guarantee. Thank you, Energies.
Dr. Mayuri Kelkar, who please felicitate. She is a senior consultant gynecologist and obstetrician from Nashik, practicing since last 35 years, an academician and dynamic practitioner. She has been chief scientific coordinator for many conferences. With her, I would like to invite Dr. Meeta Singh ma'am on the stage. So this session probably would clear all the doubts which are there in your mind. A question answer session. So if you have any doubts or any questions, just be ready with it.
What I would like to start with is the few things that we have to be very clear about is that MHT, that is Menopausal Hormonal Therapy, is the new word that is coined instead of what we used to call as hormone replacement therapy. So we call it as MHT now. So we had a lot of concerns about that, but over a period of time now, we can, if we have done the proper workup and if all the contraindications are looked into, we can safely give a patient who has no comorbidities, who has no risk, and who doesn't smoke and lifestyle disorders like smoking or alcohol, we can safely give them up to 10 years of menopause and up to 60 years of age without losing our sleep over it. That's one. Second is that, as Madam has rightly pointed out, that menopausal hot flashes and symptoms come even 10 years later. So if she has gone into menopause by 55, she might have the hot flashes till 65. So do we stop the treatment at 60? No. Like Madam has already said, that we have to re-evaluate her, and if all her scores are low, we can continue the treatment after proper counseling and telling her that she has an increased risk of stroke and cardiovascular problems and coagulation problems after 60, and after taking her consent and writing it down, we can still do that. Am I right? Yes. And the third thing is that duration. As short as period of time for relieving her symptoms. In fact, I would say that you start thinking of withdrawing the day you start the MHT. That's the shortest period of time. Alright? So that's the third thing I would say. And in addition to whatever contraindication like the breast cancer risk of less than 5 or the cardiovascular risk of less than 10%, ma'am, would you say any strict contraindications where you would not give irrespective of the symptoms?
Yeah, I think there are very clear contraindications. There are many, you divide your contraindications into absolute. And then you have the relative contraindications. So there was one slide which I put up as low risk, high risk, intermediate risk and high risk. So the high risk group is, when you read the literature, commonly what you will find is an active liver disease, estrogen dependent cancers anywhere in the body, and coincidentally all this meningioma, glioma, that also falls into the absolute contraindication. Another is active thromboembolism episode. So earlier, past history of thromboembolism was a total contraindication, but now it has now graduated into an relative contraindication, because you can give the transdermal in those people whom you feel always any medication, not because you want to give it. It's only when you feel that the benefits are far better than any risk involved, only then you're going to give it. But I think the contraindications which in day-to-day practice, which are very important to understand, is presence of a cardiovascular disease itself. So somebody is having a established cardiovascular disease or at a high risk of breast cancer. Because high risk of breast cancer may become a relative contraindication in the coming years when we have some more information on the type of breast cancer this particular woman maybe is destined to get. If you have that kind of information, estrogen positive, estrogen negative, receptor negative patients, if you are able to classify, maybe things are going to change. But as of today, to be safer side, I think for the general practitioner, high risk of breast cancer, cardiovascular disease, and don't get the hormone therapy, you go for alternatives. It's safer.
Okay, so now that we have ruled out all the contraindications and that we have ruled out all the risk factors and our patient is symptomatic for menopausal symptoms, and we have decided to start her on a therapy. So we are going to start her obviously on estrogens. So let's talk about estrogens first. So between 17-alpha estradiol and ethinyl estradiol and conjugated estrogen, which would be your drug of choice?
Yeah, we are at menopause. There is no role for synthetic estrogens. That means you are not going to give the estrogen, ethinyl estradiol, which are used in oral contraceptive pills, which we are giving for the younger generation. Absolutely no role. So you are not going to prescribe it at all. Because once upon a time, 25 years ago, we never had the different kinds of hormone therapies which were available to us. So people were writing at that time and were thinking that probably they're cheaper and that is why we are giving it. But it has no role now. Because we know that they can cause problems. If you're giving, like I said, the potency. That is the reason why you have to understand the potency. So it's only 17 beta estradiol or conjugated equine estrogen is what you have to give.
Any concerns about conjugated equine estrogens?
Yeah, I think conjugated equine estrogen is one of the most potent medications that we have, so I still very fond of it. When you have severe vasomotor symptoms, works very well. But we know the WHI, because of the WHI, it has taken a little backstep. But we know that even in the WHI, estrogen alone, if you are giving only conjugated equine estrogen, the breast cancer risk was lower. So it's not totally off the market, we can still use it. So I don't think, except for those women where, in fact it is very good even if you want to raise the HDL, lower the LDL. But there you are not going to give it if somebody's got hypertension, uncontrolled hypertension, because it's acting through the liver. So thromboembolism, so all these related contraindications more for conjugated equine estrogen compared to the 17 beta estrogen.
So there are no concerns so far as conjugated equine estrogens are concerned, so far as the equine proteins or hepatic problems are concerned?
Correct. Because it has really withstood the time, It's like 50 years since we have been used, and the benefits outdo any risks involved, and we know what are the risks. We know that it can increase all those proteins from the liver, so and increase the sex hormone binding globulin, which is good. But then it also increases those other proteins which may have an effect on your thromboembolism, which may have an effect on hypertension, uncontrolled hypertension. So those are the areas where we have to be careful, the triglycerides. So these three I think are the ones which we need to be careful.
Yes, this was discussed because there were a lot of papers on conjugated equine estrogens which are supposed to have some foreign equine proteins which are not good for our body, and the second thing is that the CEE also had long-term hepatic effects. There were 2-3 papers, so we are cleared about this, that this no longer holds true. And why we don't use ethinyl estradiol, because it is 700 to 1000 times more potent than your 17 beta estradiol, and 17 beta estradiol is the nearest to our natural estrogens, nearest to them. Now, one more thing we would like to say is, what are the beneficial effects of estrogen on the lipid profile? Is it low? Yeah, HDL and LDL. But remember, it increases your triglycerides. And what are the other effects when we are practicing and we are using estrogens? We have to look at the other effects that the estrogen has, especially the oral estrogens, because the oral estrogens will go through the liver first. So the first pass effect, because of which what all things can happen, is what we are concerned about. So the first thing that the oral would do is that it would increase the clotting, thrombogenicity, Second, it will go through the induce hepatic enzymes. Therefore, if your patient is on thyroid, it will increase the thyroid binding globulin. Therefore, your requirements of thyroid will be more because your free levels will be lesser. Similarly, it will increase the binding of cortisol binding globulin. So, if your patient is on cortisol therapy and you are doing the cortisol levels, you may get a falsely high level because of this increased binding globulin for cortisol. And the third thing you remember about estrogen is that it all good effects, but it increases the testosterone binding globulin. So the available testosterone will be low, so it is negative against libido. So all those things which we are doing for our post-menopausal women, it will bring down the libido. This is what I wanted to impress upon. That think about this. The libido is the main problem. The estrogen will bring down the libido. So now we come to the next thing. We have decided that we are going to use either CEE or we are going to use 17-beta estrogen.
Can I add one or two more points for that lower? Yeah, so very rightly said. So whenever somebody comes with a sexual dysfunction and low libido, you're not going to keep the oral therapy. That is where the transdermal therapy is preferable because of the explanation what Dr. Ujwala has very rightly given. It's so like I was talking about hypertension, no? The same thing happens. The angiotensin-renin system, so that gets altered, and that is why that sometimes some people can have an unusual reaction for conjugated equine estrogen. Not everybody. 17-beta estradiol, in fact, is supposed to be lowering the blood pressure in some of the studies that they've shown, especially when given with a combination of drospirenone and even dydrogesterone. They have shown that there is a little slight drop in your systolic blood pressure. And third, very rightly said, the thyroglobin, because of that your excess. So similarly, even the cortisol and even your hypoglycemic agents, somebody is a diabetic, the requirement may slightly increase. But also it reduces the oral therapy, reduces the insulin sensitivity. So that advantage is not there with the transdermal. So you understand when I was talking about in the morning, you have to tailor. Each woman is different. So here for a libido, you're going for a transdermal. But if somebody is a diabetic, early diabetes or pre-diabetic, you would prefer a transdermal or an oral? Oral. You would prefer an oral. But if she is an established diabetes with with obesity and with metabolic risk factors, same diabetic profile. But what would you prefer? You would prefer a transdermal. So that's why you have to really understand the basic physiology before you prescribe.
And another thing is we see a lot of epileptic patients in our practice who come for postmenopausal therapy. For them, the anti-epileptics will enhance the metabolization of your estrogen, so they will require a higher dose. So these are the clinical scenarios which we have to keep in mind when we are treating the postmenopausal patients. So now we have discussed about the type of estrogen. Now almost discussed about the applications. I mean, it could be oral, it could be transdermal, or it could be local usage. So transdermal we have almost covered up, that those who are hypothyroid or cortisol dependent or as she rightly said, borderline diabetics. And also if you are treating only on transdermal is the best. And also those for migraine with aura. You don't want the systemic effects, so transdermal acts better with migraine with aura because the fluctuating levels of estrogen precipitates the migraine headaches. So now we have even covered where you are going to use oral, where you are going to use transdermal, and even tell us about the local or vaginal usages.
Yeah, I think that's one of the safest medication to use. Because luckily in India we don't have the 17-beta estradiol preparation. If you've got the 17-beta estradiol preparation, then the monitoring of the dosage becomes a little more difficult because it gets into the absorption and the blood levels are there. So we have two preparations, but now unfortunately we have only one preparation. Earlier it used to be conjugated equine estrogen, local therapy, and you also have the estradiol. My favorite was estradiol because it was really safe. And even up to, the syringe gives you only 0.5, that is 5 grams of the estradiol, you don't have more, so there is no question of excess of it. Whereas when you're looking at the conjugated equine estrogen, there are a lot of the syringe markers, no? There is 0.5, there is 1, there is 1.5, there is up to 2. So the 2 means you're going up to 2.5. almost 0.625, 1.25, and then up to 2.5. So you see, the woman can, unless you explain to them, can use much more, so the safety margin is lesser. And the absorption increases as the dose increases, and once the estrogen is well epithelialized, it is desquamated, no, in GSM, but once the epithelium becomes thicker, then the vascularity also increases. But of course, earlier the absorptions are faster, much more, whereas there is a self-limiting, just like your iron. The absorption is lesser once the epithelium becomes thicker. But whatever said and done, you have to be careful when you're explaining to the woman you have to explain. It's not about just prescribing 0.625 milligrams. That is almost, that's a routine prescription, 1 gram for 15 days at bedtime, followed by twice weekly for 2 months, 3 months, 6 months, depending upon the woman that she needs. But you have to actually have a sample of the syringe with you. And you have to explain how to insert, because many a time the woman doesn't know how to insert, and they may be hesitant, they may have problems, so you have to explain to them. So unless it is done properly, it won't work. I had a patient and I learned it the hard way, because there was an educated lady early in her practice, and I told her, you take it like this, without really explaining, in a busy practice you'll write and you'll say, okay, use it vaginally at bedtime, and you forget about it. And later on, over a period of 1 year, she used to keep coming on between, and I used to keep writing, but I never really understood that she was not really taking the way that I wanted her to take. And she came with agglutination, label agglutination. That means she was not using that medicine properly, and after that I keep one syringe there with me. It was a hard lesson, and I don't want you all to do that with your patient like what I've done. So, that because she said, yeah, she was using, but she was not putting inside. They're just putting outside. Because some people, even after deliveries, even after everything, they're still so hesitant to understand the private part, or maybe they don't understand how to use it vaginally, deep inside. There are few people who would be like that, and this is an educated lady whom... so don't assume. That's what I learned.
One more comment I would like to make is that many of our patients have access to these drugs all across the world. So in that case, if they have access to 17 beta estradiol, which is to be used locally, then the dosage is almost, as she said, every day night for 14 days, and then just twice a weekly for this thing. And the dosage is around 0.01 milligram for local usage. So the total usage in a year is 1.14 milligram of estradiol. So for that, you don't require progesterone to offset the effects on the endometrium. This is what I wanted to bring to your notice, that if she has availability of this estradiol, and if you're giving it locally, you can give it for n number of years and need not give progesterone, because the yearly estrogen that is given to the patient is just 1.14 milligrams. Okay. So now that we have given this thing, estrogen, let us see the scenarios. And she's a perimenopausal age group. She's got AUB also. As we have seen the slide, that between 45 and 49, the chances of pregnancy are 2 to 3%. After 50, the chances of pregnancy is 1%. So if the patient is around perimenopausal age group and she has an additional need of treating even her AUB, and she's got menopausal symptoms, what would you suggest?
Yeah, I think this is a tricky situation. Then you have to decide what is more troublesome for her. Because sometimes the cyclical combined therapy will not work for the AU, because the progesterone is not, is very little. So, because most of the abnormal bleeding that you have at this time are the ovulatory time, isn't it? It is AUBO, where the estrogens are fluctuating. Sometimes the woman has high levels, sometimes she can have low levels, and then you have the progesterones which are very low. So you have to have a steady levels of estrogen, but you have to give more progesterone. So here your traditional MHT may not work. So many a times, I think plain or just progesterones. And you also must have seen in your practice, you start with, so that is why now the companies have come. Earlier we used to have only 5 milligrams of norethistron acetate. Now we have 15 milligrams of norethistron acetate, because they are to be given for these AUB who need more of progesterone. So maybe if she's not happy with the progesterone alone, in the cyclical therapy, or sometimes we give long cycles also, 2 months, 3 months continuously with the progesterones, then you add a low dose of estrogen to keep that level steady. So you have to tailor it.
Would you consider giving her OC pills?
Yeah, OCP is one easy option for people who don't want to think too much.
That was a good one. Okay, now if she's early menopause, now the next thing which we want to discuss is whether it is one size fits all or whether you have to titrate the dose. So let us consider early menopause, about a year into menopause, having severe symptoms where she needs the treatment. In that case, what is the, would you titrate the dose, start with the lowest and titrate the dose, or you would give standard dosage?
Yeah, so this question I think the audience have to reply. Because we've been talking about since morning. Do you think any woman needs titration, or we should start with the standard dose?
Start gradually and assess in between the every 3 months.
So
Start gradually.
correct. So we said actually, we said that at POI, you need more standard dose. You need a higher dose. But always start with just think what would you do, say you have hypertension. Would you start with a high dose or you start with a low dose? Same thing applies. Safe medication. Start with the lowest effective dose. Doesn't work, then you increase the dose.
So,
we are not, but then here the standard doses are 0.625 or 1 mg. The low doses would be 0.3 of 6 point. But then but what I have noticed in my practice, you start with 0.3 at the perimenopause, it doesn't work. So that is why I have written, early menopause transition, you have more estrogen. So late transition, you start with lower dose. So that will apply for the late transition. But if she is the scenario in which you were describing, early menopause transition, I would start with the standard dose.
So the dosage varies between 0.05 depending on the patient's condition to 1 milligram, and you could titrate. Now we have to understand how much time does it take for the effect for estrogen to take place. The effect of oral estrogen on the hot flashes will take about 3 to 4 weeks, so you have to wait for that much time before you titrate the dose. And if you give transdermal, it is 6 to 8 weeks, so you have to titrate the dose only after this period of time so that you get the appropriate dosages.
Yeah, so remember, all of us are obstetricians. When you start your syntesanol, how do you start? Then when will you increase the dose? Yeah, you will never increase, you just don't start increasing the dose after 10 minutes. Same thing.
And we would talk about scenarios where there is premature ovarian failure. There you would give a dose of almost 2 milligrams because that's the dosage you would require. And you would treat the premature ovarian menopause with 2 milligrams till the time of natural menopause, and then take a call whether she requires MHT. Now, in which cases, now let us see if they have heard the lecture properly. Now, in which cases where we have done a surgical menopause, but you would still give progesterone?
Endometriosis.
And?
Ablation.
Correct. And? Supracervical hysterectomy. These are the 3 cases in which, although you have done a surgical menopause, you would still give progesterone. Ma'am, congratulations. Everybody was wide awake and heard your lecture.
That's a lot of satisfaction.
Okay, so now we go to the next thing, that when we have given estrogen now, then we have to protect the endometrium. So for which case, how early does endometrial proliferation or mitotic activity see? By 6 months we see that. Okay. So we need to give progesterone.
So I think ma'am's question was, how long it takes unopposed estrogen to present itself as a hyperplasia. Do you think, but what ma'am is talking about is only the hyperplasia. For it to develop cancer, it depends on the woman's profile, So it can be 2 years to 10 years also.
Yes. So amongst the progesterone, Ma'am, would it be natural micronized progesterone, dihydrogesterone, norethistron acetate, or would it be medroxyprogesterone?
Yeah, so again I would say depending on the age of the patient, no? Like we said AUB. AUB I would prefer a norethistron rather than a dihydrogesterone or a progesterone. I would definitely not out for this. But late menopause trans, you don't have a problem.
So what are the advantages of natural micronized progesterone or dihydrogesterone over medroxyprogesterone?
Yeah. So we all know that they are more lipid friendly. They are metabolically friendly. Put it all in one form. It's metabolically friendly. So they don't have any effect on the mineralocorticoid receptors. They don't have an effect on the glucocorticoid receptors. So it doesn't change the insulin levels or the need, the requirement for the insulin. So I think these are the two major areas. And then thrombogenic potential is also low. We know that norethistron to some extent gets converted back into estrogen. And that is why the thromboembolism is more with the registrons that we have been using, for a period of years. So even if you put the patient on norethistron acetate, I had a patient who had gone into thrombosis. So, but then this kind of a picture is usually not seen with the progesterones, with the dihydrogesterons, or even with tibolone.
And another major difference is natural micronized progesterone and dihydrogesterone are breast cancer nuclear. So that's a major advantage. But supposing my patient is not very affordable and I would like to put her on medroxyprogesterone acetate because that is the least costly, then what are the things I'm going to look at when I put her on medroxyprogesterone?
Yeah. So the surveillance is the same. Just because you're adding a medicine doesn't reduce or increase your surveillance, because you're going to choose. If the woman is low risk for breast cancer, moderate risk for breast cancer, you're going to prescribe the therapy. But you're also going to tell them that, yeah, she cannot be medroxy. I don't know whether the rates are anyway different. I think the choice would be only if you're going to give the OCPs versus the hormone therapy, because medroxyprogesterone acetate anyway it's not available as 2.5 or 5 milligrams. For us now, only 10, yeah. So we don't have the kind of medroxyprogesterone which you would like to use in therapy. So I think that question is not relevant for India. But one thing that is relevant for India is probably levonorgestrel, which we are using now day in and day out. So there are a lot of reports about levonorgestrel use in hormone therapy, especially in UK because it is an NHS. Everybody, for contraception also they use only levonorgestrel. So a lot of reports are coming in from the European countries about the association with breast cancer. So, we have to wait and watch.
So the three things that
not much of information related to breast cancer. Most of the other progesterones we really don't know. Dymagest is another new molecule which you're using so much for your...
Drospirenol being the third generation, thromboembolic effects are more than the effects on lipid profile. We are coming. So with medroxyprogesterone acetate, you just have to keep a surveillance because the breast cancer rates are very high and your lipid profile is unfriendly, and the third cardiovascular accidents are more with medroxyprogesterone. So in case we are using it, we should know about these three things about it. So now, where will we give cyclical therapy and where will we give combined therapy?
Yeah, so strictly cyclical therapy, we are no longer using for menopause hormone therapy. Because when you're talking about cyclical therapy, it means like a contraceptive pill. That means you're using estrogen and progesterone in a cyclical fashion with that 1 week gap, which you're not giving because in that 1 week gap, the woman becomes miserable. The vasomotor symptoms will come in. So the kind of cyclical therapy that we're going to use is a continuous sequential combined regime. That means every single day she's getting her estrogen. There is not a day where she doesn't go without the estrogen. So every single day. Progesterone is added on every 14 days of the month. So earlier we had to make all those calculations in the calendar, write the dates, you take estrogen separately. Now we have, Abbott has come with lovely combinations with different, 1 by 10, 2 by 10. Then you have the Conti also 1 by 5. Then you have a mini which they have come up with. So I think we have a very nice combination of drugs. Only when you're giving your conjugated equine estrogen, then you have to see which progesterone you're going to add to that. So either it's a dihydrogesterone or then plain progesterones, you have so many 100, 200, whatever. And I think levonorgestrel is another, because we are using lots of levonorgestrols for AUBs at menopause transition. So I think it's good enough for 5 years, low risk of breast cancer. But we have to be wary about that cancer, which is a lot of talk going on there.
Okay, so we have to understand one thing, that when we add progesterone to the estrogen, we are increasing the risk of not only thromboembolic phenomena but even CA breast. This is what we are increasing, although we are having a protective effect on the endometrium. So if we give a cyclical regimen, a sequential regimen, then only from the first to 14th day of every month we give progesterone. So patient also doesn't forget, we also don't forget. So first 14 days you give that. But this is okay for perimenopausal women who are okay with the bleeding. If postmenopausal woman doesn't want the bleeding, then you can give a combined therapy. That it is not a sequential therapy, it is combined with progesterone. Now, if the patient has got severe side effects with progesterone, I mean, she did all this for hot flashes, and she's got severe mood swings, and she's gone into severe depression and a lot of bloating, she can't wear a chappal, she can't wear her rings, then you have to have an alternative to progesterone. In that case, what would you suggest?
Yeah, I think you have to just change the progesterone or change a little bit of a dosage. If she has been on earlier, these problems were more with the medroxyprogesterone and the norethistron that you're using. I think they are much lesser with the natural progesterone. Whether it is the natural progesterone or the dydrogesterone, the swelling, the salt retention, because the mineralocorticoid effect is less, the salt retention is less, the breast tenderness with this itself is less. The PM is also less. The only thing that happens is probably with the progesterone, they may have a little sleepiness and dizziness, which we find even, that we find even when you're giving it during your obstetric practice. Dydrogesterone doesn't have this dizziness. So I think they're pretty comfortable.
Yes, so what the textbooks have to say, that if the patient complains of symptoms which are you attribute it to the progesterone and you want to delete the progesterone, then in that case you have 2 or 3 options. One is that you could switch over to LNG, okay? But the only issue is LNG will give you 20 micrograms of levonorgestrel every day, and for our patients 10 micrograms is more than enough, so we are subjecting the patient to much more dosages of levonorgestrel. And the second thing is that you could delete the progesterone completely, but you have a SERM, benzodiazepine, which will act along with the estrogen on the hot flashes. At the same time, you need not give progesterone because it has a protective effect on the endometrium. So these are the 2 alternatives you could do if the patient is unable to tolerate the progesterone.
Yeah, we don't have the benzodiazepine in India. One thing is we don't have it in India, and
But the thing is that why we are discussing is because lots of our patients have got access to these things.
But the problem is, Ujwala, what I find is, see, I won't totally go with that kind of a management because it's also country based. Now, American people don't have access to the dydrogesterone. It's all European and Indian and the Asian countries. So dydrogesterone as such is a wonderful drug. I mean, this disclaimer, though this is Abbott which is sponsored, but I think dydrogesterone is a wonderful molecule from the beginning. A lot of, it's friendly everywhere. But the only problem was, it is not strongly progesterogenic as some of the other progesterone. So naturally you would expect the side effects also to be lesser. And natural progesterones, you're having so many formulations with different potencies available to us. So Bezidexone would be a little different. So I would still, even if that was available, my personal choice would still be an estrogen and a progesterone for vasomotor symptoms.
If we are giving natural micronized progesterone, better to give it at bedtime because of the somnolence effect of this. So now we've covered the estrogens, the progesterones. We have started the patient on that, and as we had previously said, the shortest amount of time to control or give relief to the patient, and start planning withdrawal on the day you start the MHT. So now when we are withdrawing it, we have to take into consideration that we've already said 10 years and up to 60 years, but the safety profiles have been for about 5 years for these regimens. So most of them talk about withdrawing by 5 years time. So withdrawal will be abrupt or gradual.
Yeah, so post WHI, we have got some good information that we can continue up to 7 years from the study, and there is a good follow-up after that also for 18, 19 years now, after 7 years of study. But there is some good material also, ad hoc from the European countries where they have used for longer periods of time. And that is how the NAMS guideline has changed its tune now, where indefinitely, they have written if necessary. But then that's not the norm. Most of the people by themselves after 2 years, once they start feeling better, they'll say they'll stop the drug. They may not even come back to you. And but when you decide between the two of you that okay, now you need to stop the medication because you're feeling comfortable and you don't need it for your bone health, then either you can stop abruptly because we don't have data on this. So either you stop abruptly or you gradually reduce the dose and say twice weekly, once weekly, and it goes like that. So it's all the choices that you have, and it all depends on how the woman reacts. So because even in my practice I have seen 40 to 50% of the women do well once they stop. And some of them get miserable. 3 months they come back. They'll say, oh, you want to get back to that medicine, we are not happy at all. And they keep continuing with the medicines for a long period of time. There are few people who cannot do without estrogen. They continue. Because the quality of life is so good.
So, among all the studies and papers and textbooks, they say that it is, if you stop abruptly, the symptoms will come back in a month and a half's time. And if you do a gradual type this thing, it will come back in 6 months' time. The severity is the same after 9 months. After 9 months to 9 to 12 months, the severity is the same. But of course, there are people, as she rightly said, who stop by themselves, relief of symptoms, and don't come back again. But but it is better to reduce it gradually. So it could be 7 pills a week to 6 pills a week for 2-3 weeks, then 5 pills a week for 2-3 weeks, and come down that way. And if she again has a certain bout, then decrease it 6 pills for 2 months, 5 pills for 2 months. So gradually, taper the dose as per this thing. So then you don't have to restart it, sort of things. So now we have considered these things about estrogen, about progesterone, about starting, titration, stopping, everything we have considered. Now, if the patient complains only of sleep disturbances, are we right away going to start MHT?
So you got the answer from the audience. Because sleep, only sleep doesn't figure as the menopausal symptom, isn't it? So only sleep disturbance without anything else, of course, it's not MHT at all. But then there are definitely, if it is a part of the vasomotor symptoms, severe vasomotor symptoms, night flushes, disturbed cognition, then yes, But we know that there are so many reasons for sleep disturbance at menopause, which may not be related to menopausal symptoms at all. The 90% of the women who don't have vasomotor symptoms can suffer from sleep disturbance. So the take-home message is, don't start MHT for sleep disturbance.
That is what we wanted to impress upon you, that the sleep disturbance may be because of obstructive apnea, which has to be ruled out at that point of time, and restless leg syndrome, which occurs in that age group. So,
we are done.
Yeah, we can.
So, no, I was requesting if we can start the audience question answer session, if it's okay.
So this is what we want to impress upon you, that for sleep disturbance only, of course if it's because of vasomotor symptoms, the sleep disturbance, MHT. But please first rule out restless leg syndrome and apnea, which are the causes of lack of sleep, and don't start the menopausal therapy for these symptoms. And so far as depression and anxiety are concerned, I think we have got a lot of many drugs which we can use, like naloxone or fluoxetine or gabapentin, or all these things we can try first, and if they are not responsive to that and the depression and the anxiety continues, you can still put them on menopausal hormonal therapy. And
refer to the psychiatrist.
Yes.
And all the menopausal, all the vasomotor symptoms and cognitive problems, refer them to the gynecologist.
just a word about calcium now. 1200 milligrams per day, 800 milligrams of vitamin D. And exercise, if she's doing moderate exercise, then about 30 minutes per day, 5 days a week is more than enough. And vigorous exercise like trekking or running or the gym, then 75 minutes a week. That means 15 minutes in 5 days is more than enough to keep your bones in shape. Yeah, this is what
actually, there is, Dr. Gauri and Mayuri, you should have another session completely, because I disagree with this 1200 milligrams of calcium for the Indian woman, very strongly. So, so we have lot of explanations as to why you have chosen that. So it's not a standard like that. We say 800 to 1200, but every menopausal, perimenopausal women, postmenopausal women should get at least more than 800 milligrams of calcium. And this statement is because we don't want the farmer to be pushing the calcium supplements in the Indian market. What is happening is, if you're going to make 1200, you see an average Indian woman doesn't even take, even the people who can afford, it's not about affordability, 400 to 600 milligrams of calcium. So if you calculate, and so people who are very health conscious, and he said, ragi has got high glycemic index, and the nuts will also have, and the milk also will have. So like that, when you see, you have to see that they get calcium from the diet. So anything more than 800 milligrams, and we are promoting 1000 IU of vitamin D. So 1000 to 2000, so it's a range actually. 1000 to 2000 per day, and 800 to 1000 is also enough, but you can stretch it to 1200, doesn't matter.
Not going according to what the pharma standards say, but what the recommended dietary daily allowances. In Japan it is only 600, in America it is 1300. So
exactly. So Indian women, this is what Indian for the guidelines in osteoporosis as well as menopause, very categorically, and I have actually written an editorial on this, debating and questioning the ICMR NIN guidelines, because they have suddenly shifted from 600 to 1200, which is not correct without a base.
And they say that recommended dietary allowance is around 1000, but about 30 milligrams of calcium you excrete every day. So that's why the effective daily allowance should be 1200 milligrams. This is what the research papers say, but she knows better, so we go by what she has to say. So let's end by saying that previously MHT was used for vasomotor symptoms, osteoporosis, cognitive disabilities, dementia, and cardiovascular health. But now there are only two things which we are using it for: vasomotor instability and your prevention of osteoporosis. But it is not used for cognitive dementia in women who are already entered the menopause. The caveat here is, if it is a premature ovarian failure, where you have another 20 years to go, for them the protective effect of estrogen and progesterone is there for prevention of dementia, for prevention of cardiovascular effects, and for cognitive ability. But once you have entered menopause, these things are not reversed. Okay. I think we will end up with that because we're short of time. Thank you so much.
We take some questions from the audience. I'm sure all of your questions have been answered. Yes, sir.
I have two case scenarios. One is a case of CA breast. One side radical mastectomy has been done. Uterus ovaries are present. Now she is menopausal. And she has urogenital symptoms. So we try to avoid oral hormone.
No oral.
But she is having mainly urogenital symptoms. She doesn't have vasomotor.
Yes.
So is Primarin cream safe for her?
Okay. That's a very common scenario with the post breast cancer patients, because they have the radiotherapy and the mucosas, they get into this GSM very fast. So first we start with the non-hormonal local therapy initially. So there are options available. We have the isoflavones which are there, then we have the moisturizers, we have the lubricants. So you can try all of them. But if she is not happy with it, and if she is not ER positive, ER negative, straight away you can put her on Premarin, but try to give monitor, for these kind of patients. Anyway, she is under surveillance, so you can give treatment. I would have preferred estriol, but it is not available. So the first line of management would have been estriol. Because that's not available, Premarin, conjugated equine estrogen can be given.
Premarin local, I'm saying.
Yeah, local, no oral. We are not giving
How much percentage of Premarin local
so
would be absorbed?
Correct. So it all depends upon the severity of the GSM. If it is very severe, then you can start off with 0.625 once daily for 15 days and then make it twice weekly for 1, 2 months. Stop and see how she feels. But there may be recurrent attacks which she may be needing the therapy again and again.
Yeah. The second case scenario is a case of CA endometrium. She was contraindicated for surgery. So she has undergone radiation. Now because of that she has developed radiation vaginitis, radiation urethritis.
Correct.
Now can we give Premarin cream to her?
Yes, you can give.
Because uterus is still there.
Yeah, no problem. Because there, with the radiotherapy that you have done, most of the endometrial receptors would have gone. So, but the vaginal mucosa, we really don't know how much the estrogen therapy is going to work even with the vaginal mucosa because radiation. But still, I think probably first we must try with the non-hormonal along with, and then try the.
But it's not contraindicated.
No, it's not contraindicated. But I personally not given for anybody, so I don't have a personal experience. But I don't think. The books, according to the books, it is not there. So any cardiovascular disease, these kind of post-radiotherapy, because they have not only the vaginal symptoms, they suffer more from the urethral symptoms and the proctitis.
Yes.
Those problems are much more severe for them.
And thirdly, is there any study where the patient is on oral estrogen therapy and to prevent DVTs or those kind of things, she's a little at high risk like obesity.
Correct.
She's not got any prior history of thromboembolic phenomena.
But she's a high metabolic.
Yeah. So is there any study with estrogen with low dose aspirin as a prophylactic?
No.
In such women?
No. Because nowadays we don't even, we have so much of transdermal available, no? We have transdermal estrobate gel, these people, avid people have the gel. Then Lanzetto is what has come out spray. So we have 2-3 options which are there in India now. So we should straight away go for that and not go for the oral.
What's the difference between a vaginal moisturizer and a lubricant, and how do you decide what to use when?
Yeah, that's a very good question. So a lubricant is a short term, no? It is only before the sexual activity when there is dyspareunia, you're going to use the lubricant. So it's all this oil based. Whereas moisturizer is mainly water based. So most of the gels are water based, and so that's the major difference. So that's oil based and this is water based. But here also in moisturizer, that's why remember I don't know how many of you are using the vaginal washes on a routine. Are you prescribing the vaginal washes on a routine rather than plain simple soap and water? So there's a fashion, no, in between, where all of us are prescribing these vaginal washes as a perennial hygiene. So why did you all stop?
No,
it doesn't change the pH.
It is not to be used for intravaginally. They have clearly mentioned that it's to be used only externally. So how is it going to? It's not going to help.
Dryness. Used to cause a lot of dryness.
Yeah, I think that's a question. I'll leave it. All of you can go home and work on that. Yeah. So there is they say the WHO has got some guideline on the water content of it because that destroys the cellularity. You're using excess. So they say don't use any of the washes for perennial hygiene, just a plain simple soap and water is good. That's why we say don't use it. People like to use Savlons and Betadines and whatnot. People who are really very obsessive about the cleanliness, no? So it's only soap and water and clean and dry. That's it.
What is the place of phytoestrogens nowadays? What do you say about phytoestrogens?
Soya.
Correct. I am not a huge fan of phytoestrogen. I am not promoting or not mispromoting anything. Because see, when you look at the just like calcium, for me any of the nutraceuticals is like go with the foodstuffs unless it's got some problem. Unless somebody cannot swallow or cannot absorb or has problems where you're not able to get from the diet, then go for the nutraceuticals. It has an important role to play. So phytoestrogens on its own, it works a little better than placebo effect. Because the potency, like she said, ethinyl estradiol compared to the 17 beta estradiol, like how it is, almost 7,500 to, almost 1,000 times more. Here the potency is 1,000 times less again. So it's only a sense of satisfaction that you're giving something. Unless there is a contraindication, then you give, it works. It works because it works in 50 to 60% of women. But even if you're giving lycopene, it works. You're giving a multivitamin like a menopause, it works. That is all 50 to 60%, but not for the severe symptoms. So all of them are going to work for your mild to moderate symptoms. But phytoestrogens, we have so much in the rajma, in the chana, fermented foods. So yeah, everybody keeps talking only about soya, but how many of us really like to use soya? So yeah, or have been using soya from childhood. See, so these are all the things which are very important. So the Indian food that has got these phytoestrogens, the lignans, especially chana dal, rajma, your chole, your fermented foods, these are the ones we should be promoting.
Madam, since our talk was about the holistic approach, do you have any experience about the Ramdev Baba exercise or the yoga in high-risk group, especially
Excellent. One thing good about Ramdev Baba is at least he has created a trend. We have to thank him for that. Everybody is talking about yoga after him. And I think we have to appreciate that. At least he has done something good, not bad. And he has made everybody come onto the ground and exercise and do all the stretches. No, otherwise, how many, now everybody is onto it. So I think it's a good thing to do. And yeah, definitely. 100%. No, see, lifestyle management now is considered to be, madam already talked about, even 15 minutes is going to help your bone. It's going to help your muscle. Because all of us have become so stationary. We are sitting all the time.
What is the bioidentical hormone therapy? How it is better than this MHT? That is something which keep on listening.
Luckily, bioidentical hormones have not entered our market. There was a company who was desperate, who were, after the Indian Menopause Society, that they want to talk about it, and so bioidentical hormones and the hormones produced by the pharmaceuticals are two different things. Bioidentical is they are manufacturing these hormones without a standardization. Yeah, just like even thyroid supplements, some bioidentical, they come just like those Ambien products, they'll say iron. Is it standardized? I mean, I don't promote the Ambien products or the proteins. They're so expensive and they don't have, we don't have the standardization, we don't know how much we're giving. So the logic is very simple.
So, ma'am, something more on how long, where?
Yes, very good. Nothing you have mentioned.
Nothing you mentioned. Other than starting in 1 year 3.
Okay, so if you see in man's slides, tibolone is to be used 1 year after menopause so that you don't exacerbate the hot flushes. Now it has got metabolites which are estrogen, progesterone as well as testosterone. So yes, so it improves even the libido, it improves your hot flashes, it looks at osteoporosis also. But not to be given beyond 60 years because the increase in number of strokes, and not to be given in breast CA because the recurrence of CA breast increases. That's all. Thank you so much.
I think we all have enjoyed this coffee session more than any other coffee shows.
But the coffee mug is empty.
Yeah, though they are...
Next time.
Ma'am, that was for photographs actually. So I request Gauri Karandikar ma'am and Kadorkar ma'am to please come on stage and felicitate our speakers.
I like your truthfulness.
Don't go behind. Don't go behind.
Ma'am, look here. Ma'am.
Look here, please.
समोर कॅमेऱ्याकडे.
This is the paitani which you bought yesterday. And
Look at the camera.
Wait.
so this was a real enchanting session on HRT and MHT, and I think we couldn't have better ladies than doing this for us. So one bigger round of applause for those girls.
To our next lecture by Dr. Nilesh Jejurkar. He is practicing psychiatrist in Nashik. He is lecturer at NDMVP Medical College and SMBT Medical College Nashik, and he has done his TPM from Aurangabad. So I welcome him for his talk.
बंद करा, थोडे राहू द्या. मला अंधारात परफॉर्म करायची सवय नाहीये. स्टेजवर अंधार झाला की ब्लॅकआउट म्हणजे आम्ही विंगेज जातो. आणि इथे पण मी जास्त वेळ उभं राहणार नाहीये. इथे काही फार नाहीये. त्यामुळे कंटेंट जे काही आहे ते आपण लॉट ऑफ सायन्स अँड अकॅडमिक्स झालंय. आणि सायकॅट्रीमध्ये इट्स ऑलवेज कॉम्बिनेशन ऑफ आर्ट अँड सायन्स. सो I will be talking more about the art that we are dealing with. सुरुवातीलाच धन्यवाद. आणि it's a 2020 time, so I will not cross the limit of 20 minutes allotted to me. आणि बऱ्याचदा असंच होतं की स्लॉग ओव्हर्स मध्ये येतो. सायकेट्री असाही 7 मार्काचा सब्जेक्ट होता. हे आम्हाला सवय आहे. आणि पण असं आहे की यू कॅनॉट सेपरेट माइंड अँड बॉडी. ज्या वेळेला शरीरामध्ये काहीतरी होत असतं त्यावेळेला मनामध्ये पण काहीतरी सुरू असतं. आणि ज्या वेळेला मनाला काहीतरी होतं त्यावेळेला शरीरावरती पण त्याचे रिफ्लेक्शन्स बघायला मिळत असतात. कोणी आहे का मराठी बिलकुलच समजत नाही असं? नाही ना? नाशिकमध्ये प्रॅक्टिस करतात त्यामुळे थोडं थोडं तरी मराठी नक्कीच येत असेल. मी जास्त मराठीत बोलणार आहे कारण थोडा उशीर झालाय. मला असं वाटतं की इफ आय कांट मॅनेज माय एन्झायटी देन व्हॉट इज द पॉइंट. whatever I am comfortable with. What is menopause? I am not the expert to talk here today with so many gynecologists around what is menopause. But what is happening in body, we have seen a lot of hormonal changes, and to describe in a very apt way, I can say it's orchestra going on throughout the life of a woman, and the melody keeps on changing in different life phases. So it's a transition time, and perimenopausal period is more difficult rather than postmenopausal period, because this transition time, lot of things are happening in the women's life at that age. त्यामुळे शरीरामध्ये जरी एवढे सगळे बदल होत असले तरी मानसिक पातळीवरती सुद्धा खूप साऱ्या गोष्टी घडत असतात. डिप्रेशन जसं आपण म्हटलेलं आहे आपल्याकडे मुळातच लहानपणापासून 40शी आली बायकांचंच नाही पुरुषांचं सुद्धा असंच होतं. आणि आपण पण 40 झाला तर दरवर्षी टेस्ट करायला सुरुवात करा, दरवर्षी ते आपलं सगळं रुटीन चेकअप झालं पाहिजे. ते 40 सुरू झाल्यानंतरच हे सगळं मनामध्ये ते शरीरात हार्मोन्स चेंज होतील तेव्हा होतील. पण हे आधीपासून आपल्या सगळ्यांच्या मनामध्ये सुरू व्हायला लागलेलं असतं. सामान्य लोकांच्या बाबतीमध्ये 40 नंतर ते वेगळ्या लाईफ स्टेजमध्ये असतात. पण मला वाटतं डॉक्टरांचं आपलं सगळं थोडं उशिरा आहे. 40 परत 40ला येता लोक कुठं आता जरा प्रॅक्टिसमध्ये स्थिर स्थावर झाले असंपर्यंत आलेले असतात. आणि त्याच्यात लगेच अरे 40 वगैरे. त्यामुळे हे सगळं मानसिक पातळीवरती सुद्धा खूप साऱ्या गोष्टी घडत असतात. मग त्यावेळेला आपले अँझायटी सिम्पटम्स व्हायला लागतात, थोडं डिप्रेशन यायला लागलेलं असतं, खूप सारे विचार मनामध्ये येत असतात. मुलांची शाळा, मुलांची कॉलेजेस, काहींची मुलं 11वी-12वी क्रॉस करून आता त्यांचं पुढचे एज्युकेशन सुरू होणार असतं, ते मुलं घर सोडून बाहेर जाणार असतात. त्यामुळं हा जो सगळा एज टाईम स्पॅन आहे त्याच्यामध्ये शरीराबरोबरच मानसिक पातळीवरती सुद्धा खूप साऱ्या गडबड होत असतात. पेरिमेनोपॉझल पिरियडमध्ये स्पेसिफिकली काय होतं की जसं आपण आत्ता जस्ट 5 मिनिटापूर्वी बोलत होतो की झोप बिघडते. आणि मला असं वाटतं की जेवणापेक्षा झोप जास्त महत्त्वाची. 3 दिवस उपवास करायला सांगितलं तर आपण कसा बसा 3 दिवस उपवास करून घेऊ. आजकाल लोक करतातही, लॉंग फास्टिंग, टाकावर दिवस काढा वगैरे वगैरे. पण झोपायचं नाही 3 दिवस म्हटलं तर फार गडबड होऊन जाईल. त्यामुळे साऊंड स्लीप इज आय थिंक द फर्स्ट कॅरेक्टरिस्टिक साईन की आपलं मेंटल हेल्थ इज गुड. आम्ही असं नाही म्हणतो की पहिले कशावरती जर फरक पडत असेल, आपल्याला जेव्हा तणाव येतो, टेन्शन येतं, त्रास होते, तर आपल्या झोपेवरती परिणाम होतो. माझ्यासारख्या काहींना परीक्षा आल्यावर जास्त झोप लागते, काहींची गायब होते, पण झोपेवर परिणाम होतो हे मात्र नक्की. त्यामुळे झोप फार महत्त्वाची आहे आणि त्यासाठी मग आपण स्लीप हायजीन, लाईफस्टाईल मॅनेजमेंट या सगळ्या गोष्टींकडे आपण नक्कीच बघितलं पाहिजे. डिप्रेशनमध्ये जरी नाही गेला माणूस तरी डिस्फोरिया असतो आणि कम्प्लिटली डिप्रेशनचे सगळे साईन सिम्पटम्स येत नसले तरी कुठेतरी इरिटेबिलिटी, चिडचिड काहींना दर महिन्याला अनुभवायला मिळते. आमच्याकडे काही पेशंट्स येतात तर बायकोशी बोलून झाल्यावर आम्ही नवऱ्याला पण सांगतो, हे बघ ती जसं कॅलेंडर लक्षात ठेवते तसं तू पण कॅलेंडर लक्षात ठेव. हे 4 दिवस भोगायचं आहे, आर्ग्युमेंट्स नाही, ओके ओके म्हणायचं. कारण ते 7-8 दिवस झाल्यानंतर तिच्याच लक्षात येतं की किती छोट्या छोट्या गोष्टींवर मी चिडले होते उगाचच. तर हे जे आहे ना होलिस्टिक अप्रोच असं जर म्हटलं की बऱ्याचदा खूप सारं ऐकून घ्यावं लागतं. हिस्ट्री घेणं फार महत्त्वाचं आहे की कुठल्या बायकांच्या बाबतीमध्ये पुन्हा पेरिमेनोपॉझल किंवा पोस्ट मेनोपॉझल पिरियडमध्ये जास्त लक्षणं दिसणार आहेत की त्यांची लाईफस्टाईल कशी होती, त्यांनी गेले 20-22 वर्ष दर महिन्याला काय काय त्रास होत होते, आता त्यांची फिजिकल हेल्थ कशी आहे, कोमॉर्बिडिटीज आहेत का, आधी डिप्रेशन होतं का, आधी ओसीचे सिम्पटम्स होते का, परफेक्शनिस्ट होत्या का, अँक्शियस होत्या. ह्या सगळ्या गोष्टी जर आपण हिस्ट्रीमध्ये जर नोट डाऊन केल्या तर आपल्या लक्षात येतं की ह्या स्त्रीला पर्टिक्युलरली या पिरियडमध्ये जास्त त्रास होणार आहे. त्यामुळे मला असं वाटतं की हिस्ट्री टेकिंग हे आपल्याला जे UG डेजमध्ये शिकवलेलं आहे दॅट अप्लाइज हिअर टू स्ट्रेसर्स. जसं आता मला फिजिकल हेल्थ जर आधीपासूनच हायपरटेन्शन असेल, डायबिटीज असेल, दुसरे काही आजार असतील, कोमॉर्बिडिटीज असतील, सायकोलॉजिकल फॅक्टर्समध्ये जर काही आधीपासूनच मानसिक आजार असेल, त्याच्यासाठी काही औषध वगैरे चालू असतील, प्रीमॉर्बिड पर्सनॅलिटी, अँक्शियस पर्सनॅलिटी, डिपेंडंट पर्सनॅलिटी. काही लोक असतात की जे प्रश्न विचारल्याशिवाय की कोणाकडनं तरी ॲफर्मेशन घेतल्याशिवाय कामच करत नाही, तर या डिपेंडंट पर्सनॅलिटी. अँक्शियस पर्सनॅलिटी म्हणजे काय होईल, कसं होईल का, सगळं नक्की बरोबर होईल का, घरातून निघाल्यावर बस मिळेल का, बसमध्ये जागा मिळेल का, जागा मिळेल तर शेजारी कोण बसेल, प्रत्येक गोष्टीमध्ये प्रश्नचिन्ह हा असतो. त्यामुळे ह्या सगळ्या पर्सनॅलिटी फॅक्टर्स सुद्धा कॉन्ट्रीब्यूट करतात की काय होणार आहे आणि हे आपण अँटिसिपेट करू शकतो जर आपण हिस्ट्री प्रॉपरली घेतलेली असेल तर. आणि ॲटिट्यूड ही फार महत्त्वाची गोष्ट आहे की आयुष्यामध्ये ज्या घटना घडता आहेत त्या घटनांकडे बघण्याचा त्या व्यक्तीचा ॲटिट्यूड कसा आहे. कारण मला असं वाटतं की कुठल्याही गोष्टीकडे बघताना आपण एक 4 स्टेजेसमधून जात असतो आणि जितक्या लवकर आपण ॲक्सेप्टन्सच्या लेवलवर येतो, स्वीकाराच्या पातळीवर येतो, तितका त्रास कमी होतो. सगळ्यात पहिल्यांदा तर डिनायल असतं, अजून नाही, अजून बराच वेळ आहे, किंवा नाही मला एवढा त्रास होणारच नाही, किंवा माहितीच नसतं, त्यामध्ये डिनायल मोडमध्ये असतात. त्यानंतर अँगर असतो की का आहे, मग मलाच का सहन करावं लागतं, माझ्या बाबतीतच असं का होत आहे. त्याच्यानंतर मग बार्गेनिंग असते, जर असं झालं असतं तर, मी आधीपासून काळजी घेतली असती तर, मला हे करायला जमलं तर, मी माझ्या लाईफस्टाईलमध्ये हे फरक केले तर, खूप सारं बार्गेनिंग असतं. त्यानंतर डिप्रेशनची एक स्टेज येते की हे का होतंय, कशामुळं होतंय, हे व्हायलाच नको होतं, आणि मग कुठेतरी माणूस ॲक्सेप्टन्सच्या लेवलवर पोहोचतो. असं प्रत्येक क्रायसिसमधून जात असताना माणसाच्या बाबतीमध्ये होत असतं. तर मला असं वाटतं की जितक्या लवकर ते ॲक्सेप्टन्स लेवलवर पोहोचतील तितकं त्रास कमी होत असतो आणि हे आपल्याला कम्युनिकेशनमधूनच साध्य करता येऊ शकतं. त्यामुळे ॲटिट्यूड फार महत्त्वाचा आहे. The power of subconscious mind is not applicable for only positive things, but whatever is happening in our life, the power of subconscious mind is very important. आणि menopause, what does it mean to you? नक्की काय? हे प्रेझेंटेशन करण्याआधी किंवा मला ज्यावेळेस मॅडमने सांगितलं की तुम्हाला ह्या विषयावर बोलायचं आहे, मी पहिल्यांदाच ह्या विषयावर बोलतोय म्हटलं की साधारण त्या वयोगटातल्या बऱ्याच महिलांशी बोलावं. मग काही सिनियर्स आहेत किंवा काही आपले कलिग्स आहेत आणि मावस बहीण वगैरे आहेत, त्यांच्याशी मी बोललो की नेमकं काय वाटतं, तुला काय होणार आहे? तर पहिली गोष्ट हो, काहींचं असा रिप्लाय आला की फार विचारच नाही केला याच्या बाबतीमध्ये. पण काही लोक होते मात्र, अरे मी तयारी सुरू केली आहे, मी आत्तापासून फिटनेस ठेवते, मी आता माझी जिम वगैरे सुरू केली आहे, मी माझा डाएट प्लॅन चेंज केला आहे, मी आता ह्या सगळ्या गोष्टी करायला लागले. म्हटलं कशासाठी? आय हॅव टू गेट रेडी फॉर द मेनोपॉज. व्हेरी गुड. कशासाठी? तर त्याच्यामध्ये पण बऱ्याच लोकांच्या मनामध्ये वेगवेगळ्या कन्सेप्ट आहेत. दर महिन्याला जी सायकल येते आहे, आता मेडिकोजमध्ये फार कमी वेळा हा शब्द वापरला जातो, पण आपण जर सर्वसामान्य लेमॅन्स ग्रुपमध्ये जर गेलो तर प्रॉब्लेम नाही आला. प्रॉब्लेम नाही आला हा प्रॉब्लेम आहे की 4 दिवसासाठी प्रॉब्लेम म्हणायचा आणि म्हटलं मग आता हे थांबणार आहे ते चांगलं आहे का वाईट आहे? खूप सारे मिसकन्सेप्ट आहेत आणि लहानपणापासून त्याच्याबद्दल आपण काय ऐकत आलोय, आपण काय बोलत आलोय, हे सगळं कुठेतरी मनामध्ये साचलेलं असतं. ते सगळं त्यावेळेला बाहेर पडणार असतं आणि अचानक बदल व्हायला लागतात. त्यावेळेला बऱ्याचदा हे बदल का होत आहेत हेच खूप लोकांना माहीत नसतं. जसं आपल्याला पहिल्यांदाच आपला आवाज बदलायला लागतो, त्यावेळेला आपल्याला असं वाटतं काय झालं, माझा आवाज का बदलतोय, आरशात अचानक कंठ दिसायला लागतो, आपली सूज आली की काय. मग ज्या वेळेला असं कळतं की नाही आपल्या मित्राचा पण आवाज बदलतोय, त्याही मित्राचा आवाज बदलतोय. माझ्या बाबतीत काय झालं की मी 81 बॉर्न आहे, पण मी मॅक्झिमम 82 बॉर्न लोकांमध्ये होतो. त्यामुळे वर्गात सगळ्यात पहिल्यांदा आवाज माझा बदलला. काहीतरी गडबड होते. मग ज्या वेळेला अजून 1-2 आवाज बदलले त्यावेळेस म्हटलं नाही हे काहीतरी नॉर्मल दिसतंय. सो हे फक्त होतं, हे फक्त माझ्या बाबतीत होत नाहीये, तर लोक याच्याबद्दल बोलतच नाहीत जास्त. माझ्या घरातला अनुभव सांगायचा म्हणजे MBBS पास झालो, आईचा पेरिमेनोपॉझल पिरियड होता आणि मग रात्री ते अचानक रात्री 11-12 वाजता हॉट फ्लशेस, जाग येणं, धडधड होणं, आपल्याला त्यावेळेस काहीच कळत नव्हतं. ECG अमकं तमकं सगळं झाल्यानंतर मग अचानक एक दिवस आमच्या सरांनी सांगितलेलं गायनॅकच्या याच्यातलं आठवलं, म्हटलं गायनेकॉलॉजिस्टलाही भेटून घे. आणि त्यावेळेस तिला म्हटलं की एकदा तुझ्या मोठ्या बहिणीशी पण बोलून घे. मग तिने मला सांगितलं अरे मावशीला असंच काहीतरी झालं होतं. म्हटलं मग मावशीने तुला सांगितलं नाही की तुला असं काही होणार नाही या विषयावरती. त्यामुळे मला असं वाटतं की सेम एज ग्रुपमध्ये आल्यानंतर कॉलेजमध्ये गेल्यावर जशी सिनियर्स रॅगिंग घेतात तेव्हा बऱ्याच गोष्टी शिकायला मिळतात, तसं मला वाटतं की सिनियर्सनी कंटिन्युअसली हे बोललं पाहिजे. आपणही आपल्याला काही असं होत असेल तर आपल्या आधी कोणी या पिरियडमधून गेलं असेल तर त्यांच्याशी मनमोकळेपणाने बोलणं फार गरजेचं आहे. आणखी सबकॉन्शियस माइंडमध्ये माझ्यानंतर मनीष बोलणारच आहे की काही लोक असतात चला संपलं आता काही टेन्शन नाही, आता निसर्गानेच आपल्याला सांगितलेलं आहे की आपलं आता सेक्शुअल लाईफ संपलं, मेनोपॉज आलेला आहे. सो दीज आर व्हेरी रिलिजियस पीपल की त्यांना असं वाटतं की हां आता मला काही 4 दिवस पाळायचे नाही, काही नाही, मी कधी देवपूजा अमकं तमकं हे काहीच नाही. पण काही लोक असतात त्यांना पण हे पण टेन्शन असतं, अरे बापरे म्हणजे आता ड्रायनेस येणार, मग माझं सेक्शुअल लाईफचं काय होणार, मग मला व्यवस्थित परफॉर्म करता येईल का, मग माझ्या पार्टनरला काही त्रास होईल का. तर दोन्ही प्रकारे विचार करणारे माणसं भेटलेले आहेत की त्यांचा स्वतःचा सेक्शुअल लाईफकडे बघण्याचा काय दृष्टिकोन आहे. त्यामुळे तिथे पुन्हा what lies in subconscious mind that is also going to play a very big role. आणि आणखीन एक महत्त्वाची गोष्ट म्हणजे पेरिमेनोपॉझल पिरियडमध्ये ज्या वेळेला अचानक 2 महिन्याने कधीतरी पुन्हा सायकल येणार आहे, कधी 3 महिन्याने सायकल येणार आहे, त्यावेळेला ना बरेच लोक याच्यामुळे जास्त अस्वस्थ होतात की त्याच्यामध्ये अनसर्टनिटी खूप आहे, अनिश्चितता खूप आहे. म्हणजे आता आमच्या घरी सण आहे, आमच्या घरी पूजा आहे, मग श्रावणामध्ये आपल्याला काहीतरी करायचं आहे, गणपतीत आपल्याला काही करायचं आहे, मग गोळ्या घ्यायच्या की नाही घ्यायच्या. ही जी अनसर्टनिटी असते ती सुद्धा माणसाला जास्त अस्वस्थ बनवते. आणि मग आता हा ट्रान्झिशन पिरियड किती वर्ष चालणार आहे, काहींचा 2 वर्ष चालणार आहे, काहींचा 3 वर्ष चालणार आहे. त्याच्यामुळे मला असं वाटतं की पेरिमेनोपॉझल पिरियडमध्ये पण सायकोलॉजिकली दे आर मोर डिस्टर्ब. एकदा ते पूर्णपणे मेनोपॉज अचीव्ह झालं की मग त्यांना माहिती असतं की आता मला एक विशिष्ट प्रकारची लाईफस्टाईल जगायची आहे. सो व्हॉट लाईज देअर इज व्हेरी important thing and what to do now. Let's talk about I am not different. ते खालचं आहे ते हात वर केला पण मी त्याच्याकडे शेवटी ठेवलेलं आहे त्याला. पण त्याच्यासाठी मला असं वाटतं की आधी बऱ्याच गोष्टी करण्यासारखे, जसं आम्ही सांगतो की सेल्फ हेल्प ग्रुप पण असतात. अल्कोहोलिक अनॉनिमस असा ग्रुप आहे की प्रत्येक वेळेला गोळ्या घेऊनच दारू सोडील असं काही नाही. पण मी माझ्यासारख्या इतर लोकांशी बसून सोबत गप्पा मारल्या की मला त्याच्यातून बऱ्याचदा सोल्युशन्स मिळतात. प्रत्येक वेळेला आपल्याला डॉक्टरच सोल्युशन देऊ शकेल असं काही नाही आहे. तर आमचे बरेच मित्र आम्हाला सांगतात की दारू सोडताना जो त्रास होतो त्या अरे याने असा उपाय केला होता याची सुटली, त्याने तसा उपाय केला होता त्याची सुटली. आमच्या एका पेशंटने सांगितलं की गुळ खाल्ल्यानंतर क्रेविंग कमी होतं. म्हटलं चांगले आहे, डायबिटीज नसेल तर गुळ खायला काही हरकत नाही. पण हे सेल्फ हेल्प ग्रुपमध्ये जेव्हा तुम्ही एकमेकांशी बोलतात त्यावेळेला मी काही वेगळा नाही आहे, माझ्याबरोबर काही वेगळं होत नाही आहे आणि माझ्यासारखे बरेच लोक आहेत ते पण ट्रीटमेंट घेत आहेत, त्याच्यातून बाहेर पडत आहेत. त्यामुळे ते एक ॲश्युरन्स मिळतो आणि एक काय म्हणता येईल त्याला की सायकोलॉजिकल सपोर्ट असतो. आणि आपल्याला दुसरं कोणी समजून घेईल की नाही घेईल ही एक मनामध्ये भीती असते की आपल्याला कोणी समजून घेणार आहे की नाही घेणार आहे. रीच टू ॲक्सेप्टन्स ॲज अर्ली एज पॉसिबल ते म्हटलं तर माइंडची जसं फिजिकल एक्सरसाइज गरजेची आहे तसं मला असं वाटतं की तो जो ट्रान्झिशन पिरियड आहे लाईफमधला 50च्या आसपासला त्यावेळेला एम्प्टीनेस सिंड्रोम आहे, मुलं बाहेर पडणार आहे, नवरा अजून रिटायर झालेला नाही त्यामुळे तो कामामध्येच व्यस्त आहे, असं एक रिटायर झाल्यावर किती वेळ दिली याची काही गॅरंटी नाही. पण तरी सुद्धा मला असं वाटतं की आपला मी टाईम जो आहे तो प्रत्येकाने ठरवला पाहिजे की माझं आनंद आणि माझं सुख जे आहे ते मी कोणाच्या दावणीला बांधता कामं नाही. आता इथे चान्स मिळालेला आहे, बऱ्याच महिला वर्ग आहे म्हणून मी सांगतो की पाऊस पडतोय, भजे खायचे, थांबा यांना घरी येऊ दे. पोरं म्हणतात आई आज अमुक तमुक कर, आज बाबा घरी नाही आहे, बाबा घरी असेल त्या दिवशी करूया. बाबा मित्रांबरोबर पार्टीत काय खातोय माहित नाही, बाबा विचार नाही करत. तर मला असं वाटतं की आपलं सगळं सुख आपण एका माणसाशी बांधून ठेवता कामाने. कॉफी प्यायला आपल्याला एखादा वेगळा मित्र असू शकतो, पिक्चर बघण्यासाठी आपला एक वेगळा फ्रेंड असू शकतो. आपण आपले आनंद वेगवेगळ्या गोष्टींमध्ये शोधला पाहिजे. मला असं वाटतं की मी जर माझ्याबरोबर आनंदी राहू शकत असेल तर त्याच्यासारखं काही नाही. कधी कधी अशी वेळ येते की कोणीच आपल्याला भेटत नाही. मी बऱ्याचदा डिक्लेअर करतो की मी आज पिक्चर बघायला जाणार आहे, कोणी येणार आहे का असं मी विचारतच नाही. 80% पिक्चर मी माझ्या आयुष्यातले एकट्याने बघितलेले, आता त्याच्यातच जास्त आनंद मिळतो. वाद होतात घरी आल्यावर, बायको विचारतो एकट्यानेच पिक्चर बघितला, म्हटलं नाही 150 लोक होते स्क्रीनवर काय चाललंय ते बघायला शेजारी कोण बसलं काहीच करत नाही. सो हा जो मी टाईम आहे, लोकांना मी टाईमची कन्सेप्टच कळत नाही. मी टाईम म्हणजे अरे मी व्हॉट्सअपवर ऍक्टिव्ह आहे, सगळ्यांशी गप्पा मारतो, दॅट इज नॉट युअर मी टाईम. मी टाईम म्हणजे फक्त मी माझा आहे. आणि त्यावेळी मी पुस्तक वाचेल, गाणं म्हणेल, एखाद्याला वाटलं तर तो अजून अर्धा तास जास्त गरम पाण्याने आंघोळ करेल, पण तो माझा आहे. त्या वेळात मी कोणाशी कनेक्टेड नाही, काही नाही. तर आपण आपल्याबरोबर पण थोडंसं आनंदी राहायला शिकलं पाहिजे, थोडे छंद जोपासले पाहिजे. बऱ्याच गोष्टी ॲक्टिव्हिटीज करायच्या राहून गेलेल्या असतात. कोणी कॉलेजमध्ये छान गाणं म्हणत असतं, कोणी ॲक्टिंग करत असतं, कोणाला वाटलं तर या आपण परत एखादं छानसं नाटक बसवूयात. तर हे आपले आपले छंद आपण जोपासले पाहिजे. त्याच्यामुळे सुद्धा मला असं वाटतं की निरोगी मन हे निरोगी शरीरासाठी फार आवश्यक आहे आणि त्यासाठी आपण वेगळी मेहनत घेण्याची गरज आहे. बरेच सायकियाट्रिस्टकडे पेशंट किती 15% लोकांमध्ये मानसिक आजार आहे असं म्हटलं जातं. 70 लाखाची नाशिकची पॉप्युलेशन आहे आणि आम्ही 22च लोक आहेत. आम्ही विचार करतो बाकीचे पेशंट गेले कुठं, माझ्याकडे काही गर्दी नाही आहे. थोडंसं आजूबाजूला फिरलात त्र्यंबकेश्वरला गेलात, पुढे मंदिरात गेलात, पुढे सत्संगाला जाऊन बसलात, तुम्हाला दिसतं की बरेचसे लोक आपल्या आयुष्यातले प्रॉब्लेम सॉल्व्ह करण्यासाठी तिथे जातात. काही तासन तास फक्त टीव्हीवरच्या बातम्या पाहतात, पण त्याच्याने काहीही प्रॉब्लेम सॉल्व्ह होत नाही. मला असं वाटतं की हा माइंड जिम फार महत्त्वाची आहे. आपण आपल्या मनासाठी काहीतरी केलं पाहिजे. प्रायमरी केअर अँड सपोर्ट, तुम्ही सगळे तुमच्याकडे पेशंट येतात, चांगली हिस्ट्री घेतली आणि एम्पॅथेटिकली जरी आपण पेशंटशी बोललो ना तरी खूप पेशंटला बरं वाटतं. हो, मी समजू शकतो तुला काय होतंय किंवा तू कुठल्या अवस्थेमधून जात आहेस. ते बऱ्याचदा काय होतं, अरे खूप लोकांना होतं, काय टेन्शन नॉर्मल आहे. मला असं नेहमी प्रश्न पडतो की समजा फिमेल गायनेकॉलॉजिस्ट आहे हू हॅज अचीव्ड हर मेनोपॉज आणि तिच्याकडे पेरिमेनोपॉझल पिरियडमध्ये जर फिमेल आली तर ती तिला सांगताना काय म्हणेल? काय नाही, माझं म्हणून गेलं 2 वर्ष, त्रास नाही घ्यायचा, टेन्शन नाही घ्यायचं. पण मला असं वाटतं की त्याच्याने बऱ्याचदा काय होतं पेशंटला की डॉक्टरला नक्की कळतंय का मला काय होतंय. कारण प्रत्येक इंडिव्हिज्युअलचे रिस्पॉन्सेस वेगळे असतात. म्हणजे एखाद्याला एखादा काटा टोचला तर काय होणार नाही, तो ठीक आहे काटा टोचला काढून देईल. पण एखादा माणूस काटा टोचून निघून जरी गेला तरी कितीतरी वेळ त्याच्याकडे बघत रडत बसू शकतो. त्यामुळे आपल्याला काय वाटतं हे न बघता त्या पेशंटला त्यावेळेला काय वाटतंय ते बघणं जास्त महत्त्वाचं आहे. यू शुड बी एबल टू पुट युअर सेल्फ इन अदर पर्सन शूज. डोंट वॉक विथ द शूज बट ॲटलीस्ट पुट युअर सेल्फ इन द पर्सन शूज. म्हणजे ते नदीत पाय टाकून बसण्यासारखं आहे. तुम्हाला प्रवाह कळला पाहिजे, गार की गरम आहे तेही कळलं पाहिजे. डोंट जम्प इन द रिव्हर. कोणाला वाचवण्यासाठी लगेच पाण्यात उडी मारण्याची गरज नाही. अदरवाइज इट विल बी व्हेरी पेनफुल फॉर ईच वन ऑफ अस ट्रीटिंग एव्हरी पेशंट डे इन अँड डे आउट. So empathy is very important for all our specialties so that we can understand what the patient is going through. आणि empathetically बोललं ना की पेशंटला ॲटलीस्ट एवढं तरी वाटतं, चला डॉक्टरला समजलं तरी. डोंट गिव्ह म्हणजे बोलत असताना किंवा काउन्सिलिंग करत असताना हा काय सांगतो असं होतं, अरे अरे सरप्राईज. पेशंटला जर असं वाटलं की डॉक्टरला आश्चर्य वाटतंय माझे लक्षण ऐकून, तर त्याला असं वाटतं त्याच्याकडे असा पेशंट आलाच नाही. हो, समजू शकतो. असे पेशंट आले आणि ते बरेही झाले, त्याला म्हणलं हा याने असे खूप सारे बरे गेले. सो दिस एम्पॅथी इज व्हेरी इम्पॉर्टंट. आणि प्रोप्रेनोलॉल्स आधी जर आपल्याला असं वाटलं की अँझायटी आहे, वर्किंग पॉप्युलेशन आहे, सिप्लारेले 20 मॉर्निंग डोसमध्ये, एटिझोलाम वर्किंग पॉप्युलेशनमध्ये, टोफिसोकाम अँक्झिओलायटिक आहे 50 मिलीग्रॅमची, सिडेशन येणार नाही. झोपेचा प्रॉब्लेम असेल तर क्लोनाझेपाम आहे. अल्प्राझोलमकडे जाऊ नका, कारण ते त्याचा डोस नंतर ते पेशंटच स्वतः वाढवत जातं आणि परत भेटत नाही. आणि डॉक्टर लोकांसाठी सगळ्यात मोठी प्रॉब्लेम अशी झाली की आपले मेडिकलवाले जे आहेत ते खूप हुशार झाले. मला काल एक पेशंट भेटला ज्याने मला कंप्लीट महिनाभराचा BP चार्ट दाखवला. म्हटलं वा तू हे सगळं घरी केलं? नाही म्हणे माझा फार्मासिस्ट आहे. त्याच्याकडे गेलं की तो माझा BP घेतो, ह्या सगळ्या रेकॉर्डवर ठेवतोय आणि त्याने सांगितलं की हे डॉक्टरांना जाऊन दाखवतो नंतर, पण मला आज त्रास होत होता म्हणून त्याने मला ही सिप्लर घ्यायला लावली, कारण तुम्हाला यायला 2 तास होते. आपलं काम ऑलरेडी कोणीतरी घ्यायला सुरुवात केलेली आहे. खूप सारं आपण त्यांच्याकडे नको देऊया. तर काय मेडिसिन देतोय आपण पेशंटला आणि त्याला लवकरात लवकर त्याच्यापासून मेडिसिनपासून बाहेर पण काढायचं आहे आपल्याला. वी डू नॉट वॉन्ट टू प्रिस्क्राईब इन फॉर लाईफ टाईम. आणि जर असं वाटलं की या सगळ्यांबरोबर डिप्रेशन आणि काही ओसी सिम्पटम्स किंवा जसं मॅडमने सांगितलं की बाकीचे सिम्पटम्स रिलेटेड टू हार्मोन्स नाही आहेत, पण सायकोलॉजिकल जास्त डिस्टर्बन्स आहे पेशंटमध्ये, तर सायकियाट्रिस्ट म्हटलं की पेशंट कदाचित म्हणजे बापरे मी कसं काय सायकियाट्रिस्टकडे जाऊ. तर तुम्ही काही वेगळे शब्द वापरा. मी माझ्या बोर्डवरती सायकियाट्रिस्ट अँड काउन्सिलर असं टाकलेलं आहे. लोक काउन्सिलरकडे जास्त येतात आणि मी हळूच सायकियाट्रिस्ट म्हणून 2 औषध देतो. कारण त्यांना तिथे आल्यावर समजून सांगणं सोपं असतं. बाबा रे फ्रॅक्चरसाठी डायरेक्ट फिजिओथेरपी नाही करता येत. तुला आयदर प्लेटिंग करावी लागेल, नेलिंग करावी लागेल, 4 दिवस प्लॅस्टर ठेवावं लागेल, फिजिओथेरपी करू आपण. पण आज तू मग तो अच्छा ठीक आहे, म्हणजे किती दिवस, हां 2-3 महिने तर गोळ्या खा, 2-3 महिन्यात त्याला लक्षणं गेली की त्याला कॉन्फिडन्स येतो, पुढे 6 महिने पण खातो, प्रॉब्लेम नाही. पण डे 1ला जर त्यांना आपण आधीच सांगितलं की नाही काउन्सिलिंगची गरजच नाही, तुला गोळ्याच खाव्या लागणार, तर म्हणतो डॉक्टर बदल. तर ह्या पद्धतीने आपल्याला पेशंटला समजून सांगायचं आहे, आधार द्यायचा आहे. आणि मला असं वाटतं की बोलणंच जास्त महत्त्वाचं आहे. आपण त्यांना बोलून किती आधार देऊ शकतो ते. आणि जसं प्रत्येकाचं चार्ट वेगळा आहे, प्रत्येक पेशंटची डिटेल हिस्ट्री हार्मोनची जशी घ्यायची तशी प्रत्येकाची पर्सनॅलिटीप्रमाणे, प्रत्येकाच्या इंडिव्हिज्युअल कॅरेक्टरप्रमाणे त्याची लक्षणं बदलणार आहे. त्यामुळे आपल्याला त्याची टेलर मेड थेरपीच द्यावी लागते. आणि हे आपल्याला खूप सारं हिस्ट्री घेऊन आणि खूप सारं काउन्सिलिंग करूनच शक्य होतं. मला असं वाटतं की आपल्यापैकी बरेच लोक बिझी असतील, त्यावेळेस त्यांना त्यांच्या ओपीडीमध्ये तो किती वेळ देणं शक्य होईल माहीत नाही, पण यू कॅन ट्रेन अ पर्सन इन युअर हॉस्पिटल. बरेचसे क्लिनिकल सायकोलॉजिस्ट मुलं मुली दरवर्षी पास होतात, त्यांचं छानसं ट्रेनिंग घेऊन मेडिकल सोशल वर्कर आहे असा एक जरी माणूस आपण क्लिनिकमध्ये ठेवला, 1 महिन्यातून 15 दिवसातून असे स्पेसिफिक त्यांचे सेशन्स, ग्रुप थेरपी जरी आपण केले, तर मला असं वाटतं एक चांगला ग्रुप तयार होऊ शकतो आणि ह्या पेशंटला आपण एक चांगलं लाईफ देऊ शकतो. तुम्ही मला बोलवलं त्याबद्दल पुन्हा एकदा तुमचे आभार मानतो.
थोडं मराठी बोला असं वाटतंय आता. म्हणजे एकमेकांशी बोलून आणि एकमेकांचं ऐकून बरेचसे प्रॉब्लेम सॉल्व्ह होऊ शकतात. मी रिक्वेस्ट करते डॉक्टर ठोळे सरांना, जेजूरकर सरांचा सन्मान.
सर इकडे. येस इकडे सम.
Next topic, that is sexuality at and after menopause. I request Dr. Manish Mahajan. He is obstetrician, gynecologist, endoscopist and cosmetic gynecologist practicing in Mumbai, Thane and entire North Maharashtra. So I welcome you, sir.
Yes, thank you madam for giving me this opportunity to talk on this particular subject. After reading this title, I was really confused what I should talk about, but then I am going to talk about the libido and the treatment or management plan for it, and the role of cosmetic gynecology into that. So firstly I will start with certain facts that irrespective of gender, irrespective of gender, we have to consider that sexuality is an essential part of a healthy life, even in advanced ages, boost one's self-esteem, intimacy and couples relationship. Beyond procreation, it is also a source of pleasure and serves as a natural relaxant. Sexual dysfunction can lead to reduced quality of life. Sexual dysfunctions are more common in women, that is 43%, than in men. Satisfactory sexual function creates positive self-worth and self-image, and sexual pleasure is an integral part of the well-being. So coming to the menopause and sexuality, with the improved health care, there is improved life expectancy, and most women are expected to live at least 1/3 of their lives in menopause, that is almost 25 years or plus. So with increased expectation for longer and healthier life, people are now more focusing on the quality of life issues, including improvement in the sexual function. Nowadays there is a trend of late marriages, so the sexual life can continue even after menopause. There is rising awareness about the sexuality as well as sexuality awakening. It is not just like the childbirth and reproductive age is complete, one should end up the sexual life. And most importantly, there is advances in the treatment of male sexual dysfunction in a very promising way. So the erectile dysfunctions, they are improved, and so there is need of women also to have the active sexual life. Unfortunately, menopausal sexuality is frequently neglected, ignored, misunderstood and even disapproved. And the general attitude is there is a tendency to assume that the women lose interest in sex after menopause, which is entirely untrue. And there are these papers which mention that sexual satisfaction was a good predictor of a global life satisfaction in older adults, as well as the older the elder women, they have reported the high level of satisfaction with the active sexual life. Similarly, certain other studies like the SWAN study, it has reported 76% of the menopausal women reported that sex is moderately to extremely important to them. So other study has mentioned that 56% menopausal women are sexually active, but sexual activity and function decline with the advancing age. The short personal experience questionnaire that has demonstrated that 42% of perimenopausal women having sexual dysfunction, which becomes 88% in 8 years. So premenopausal sexual dysfunction, which is said to be 43%, has increased to 88% after 8 years of menopause. However, many studies report that there is a decline in all phases of sexual response as well as high level of the sexual distress as a consequence of aging and or menopause. The prevalence is high, 68 to 85%, 86%. Pathophysiology is simple. We are discussing since morning that it is the precipitous fall into the estrogen levels, and it is absolutely conversion of Drakshatun Manuka stage of all urogenital systems. So the vasomotor, it is like that, the atropic changes are tremendously, markedly noticeable. Vasomotor instability, the anatomical changes, the atropic changes, we all gynecologists are very well aware of. The physiological changes, especially the pH changes, the dryness and the reduced blood flow, they all affect the sexual function, so the sexual drive. Changes in the urological tissues, I wanted to highlight one point that premenopausal and postmenopausal SUI, what is the difference? So in premenopausal SUI, mostly the anatomical reason is the cause, that is the hypermobility of the urethral neck, while in the postmenopausal SUI, mostly the important reason is intrinsic sphincter function, and that may not be corrected with our sling surgeries or burst corpus suspension. Then changes in the pelvic floor, the weakness, and the neurophysiological changes, which we are not knowing most of the times. So the sex steroid hormones exert both organizational and trophic effect within the genitals, influencing brain responsivity and modulating the threshold of the tissue response to the stimuli. Menopause-related low sex steroid level results into the changes into certain brain areas, which correlates to the menopause-related decrease in sexual arousability. And this functional MRI highlighted a lower activation in postmenopausal women in thalamus, amygdala, and anterior cingulate cortex following visual sexual stimulation. So estrogen is affecting these factors also. Now coming to the specific sex steroid hormone and their roles. So they play a major role in positively modulating sexual behavior, mood, emotions and cognition throughout the women's lifespan. Declining level during perimenopause and extremely low level in the postmenopause are associated with the detrimental consequences on overall and sexual well-being. Now coming to the estrogen specific, the low estrogen level adversely affects sexual interest as well as responsiveness, but there is no effect on the frequency. It results into exacerbation of the effect of aging on the cognitive function. Menopause accelerates aging, and that is because of the hypoestrogenism. Estrogen stimulates several neurotransmitter systems in the brain regions involved in sexual behavior, including dopaminergic transmission. And estrogen as well as androgen, they exert synergistic stimulatory effect on the female sexual response, promoting sexual desire through a complex network of neurotransmitter and the balance between dopaminergic and serotonergic, that is excitatory and inhibitory signals. Now coming to the androgen, even with the sharp decline in the estradiol during the menopausal transition, the circulating androgen seem to remain stable. That is because of the peripheral conversion of androstenedione that we already learned about. The serum level of androgen exceeds those of estradiol, suggesting that androgenic hormones play important role in maintaining sexual activity as well as libido. So the generally libido may not be affected if it's a purely hormonal dynamics is considered. The other factors are also there. There is no significant difference in the testosterone level was observed in women having sexual dysfunction versus women showing no dysfunction. So it is related to libido only, but not responsible for dysfunctions. The Vishesh study, it demonstrated clearly that surgical menopause women show significantly higher hypoactive sexual desire disorders as compared to the gonadally intact due to abrupt reduction in the circulating 17 beta estradiol and testosterone level. And this is why we should have high threshold against removing ovary. Just her age is 45, 50, and we are thinking of why she don't need any ovaries. It is not true. Androgen therapy may be considered in women who have undergone surgical menopause, because testosterone is not FDA approved, but it is used right and left, off label, and it should be considered, the right candidate for use of the testosterone is the people who have undergone bilateral oophorectomy. Now, sexual drive affected by psychological, social and economical factors. So beyond hormones, beyond estrogen, hypoestrogenism, there are many other factors. Dr. Nilesh excellently covered all these things. So these parameters like self-esteem, optimism, satisfaction with the relationship and emotional support significantly predict overall sexual functioning, and a specific sexual domain like arousal, contentment, orgasm and pain. Financial strain is one of the very important factor, which is more likely to report decreased frequency of the sexual desire and arousal, lower level of emotional and physical satisfaction with the intercourse with the people having financial stress. Comorbidities, we all know, they have a significant negative impact on the sexual function in the postmenopausal women. The other factors which can result into the poor libido are partner and relationship issue, the relationship distress, conflict with partner, divorce, aversions, infidelity, lack of partner, sexual behaviors and sexual problem of the partner, sexual violence, sexual abuse. Then there are domestic reasons, family dynamic, domestic issue, lack of privacy. In the most of the elderly couple, they are not given enough privacy, at least apartment culture. The bedrooms are reserved for the couple, the children, and the in the hall the parents or elderly people are using. Then the orthopedic pains, apart from the dyspareunia, could be the significant reason for poor sex drive. The body image, as in obesity, or poor self body image as per the different body disfigurement. Then overall psychological health like emptiness syndrome, which was mentioned earlier, poor energy level, religious and cultural orthodoxy. मेनोपॉज नंतर काय करायचं, चारधाम यात्रेशिवाय म्हणजे ह्या गोष्टी आता तुम्हाला सुचतात तरी कशा. This can be the very basic attitude, and so the sex is sinful, guilt with the sexual activity after the menopausal period. Then there is medications which can affect libido, the SSRI, neuroleptics, cardiovascular medications and antidepressant. So generally this is summarized as predisposing factor, precipitating factor and maintaining factor, and everything is again evaluated on the basis of biological, psychosexual and contextual factors. So predisposing factor, they constitute constitutional and developmental influence that render a person susceptible to dysfunction. Then the precipitating factor, they include event, situation and or comorbidity that are more directly linked to the development of dysfunction. Menopause itself may represent as a biological precipitating event, and the maintaining factor, the other factors which are responsible for advancing this particular dysfunction. So this is our basic different models of female sexual response cycle, which has component of desire, excitation, orgasm and resolution, and accordingly there are sexual dysfunction, orgasmic disorder, female sexual interest arousal disorder, sexual pain penetration disorder. But in the simplest way, how we can diagnose, there are poor desire, diminished vaginal lubrication or dryness, pain or discomfort during intercourse, difficulty in achieving orgasms and impaired overall sexual satisfaction. Now, I have summarized how menopause results into sexual difficulties or female sexual dysfunction. Androgen estrogen deficiency, negative genital image, hot flushes, sleep deprivation, mood changes, anticipating dyspareunia, comorbidities, and there are certain medications as well as partner issues, they can result into poor libido. Other sexual dysfunction I have mentioned only because it can ultimately result into poor libido. And poor lubrication can result into poor or absent arousal. Yes, the thinner and less elastic vaginal wall, short vaginal and narrow vaginal wall, poor vascularity, poor lubrication and easy bruising, easy infection and bleeding during the intercourse or with the use of sex toys can result into dyspareunia. And the poor vascularity, poor lubrication, atropic changes with the poor sensation because of the neuronal atrophy and poor frequency or absent orgasm that results into orgasmic dysfunctions. So management principles, management sutras. So detailed interview using questionnaire like FSFI. This cannot be like 5-10 minutes consultation. You have to dedicate a separate time for evaluating these kind of problems. So psychoanalysis and counseling, examination, relevant investigations, and spotting the root cause and treat accordingly. Once the root cause is spotted, then this is the proposed flow chart for the management of sexual dysfunction in menopause. The first line approach is addressing modifiable factors. Basically, it is a health education and involving the partner and non-pharmacological interventions. For mild symptoms or contraindication to the hormonal therapy, vaginal lubricants or moisturizers can be prescribed. Off-label laser therapy, but nowadays certain FDA approval has been there for the use of lasers. Pelvic floor physiotherapy, dilators, sex therapy, and the cognitive behavioral therapy. For moderate to severe symptom not responsive to non-hormonal treatment, then we can think of local estrogen, DHEA, transdermal testosterone, which is off-label, and the combined central nervous system agents like flibanserin and bremelanotide, which are not freely available in India. And moderate to severe dyspareunia not eligible for local estrogen, then oral sums and all this. And here probably the role of cosmetic gynecology is much more. Dr. Rumi Patel sir asked, like in a patient having CA endometrium, what means should we use estrogen or not? And in that particular patient, we can definitely use PRP, which we have learnt in one workshop. I am going to highlight certain points in the treatment. The psychological counseling, we have to learn, and there are online courses which are like 1 month course or something, and they are really beneficial. They can give a lot of benefit to your patients. The cognitive behavioral therapy, the rational emotive behavioral therapy, and the transactional analysis. Solely or in combination with the medical treatment, this counseling can help the woman or couple suffering from sexual dysfunction. It can help couple to identify the relationship issues contributing to the sexual problem and allow opportunities for couple to improve the communication. And issues like relationship issues, extended period of sexual abstinence, sexual abuse history, and taking care of an elderly parent can all impact the sexual function. And behavioral exercise may help individual to reduce anxiety associated with the sexual functions. So when GSM,
we just have last 2 minutes.
yes, so when there are GSM symptoms, then the first line therapies are lifestyle modification, in which you can prescribe sex. Maintaining the sexual activity is itself is a treatment for GSM. So then education, use of lubricants with the sexual activity, long-acting vaginal moisturizers, gentle vaginal stretching exercises, low-dose vaginal estrogen, DHA insert, SERMs, and we have learnt about the systemic, when we should use the systemic menopausal hormone therapy. Moisturizers and lubricants, the moisturizers are used for chronic maintenance. They are prescribed regularly. They have ability to retain and accumulate water, and they causes hydration of the tissues, and they provide quick relief from the vaginal burning, itching, irritation. They are generally hyaluronic acid based. While lubricants, they are used for the momentary use, for the intercourse or for reducing the friction during coitus. They can be used by both the partners, and they are water based, silicone based, or oil based, oil or glycerin based. Then I will not, this local estrogen, systemic estrogen, we have learned already about it. Testosterone, other agents are used with the variable success. Testosterone, as I said, it is not currently FDA approved, but still it can be used in oophorectomized patient. Means in that particular class it can give a lot of benefit. Flibanserin, bremelanotide, it is used, it is approved for premenopausal women. So perimenopausal women with poor libido, because it targets the brain circuit that mediate motivation, interest and desire of sex. Then this dilator, sensate focus therapy, Botox, whenever there is pain associated poor drive. And the role of cosmetic gynecology, which is treating FSD as well as enhancement of the normal sexual function, and it includes PRP, stem cell therapy, energy based devices and carboxytherapy. Now this cosmetic gynec therapies, how they can improve the drive, they improve physiological parameters. These all pH, epithelial thickness, strengthening of the urogenital tissue, improved vascularity, improved elasticity and stretchability, improved resistance to infection, sensation with the neuronal regrowth, improved self-body image, self-genital image and improved confidence, improvement in the dryness symptoms, correcting or reducing the grade of SUI and laxity, and abolishing or reducing pain and pain element by the various mechanisms. So there we have PRP, then energy based devices. Can I show this video? This is O shot and G shot therapy. The arrows which are shown in the pictures. So at clitoris 1 cc, at skin's gland half cc each, and at the G spot 2 cc or intervaginal wall. This is how it is done. This is the same video, and this is the vaginal rejuvenation. For the GSM symptom where estrogen is contraindicated, we are guarded for the use of estrogen, then we can highly think of this option, and which is very easy to prepare the PRP, and we just have to inject at multiple places, and you will be surprised the level of satisfaction or improvement in the patient's complaints. Now, for this kind of patient where there is a complete labial adhesion, estrogen doesn't help much because estrogen acts on the mesodermal element more rather than ectodermal element, and the outer 1/3 of the vagina is this vulval element. It is ectodermal in part. So rather than estrogen, this newer treatments, they can be more helpful, and PRP is giving excellent result. And beyond PRP, we can use bone marrow derived stem cells or adipose derived stem cells. Now this is something new. Now we know this ovarian PRP for the premature ovarian failure, for for fertility enhancement, but the success rate is said to be 29%. But let me tell you, this reduces the FSH tremendously. Even if it will not improve the fertility, but definitely it will contribute to the estrogen, endogenous estrogen, and we should start thinking of this option also. So I will skip this slide. So there is lasers and HIFU, and then there is a carboxytherapy, injecting carbon dioxide in a small quantity, which will result into improvement of the blood flow. It encourages the neoangiogenesis, and this can be in the similar way which we are seeing in the stretch mark. It can be done at a clitoris in the vaginal mucosa, and it is also effective. So as a gynecologist, give confidence to your client to speak up the unspoken problem. So this is the board in my OPD. This is after suggestion from one of the lecture by one of the good teacher. Put a board which writes like something like, feel free to ask sexual concerns if any, or do you face problem of urinary leakage, and you will be surprised that people will start reporting their problem themselves, and this is how you can initiate a talk on that. So also high threshold for not doing the oophorectomy, doing the hysterectomy. So practical sutras to treat the sexual difficulties or FSD in menopause. So with the poor libido, we have psychoanalysis, sex therapy, sunset focus therapy, finding root cause and treat accordingly, and roll up menopausal hormone therapy, not HRT as we say, and testosterone. Then poor arousal, dyspareunia and orgasmic dysfunction accordingly. For orgasmic dysfunction, it should be highlighted that clitoral stimulation is most important. In this chart, the fantasy alone and stimulation above the waist, it has very less percentage of the orgasm, while the lower whatever is, so the clitoral stimulation, it should be, so people facing they have single partner or facing orgasmic dysfunction, this particular concept is very important. So to summarize, sexuality is an integral part of healthy life. It should not abruptly come to the end with the onset of menopause. Satisfaction with different aspects of sex strongly associated with the general health and sexual quality of life. Female sexual dysfunction in menopause are rooted in a wide range of predisposing, precipitating, maintaining factors of different origin, and menopause itself represents a biologically precipitating event. Open discussion, accurate evaluation considering different cultural and social beliefs seem to be more critical steps for an early and effective therapeutic management of female sexual dysfunction. An integrated approach is needed, and the proper intervention strategy for early prevention and promotion of the healthy sexuality in menopause. So thank you.
Thank you, sir. Please accept a little token of appreciation from Energies. Turmoil all women are going through, whether men have similar symptoms or similar difficulty in negotiating their midlife. So I invite Dr. Raviraj Khairnar. He is a practicing obstetrician and gynecologist in Nashik since last 24 years.
हॅलो, गुड आफ्टरनून. सकाळपासून सगळे टॉक्स ऐकताना आता मला थोड्या वेळ असं वाटायला लागलं की आपण तो नवीन पिक्चर लागला तो बघायला आलो. बाईक पण भारी आणि सगळ्याच बायकांचे प्रॉब्लेम डिस्कस होत आहेत, काय त्रास होतोय त्यांना बिचाऱ्यांना. नाव सुद्धा मेनोपॉजच आहे, त्याच्यात माणसाचंच नाव आहे परत. म्हणजे फिगोला मला रिक्वेस्ट करावीशी वाटते की जसं इनकम्पिटेंट हॉर्सचं नाव बदलून प्रिमॅच्युअर ओपनिंग ऑफ हॉर्स केलं होतं आणि IUGR मध्ये रिटार्डेशनच्या ऐवजी रिस्ट्रिक्शन शब्द आणला होता, तसं मेनोपॉजच्या ऐवजी विमेनोपॉज म्हणायला काही हरकत नाही. कारण उगाच त्या पुरुषांनाच परत दिलेलं होतं की हे तुझं तुमच्यामुळे होतं, बरोबर? तेच तर गंमत आहे, तेच ना, त्याच्यातही मेन आहेतच. सो does male menopause exist or it doesn't exist? याच्यात दोन मतप्रवाह आहे की काहींना वाटतं की पुरुषांना काय दाढवली, त्यांना काही होत नाही, आणि दुसऱ्या बाजू यांना कधी अक्कल येणार, यांना कधी कळेल की आता तुमचा मेनोपॉज आलेला आहे, आता शांत राहा. तर there are two kinds of people. There are opponents of it and there are proponents of it. Let's discuss about it and we can come to a conclusion regarding it. So what do the opponents think about this? They are very simple. They have very one simple sentence for this. मर तो कुछ दर्द नहीं होता है, बिचाराला काही त्रास होत नाही. And why do they think so? This is not because of the bombardment that is going on since childhood to manhood and again the old age also. Wherein they are always fed की नाही तुम्हाला काही त्रास नसतो, जो काही त्रास असतो तो फक्त बायकांना असतो. आणि the stories in the media की ह्या 70 वर्षाच्या माणसाला मुलबाळ झालं, they can reproduce at an elder age also, so they don't have any problems, right? Then there are novels which we have been filled with. ज्ञानपीठ पुरस्कार विजेते विसा खांडेकरांचं नॉवेल ययाती. That this person is longing for his youth throughout his life, asking his children to give their youth to him, and he's going ahead with his lust ahead. So all because of these conceptions. What is the awareness about menopause in males? Let's see. I found very few studies regarding menopause about males. One is a North Indian study, another is a Iranian study, then there is a European study also. The North Indian study done by Mr. Manish et al. They found they studied 757 patients and only 2.2% people were aware that there is something called as andropause, or there are various nomenclatures about it. So such is the low awareness about male menopause. Then there is the Iranian study by Mr. Farooq Salipur, and they found that the awareness of andropause was very, very low amongst all the people above the age of 40. Even the male person did not know that he is going through a phase of menopause. Why this happens? Because in women there is a defined role की 45 नंतर हे असं असं होणार आहे, तुला माहिती आहे, हेल्थ ग्रुप्स आहेत, सायकियाट्रिस्ट सांगायला आहेत, डॉक्टरकडे गेल्यानंतर गायनेकॉलॉजिस्ट तुम्हाला सांगतात की 45 झालं हा आता तर हे होणार आहे. In men the problem is different. The problem is this, that there is no defined age, there is no defined way, there is no defined symptoms which can tell you that yes, you are undergoing menopause. बायकांना एक बरं असतं की आता पाळी बंद व्हायला लागली की त्यांना कळतं आता फ्यूज आपला ऑफ होतोय, म्हणजे आता काहीतरी चेंजेस होणार आहेत, तर आपल्याला सामोरे जायचं आहे. ऑफ होतो म्हणजे फक्त मेन्सच म्हणतो, असं पुरुषांच्या बाबतीत होत नाही. म्हणजे काय होतं की सहज होते आणि सांगता येत नाही, हे म्हणतात ना जाहिरातीमध्ये येतं, तशी काहीशी अवस्था पुरुषांची असते. द मोस्ट इम्पॉर्टंट थिंग इज they are not aware of all these symptoms. Now there are various nomenclatures. The Greek word andros means the male, human male, and pause means cessation, or it is also called as male climacteric. Surprisingly, in 1946, Mr. Vendra designed this word as early as 1946. कि पुरुषांना त्रास होतो, and this was called as male climacteric. Then there is androclize. Recently, the androgen decline in aging male has been well documented, and the late onset hypogonadism, that is the word that is latest in the vogue regarding male menopause or andropause, that is LOH, or symptomatic LOH. There is another symptomology, SLOH, where there are symptoms about late onset hypogonadism in males. So the definition, now again in definition the problem comes with that the men, in case of men, it is again considered with their sexuality. So as you can see in definition, it is associated with decrease in sexual satisfaction. And there is decline in the feeling of well-being. Now this second sentence I think is more important in this definition, which is often ignored by the person himself, the relatives, the families and the peers. There is decline in the feeling of well-being, and this is associated as to be proven with low levels of testosterone. Then you can label it as andropause or LOH. And unlike menopause, as I said earlier, it is insidious in onset and the symptoms are very slow in progression. So what is the prevalence of this LOH? It starts as early as the age of 30 years, mind you. It's quite surprising to know, but yes, you will see young males. Recently I saw an interview of one guy who takes interviews of all the celebrities. He was taking an interview with Vidya. Her recent movie is coming, Niyat. And he told that his colleagues who was in the age of 35 and 40, they are suffering from symptoms of erectile dysfunction. The main reason being emotional stress. Second is financial instability. Third is alcoholism and use of drugs. And so as early as this, the symptoms are seen in many of the patients. Yes, this was the earliest study which was showing 3 to 7%, but I am sure this will be quite more in our country because we don't ask. And for a male to tell that he is losing his virility is something very म्हणजे आपणच वाटतं त्याला तो सांगत नाही कोणाला. त्याच्यामुळे तर प्रिव्हेलन्सच्या पेक्षा नक्कीच जास्त असणार आहे असं मला वाटतं. And above the age of 70 years it is more than 18%. So what are the symptoms? Well, they can be classified into various symptoms: the sexual symptoms, psychological, the psychosomatic and the physical symptoms. The sexual symptoms are there is loss of libido, the desire decreases considerably, there is difficulty in arousal. When once arousal is achieved, they can perform very well, but there is difficulty in arousal and there is difficulty in sustaining the erection for a longer time. These symptoms, unless asked to a person in his OPD, in the OPD, the person is not going to tell. So, when a female comes to you for menopausal counseling, please see that the male counterpart is also counseling for the symptoms or not. Then the psychological symptoms, the physical symptoms are there is decrease in the body hair, decrease in the muscle mass. Lot of things were discussed about sarcopenia in women, right? Similar symptoms are seen in male. There is osteoporosis, there is decrease in height, and the quality of the skin is also changed. And then there are psychological symptoms. These are the symptoms which have to be taken care of in male also. There is nervousness, feeling of being ignored in the family. Most of the males who are above the age of 60 are retired people, not we doctors, but other people they retire and they are ignored in the family. And त्यांच्या त्रासाबद्दल कोणीच काही दखल घेत नसतं. So the fatigue, then there is depression, there is impaired memory, insomnia, and inability to concentrate. These are very subtle symptoms. As I said earlier, these are very subtle, they are insidious in onset, and so you cannot pick them up very early. But yes, these are very much part of the male menopause. And the physical symptoms are quite common in everybody, the backaches and the cramps and everything, so I won't go much into it. And why this happens? This is mostly because of the decrease in the Leydig cells. Just like in women, in men it is the decrease in the Leydig cells. As the Leydig cells decrease, there is decrease in the testosterone levels. And the testosterone levels decrease, and simultaneously there is increase in the sex hormone binding globulin. Now I will explain in detail about that also. Now how much is the decrease in the testosterone levels? You can see from this chart that at the age of 25 the testosterone level 100%, by the age of 50 it has come to 50% less. By 60s it has gone to less than 45%. Now this decrease is how much? It is 1% per year. The testosterone levels decline by 1% per year. So if you consider a 30-year-old male, by the age of 50 the 20% decrease in the testosterone level is. That is 10% per decade. So by the age of 60 there will be 30% decrease in the testosterone levels. So once you see this, you will be surprised to see that more number of men will be willing to talk about this, but they don't know where to talk. So there was a European study about this. They had a questionnaire in the OPD where they used to ask the patient to fill that questionnaire and tell what are the symptoms you are feeling amongst this. So these are the common symptoms: loss of libido, difficulty in arousal and sustaining erection. There is decreased muscle mass and strength. The cognitive functions are decreased. There is loss of memory. There is backache, headache, hot flushes and sweating. These are seen in men also. It was quite surprising. And all these symptoms you have to correlate with the testosterone levels. Why? Because a general person can also have symptoms like fatigue, depression. So how do you know that it is only because of menopause and not something else? So always collaborate with the testosterone levels. So how much should be the testosterone levels? The normal testosterone levels range from 300 to 1100. Anything below that, anything below 300 nanogram per ml is something called as low testosterone levels. But between 230 to 300, that is quite a grey zone. In this grey zone, there are patients who can be treated symptomatically or by giving counseling, where they can be helped directly. But below 230, the patient may need testosterone replacement therapy. So always collaboration with the testosterone levels is very important. Now when do you should do the testosterone levels? Because there is circadian rhythm for the testosterone levels also. In young male, in 25 to 30 years old male, in 15% cases, if you do the testosterone levels at a wrong time, you will see the testosterone level will be less. So it is usual timing is 7 am to 11 am when you have to do the testosterone levels. So anything above 350 you don't need to treat with the testosterone replacement therapy. But below that, yes, you have to be aware of it. Now we come to the people who are more susceptible to this. Who are these people? The diabetics and those with uncontrolled hypertension. Now we are saying that India is the capital of diabetes. So we are going to see more of these patients. Similarly, patients who ignore blood pressure. एक महिना गोळ्या घेतल्या आता बरं वाटतं गोळ्या बंद केल्या. So again these are the people. The tablet of hypertension itself can cause some problems if I am not wrong. Yes. Right? Yes. Yes. So again that is one of the reasons. Then excess exposure to plastic. आपण सगळेच आता प्लास्टिकचा वापर खूपच करत असतो. Then those who work in the bakeries, incinerators, आपले बायोमेडिकल वेस्टचे लोक जे वर्कर्स असतात ते सगळे इन्सिनरेटरमध्येच काम करतात. Then the use of pesticides, you should specifically ask the history of moms in childhood. Whom do you ask it? Our infertility patients who come with oligospermia, astenospermia, who have why is this happening? So if there is history of moms, the lady cell count goes down and the testosterone levels also come down. Then of course surgery of testes, that is undescended testes and all can have some issues. And genetic disorders, we are all aware of this. These people can have early hypogonadism. So before you confirm the diagnosis of this late onset hypogonadism, you have to rule out certain other things. That is depression, people with chronic alcoholism, then hypothyroidism, and surprisingly the drugs which can be common is the antifungals, corticosteroids, antidepressants, digoxin. Now these are not the people who are having late onset hypogonadism, but their symptoms mimic the symptoms of late onset hypogonadism. So you have to rule out all this before confirming the diagnosis of menopause. So what is the treatment of this? Most important treatment I personally think is counseling and empathy. First you diagnose it, you have empathy for that person. Yes, you are going through a phase of declining this. Once you accept that, then most of the problem is solved. Secondly is the testosterone replacement therapy. It's a big topic actually, but yes, TRT is very much possible. We will be talking about it in a short while, but this is not part of today's lecture. We have to prove that androgens, does it exist or not. Then diet and exercise, of course, it is the release of endorphins which helps a lot. Lifestyle modification. Obesity itself is one of the deterrents. Increasing the waist size is quite corroborative with the late onset hypogonadism. So that is one of the factors where lifestyle modification plays an important role, and avoiding smoking and alcohol helps a lot. Now there are various TRT preparations, just like HRT we are talking about. There are TRT preparations which are there. What are them? The mesterolone, we are all aware of it. We have been giving it to our patients in oligospermia. This was the first drug we knew about. We used to give to the male patients. That is mesterolone. Then there is testosterone preparation. There is sublingual cyclodextrin we can use. Then there are subdermal patches. Scrotal patches, transdermal gels are available. And just like norplants, there are subdermal implants which are available for TRT. But all these things need proper monitoring. And without that, you cannot give the treatment because there is a risk of prostatic cancer. There is no proven reason why TRT can cause prostatic cancer, but if the early signs are there, they can increase after giving TRT. Then there are various injections, cypronate, proteonate, ethanoate and baculate. The dosage of each injection is different, that's why I have mentioned it over here. And as I said earlier, the lifelong monitoring is very much important. It causes symptomatic improvement. Those should be gradually titrated, and you should do PSA test for all these patients. That is, prostatic specific antigen test should be done in all patients before you start on TRT. So what are the benefits? We have been talking this, does it exist or not? If this exists and we treat the patient, what are the benefits? There is improved body composition and muscle mass. There is increase in the bone density, especially the lumbar bone. Many of them complain of backache, which you don't know why it is happening. But there is increasing lumbar bone density. There is improved libido. Testosterone has positive effect on reducing the risk factors for diabetes mellitus and cardiovascular disease. Now this is again very important, that it decreases the risk of cardiovascular disease. There is improved cognitive function and memory, and improved that, and because of that there is improved social life of the person. That's why we need to know menopause in detail, because after retirement, as I said, the male counterpart is very much neglected and he should be taken care of. He is more prone to osteoporosis and cardiovascular disease. There is loss of virility, which gives him low self-esteem. So there is sexual discontent, loss of libido, and social behavior gets affected. Because of all this, the confidence level goes down, and if you give TRT in such patients under supervision, it might help the person. So all in all, I think it says a lot about andropause, though it is insidious, though it is slow progressing disease, but yes, it should be taken care of. But still, the opponents still might say that work ko dard nahi hota hai. But the proponents do want to say that work ko bhi dard hota hai. Thank you very much.
I welcome Dr. Shivde sir. He is going to talk about healthy aging, which is a very important topic for everybody to know. Please sir.
Very good afternoon to you. I thank the organizers for giving me this opportunity, and I also thank my Enotius family for showering a lot of appreciation upon me for the recently completed Pawan Kinder trek, and perhaps taking a cue from this trek. The organizers have put me in the place of Baji Prabhu because I am standing between you and lunch. Baji Prabhu stood between the Vijaypur army and Shivaji Maharaj, barricading the access to Vishalgarh, and I am barricading your access to lunch. But let me assure you, Baji Prabhu stood in his position for more than 7 hours, but I shall not be guarding this post for more than 15 to 20 minutes. So please bear with me. The photograph which you see in here is 15 years old, and even if I am remotely looking like someone in the photograph, perhaps I am qualified to give this lecture to you. बरचसं सैन्य खिडनीमधल्या चोरवाटांनी पळून गेलेलं आहे, रोखलेलं सैन्य त्याला तरी थांबवून धरायचा मी 15 मिनिटं प्रयत्न करणार आहे. So we are looking at something which is called as healthy aging. Now let us understand what is aging, because human beings have been living on this planet for millennia, and they have been aging also for several millennia. And like all other things, our Indian culture has also given a lot of thought on aging and old age and death and maintaining our health. So let us first consider what our ancestors thought about aging and our health. Let us define what is aging first of all. What is healthy aging? Healthy aging is the process of developing and maintaining functional ability that enables well-being in older age. So that is clear, that is what is healthy aging. Now what is exactly meant by functional ability? So that brings us to this slide. Functional ability is basically health related attributes that enable people to be and do what they have reason to value. So if you feel that you feel like going for a trek, you are able to do it. You feel like going for a job, you are able to do it. You are able to go for a trip, you are able to go for shopping, you are able to enjoy life with your family members, you are able to go on a picnic, you are able to go around in the house. All these things are things which you value, and if you are able to do all these things, then you are functionally able. That is simple definition of what is functional ability. And healthy aging is the process of developing and maintaining this functional ability. Now there are several domains of functional ability. It's a complex phenomenon. You are able to move about, you are able to, it is not just about physical health or physical fitness. Functional ability involves so many things. You are able to build and maintain relationships. You are socially active. Your basic needs you are able to take care of, like your roti kapda makan. It is not just a static thing, getting old. You are still learning. माणूस आयुष्यभर विद्यार्थीच असतो. So you are learning, you are growing, you are able to take your own decisions, and ultimately you are able to contribute something to the society even in your old age. Because you may survive even up to 100 years, just as a crow survives on offering at the funeral, which is called as kakabali. Kapopi jivati chiraya balincha bhunte. That is not the kind of life which you would like to lead in your old age. This is a quotation from Hitopadesh. So that is the comprehensive and holistic approach towards healthy aging. Now our body is basically a machine. It's just like a car. It's going to run down in the course of time. The very word sharir is derived from the Sanskrit word shiryate. Shiryate means to wear off, to become shattered, to become broken. And so the body is definitely going to wear down like an old car. Its parts are going to give way, and ultimately there will come a time when the RTO condemns that model and takes it off the road. But till that time arrives, we have to keep the car in good condition. That is the meaning of healthy aging. Our scriptures say that the human body is supposed to last for 100 years. And the erudite scholar which you see in this photograph is Pandit Sridhar Satavadekar. Satavadekar was a great Vedic scholar, and he declared that I have led my entire life in accordance with the Vedas, and so I should survive for 100 years. मी 100 वर्ष जगेन. मी जर 100 वर्षाच्या आत मेलो तर वेद खोटे आहेत म्हणून जाहीर करा असं त्यांनी म्हटलं होतं. And he lived for 101 years, remaining active till the end of his life. There are several such examples. Maharshi Dhondokeshav Karve lived for 104 years, remaining active till his last days. We also have the concept of healthy aging, not just longevity. Though the life is of 100 years, it is not just a burden that we have to carry on. We have to remain fit in the last days, and here is a scriptural verse which talks about maintaining all our bodily functions till the last day. Om Bhadram Karnebhish Shunyam Deva Bhadram Pashe Makshabhir Yajatraha Sthirairangais Tushtamamsas Tanubhi Vyashema Devahitam Yadayu. O gods, let our visual faculties be preserved till the last day. Let our auditory faculties be preserved till the last day. May we see auspicious things with eyes. May we hear auspicious words with our ears. Let us not develop tremors or Parkinsonism. Let our limbs be steady and let us continue to praise God. And the last line is very important. May we enjoy a life which is beneficial to the gods. That is doing something which is useful for the society, beneficial to the society. So that is the concept of healthy aging which is spoken of in our scriptures. The Aryas in their own times were definitely leading this kind of a life and were aging in a healthy manner, but there was a period of decline in which our lifespan decreased to the age of 30 or 40 or 50 years. As you can see all these historical figures, all of them passed away at a very young age, before the age of 40 or 50. Sri Shivaji Maharaj lived up to just 50 years, and all the Peshwas which you see, the great Peshwas, that is Bajirao first, Nana Sahib Peshwe and Savai Madharao Peshwe, did not see their 48th birthday. All of them passed away at the age of 39. The same trend continued even in the British era. All these great heroes, Swami Vivekananda lived for 39 years, Gopal Ganesh Agarkar 39 years, and Ram Ganesh Gadkari, the great dramatist, passed away at the age of 34. Fortunately, things have improved, and since independence, our lifespan has gone up. As you can see here, in 1950, our lifespan, the expected life expectancy was 35 years, and we have been able to bring it up to 71 years in 2023. Now, will this life expectancy go on improving? As you can see here, the bottom line, there is a green line, and initially the life expectancy was rising at a fast rate, but now it has hit a kind of a plateau, a straight line. So that does not mean that with improving medical facilities and with the great strides that the science is taking, our life expectancy is going to become 150 years in a course of say 50 years, because ultimately the body is going to age, because there is a process which is going on in the body. The cell itself, the tissues themselves are undergoing biological degradation, which science has not been able to arrest so far. So ultimately we may reach a plateau of say 90 years. So what medicine has done so far is just reducing the premature deaths which were arising due to epidemics. Basically, the epidemic diseases have been eradicated, and so modern medicine has not extended our life by even a single years. What it has done is to save us from premature death, and now we can enjoy the full measure of our life for at least 70, 80 or 90 years. So now that brings us to the great issue of adding quality to our years, because we are going to get more time to spend on this planet. And the most important factor in adding quality, if you ask me in a single word, I have written it in golden letters here, is resilience. This is the quality. This is the key word to leading a healthy life and aging in a healthy fashion. What is resilience? Resilience is the ability to maintain or improve a level of functional ability in the face of adversity, either through resistance, recovery, or adoption. Now there are several factors which are going to help us in adding quality to years. We shall discuss all these factors in a brief fashion. Health assessment and monitoring, improved nutrition, improved physical activity, cessation of vices, control of comorbidities, maintaining our mental health, and there are several other things like vaccination, sleep, and injury prevention. Now, are we going to subscribe to regular health checkups which have been advertised very frequently by several corporates, giving packages like silver package, gold package, platinum package, consisting of a battery of tests including liver profile, kidney profile, endocrine profile. Many of the patients, because they are getting it through corporates, are taking advantage, and then they collect huge amount of data. They bring big files, not just files, dossiers घेऊन येतात. म्हणजे सगळे गुन्हेगारांचे जसे dossiers असतात ना, तसे मोठे dossiers घेऊन येतात ते, आणि ह्या बघा या सगळ्या टेस्ट मी केलेल्या आहेत. But there is a big downside to it. All of us know the benefits of regular health checkups, which I have enlisted here. These are the pros. These are the pros. Early detection of life-threatening diseases. Okay, we detect breast cancer at an early stage. We may be able to detect a very early ovarian cancer through a USG. There are many other cancers like colonic cancer or pap smear detecting cervical cancer. So these life-threatening diseases may be detected in the first stage, early stage, and effective treatment can be instituted. So that is the greatest advantage. There is increased chance of completing a cure. The risk of complications will definitely be decreased by catching diabetes or hypertension, because these are silent diseases. And ultimately this is going to reduce the cost on healthcare if the disease is caught in an early stage. And secondly, there is an element of health awareness. If a person learns that he or she is having hypertension or impaired glucose metabolism, maybe he or she can modify lifestyle, and that will be beneficial for the patient. And now looking at the downside of the things, unfortunately, all these tests basically are statistical documents. And as all of you know, human body is not running on statistics or mathematics. So many of these values are normal values for a population, and they are based on a large number of individual values. So there is no single value which can be considered as a normal value. And if there is a slight deviation and it is reported in red print, that person unnecessarily suffers a lot of anxiety. And by detecting a small anomaly in all these reports, in rural area there is a proverb, तुम्ही खूप बारकाईने पाहायला गेलात तर बायकांना पण मिशा दिसतात. So that is the kind of thing that happens with these routine packages, and then the doctors embark on a wild goose chase to investigate that anomaly, and ultimately it leads to cause. The patient is put through a lot more invasive and advanced tests, and they pose a risk and may be even harmful to the patient. So rather than going for this kind of a shotgun approach, which can be called as cowboy medicine, it is not a very rational thing to do. Yes, of course, yearly annual checkup or frequent checkups are necessary, and routine investigation should be done, but not just a mindless battery of investigations. The next thing that we talk about is nutrition, and there are of course some factors which have to be highlighted: consumption of high protein, consumption of calcium, especially paying attention to vitamin D, vitamin B12, especially for vegetarians, consumption of high proteins which are rich in essential amino acids. Empty calories should be avoided, like fast foods like chips, candies, baked goods, soda, alcohol, etc. Picking foods that are low in cholesterol and fat, and most importantly, drinking enough liquids. Coming to the next important factor, that is physical activity, it can be summarized under 4 heads: cardiorespiratory capacity, exercises that promote our cardiac status. These are jogging, brisk walking, swimming, cycling. You can take your pick according to your liking and the facilities that are available to you. And the most important thing about exercise is do something which you enjoy basically. Otherwise you will not keep up very long at that particular activities. If you have a peer group or if you have a partner, the chances are more that you will continue with that exercise. The second type of exercise which is important in old age is strength building exercises, or what we call as muscle building exercises. Of course you may go to a gym, but even in our Indian tradition there are some exercises which also contribute to your muscle strength, like danda, baithak. All these were previously used by our ancestors for muscle building. The third important component, which is also a very important component of physical fitness, is flexibility, because as you go on aging, your flexibility is going to go down drastically. You may remember many of you who were doing yogasanas since young age. Many of the yogasanas we are not able to do it now because our flexibility has gone down. People who were able to do halasana or kukudasana as a child, I used to do these asanas very easily. Now I am not able to do it. Maybe if I had persisted at it on a daily basis at this age also, perhaps I would have been able to do it. So flexibility is very important, which is taken care of by yogasanas or some kind of sports. The fourth aspect of physical fitness is balance and coordination, which is taken care of by playing certain kind of games, which is very important, especially balance for preventing falls and preventing injury in old age. And ultimately the last important point is that exercise should be fun. Now exercise can never be pleasurable. Even Olympic champions also say that exercise is not a pleasurable activity. It is work basically, but you can at least make it tolerable, if not pleasurable, by doing it on a daily basis. Regarding voices, there is universal consensus about the ill effects of smoking. Even if you are a past smoker, the mortality rate is increased. Regarding alcohol, the limit is set at 15 ounces of alcohol per month. If your consumption is exceeding this, then there are definitely going to be health hazards for you. But do not take this slide very seriously, because here are two celebrities, perhaps you know both of them. One is Guru B.K.S. Iyengar and the second person is Khushwant Singh. As you can see here, Guru B.K.S. Iyengar survived only for 96 years and Khushwant Singh survived for 99 years. Khushwant Singh used to consume 3 packs of whiskey on a daily basis till the last day of his life. And as you know, both of them led a very full life. Both of them have contributed a lot to our country. But one of them was a yoga guru and the other was a celebrated journalist. But let me tell you that Khushwant Singh had some method in his voice, because he used to start drinking at 7 p.m. and he used to close down his bar at 8:15. He used to invite a lot of people. He was a very hospitable man, but at 8:15 he would kick all of them out. All his guests had to leave his premises by 8:15, and then he would sit down for dinner. And up to his last day, he was active physically. He used to go for a swim, he used to go for a jog, and basically he was active in his work, professional work also. He was writing books till the age of 99. So there are several other factors. So alcohol is not the only thing. Khushwant Singh basically was leading a healthy lifestyle in spite of regular consumption of alcohol. Comorbidities, of course, control of comorbidities is important if you want to live a healthy long life. And the important comorbidities which will plague you in old age: hypertension, diabetes, and obesity. So proper management of these comorbidities is definitely important. A lot has been spoken about mental health. My colleague Dr. Jejurkar has already told you about this. And there are several studies which record that people who have led a stressful life die earlier. Regarding stress, there is a positive element to stress. Basically, the stress is not just a negative thing, but if it is an excessive stress, then it is harmful to health. Regular stress, like ordinary things going wrong in your daily life, they do not affect your health. Moderately stressful life events also do not affect. But if there is a big stress, like financial disaster, loss of partner, all these things definitely have an impact upon your health. Vaccination is one important thing for the elderly because the immunity is going down, and you should get vaccinated whenever it is required. Here is a study which gives you the results of elderly people who have got themselves vaccinated against flu and people who have not got themselves vaccinated against flu. Some of my colleagues have also mentioned about sleep, and several studies have been carried out. You know the greatest enemy of sleep? The greatest enemy of sleep is Netflix. Yeah. So, if you have a Netflix account, think of closing it out. Short sleepers who slept for less than 6 hours per day, the mortality was greater because it was associated with inflammatory markers. Long sleepers who slept more than 8 hours also suffered similarly because their mortality was also associated with lifestyle and health issues. So you have to find a golden mean. Yeah, injury prevention. This is the last slide. And finally, you have to prevent injuries. Basically, because if you develop a fracture, it is going to take a long time to heal. So the watchword is to be careful. Even if we go for a trek, it's a fairly long trek of 65 days, 65 kilometers in 3 days. Basically, you have to watch your step. And these are the several measures which you can take for preventing injuries: installing handrails, removing clutter, use of non-slip mats, making items easily available so you don't have to climb a ladder. So all these things have to be incorporated in your surroundings so as to make your environment injury free. So that's about aging in a healthy manner. As I started with a scriptural verse, I shall also conclude with a scriptural verse. Basically, you yourself are responsible for healthy aging. Nobody can take the burden off your shoulders. Primarily, you yourself are responsible. And there is a verse in Gita which tells you, Uddaret Atmanatmanam, Natmanam Avasadayet, Atmayava Yatmano Bandhu, Atmayava Ripuratmana. Emancipate yourself by self. Do not degrade yourself by yourself, because you yourself are your own friend and brother, and you yourself are your own enemy. And the animal which is shown here should be your role model for healthy aging, not a rabbit or a leopard, but a tortoise.
Thank you, sir. I request Malpani sir, please kindly felicitate Shivde sir.
दररोज करतो फेलिसिटेट त्याला. सर असे
Rumi sir. So please, can you please wait? Sir.
Yes, sir. Wait. Yes.
So Rumi sir, please, I request you to please felicitate Dr. Mayuri Kelkar for a talk.
Very nice.
Thank you.
अरे
पिशवीमुळे आपण जिवंत गेम टाकतो. मालपणी विसरले असेल पोरी.
हात गई बात गई.
Very bad.
So I thank you everyone. Thank you Abel for today sponsoring today's CME. All can hear to lunch.
11 तारखेला.